everyone. Welcome back to Day 2 of Taipei VALV 2026. We are delighted to have you with us for another day of inspiring talks, live cases, and valuable discussions. To kick off today's program, please join me in welcoming Dr. Andrei Pop to share a few words with us. Let's welcome Dr. Pop. Thank you.
Good morning, everybody. I'm glad that people have made it back after last night. I'm delighted to introduce the first session, TAVR decision making, how should I treat? I am joined as a co-moderator by Dr. Ohno. I'm also honored to have on the panel Dr. Park, Dr. Lee, Dr. Hashinoe, Dr. Wang, Dr. Shi, Dr. Yamamoto, Dr. Zhu, and Dr. Zhu. Dr. Ohno, do you want to take the first session?
Sure. So let's kick off this interesting session dealing with real clinical practice, case-based discussion. So feel free to join this discussion. So we'll start with case 1. We'd like to invite Dr. Tsai for giving us a case with a bicuspid aortic valve.
Okay, good morning, everyone. I'm Tsai Jia-Ru from Zhengxin General Hospital. Today I will present a case of bicuspid aortic valve. And this is a 64-year-old male with dyspnea for several months, and the CT showed a porcelain aorta, and the main problem was the critical aortic stenosis. And here's your CT, and we can see that CT showed a porcelain aorta, so he is not suitable for TAVR. And here's the coronary angiogram when the coronary looks like patent. And the cardio echo showed LVEF was about 64%, and there was moderate AR and severe MR, and the aortic valve area was about 0.6 centimeter square. And here's a CT analysis. So the annular diameter was about 29 millimeter, and the sinus valve measured around 34 millimeter, and the sinus tubular junction was about 32 millimeter. And both coronary height was over 50 millimeter. And the calcium score was about 1,600 with the calcification involving LVOT. And the femoral SS was adequate, and the annular angle was about 41 degrees. So to summarize the case, the LT root anatomy was relatively large, and the coronary height was high. Therefore, it was a low risk for coronary obstruction. So we have a few questions. First, is this truly a bicuspid LT valve or a tricuspid LT valve? Would it change your procedure strategy? Second, in this kind of heavy calcification case, what would be your sizing method? And the last question, would you choose SEV or BEV?
Right, excellent case. So let's start this discussion regarding this case of treatment strategy. So anyone in the panel wants to start? How to size this case or the morphological interpretation, is it really a true bicuspid or not?
So I think this is not much severe porcelain aorta, and the age is 64 and the calcium was involvement LVOT. If this patient is my patient, I first prefer the TAVR, and we will discuss cardiac surgeon. Is LVOT calcium is severe. Is usually that was sometimes not suitable for TAVR. There are some higher risk of root injury. Also porcelain aorta, not much severe to my eye. Yeah. So in the considering the age 64, I prefer the TAVR first.
By the way, you mentioned about severe MR. What is is it primary or secondary? What is the reason for MR?
Secondary MR.
Secondary ventricular or atrial? Or what's it, the LV function is preserved, right?
Combined. Atrial and AMR and combined with VMR.
So patient is in AFib?
Yes. Yeah.
Any other comments? SK?
So I agree with Dr. Park. So because this patient is 64 years old, and maybe we have to consider next valve if we put TAVI valve. So at first, we have to consider surgical option. And also, I want to know shorter diameter of annulus and also intercommission length. So that is important to decide the size.
Do you have additional information regarding the analysis?
Later.
Later on.
Yeah.
So not yet.
Yeah, I agree. I think this is a true bicuspid because the shape of the annulus is quite rounding. So probably I think I would prefer more on the tricuspid. And also I was considering about MR also because I didn't see any functional part of that. So this should be anatomical. So what about when we do the TAVR and how we do with the mitral valve?
Yeah, that's also a very important point. After you treat aortic valve, whether the MR gets better or does not change, it also is important. So let's say this patient was turned down from the surgeon. I don't believe Dr. Lee will turn down.
It's turned down by him because he didn't show the horizontal, the transverse view for this case, and we can go back to the reconstruction CT because of the more. Yes, here is somewhere is can clamp or somewhere it can do in the bypass. But when you see the sagittal view, this transverse view is sometimes is a very faint calcium overlayer. When you cut, sometimes you cannot suture, so you need to replace a segment of aorta. For this kind of patient, we like to talk to patient, and the aorta replacement risk is higher, and the patient think that maybe he received the transcatheter first time, and in future maybe we can solve the problem. So as he decided to receive the transcatheter one, and in Taiwan we can do the patient in porcelain aorta, and in this patient because we must clamp maybe just one part, and its size aorta quite higher, so it got very difficult to do the decalcification, and the calcium is tend to the mitral valve. So that's another problem. We need to replace double valve rather than one valve. So we decide to do one valve only.
So now we have a green light from our cardiac surgeon. So let's say the strategy is to perform TAVI in this case. So in that scenario, what is the next step? What further information do we need? Or do you have any valve choice preference in this case? Andrei, do you want to make a comment?
Yeah, so I'm simple. I just do sapien. So for me, I would predilate this with a 26. I think intercommissural distance would be very helpful, but if a 26 millimeter balloon doesn't move, then 26 valve would be what I would use. With the 26, you can add a lot of volume, and I think at this young age, there's a few things that you have to be concerned about. One is you want your valve to be well expanded, and I think a 26 will be more circular than a 29 would be. B, there's a high risk of annular injury here, so your annular injury risk is going to be a lot lower with the 26. C, the height of the 26 when it's overexpanded is going to be a lot less than the height of a 29, so that allows you to do another valve-in valve down the road. So for me, this would be a 26 millimeter valve, and call it a day.
You're going to select just a balloon expansion. Looking at the LVOT calcium is a huge amount of LVOT calcium that sometimes matter, and when you decide the Xiamen and the envelope valve, and how do you usually, even it doesn't matter?
Yeah, I think if you go undersized, which this case, because the LVOT here was 560, I believe. So 26 is going to be undersized to that. So I think your risk of injury is a lot higher if you put a bigger valve than if you put a smaller valve. The other thing is, and this is, I'm curious to see what the surgeons would say about this, because intuitively to me, I haven't had the pleasure yet of having this complication, but intuitively to me, it's if you predilate with a 26 and you don't rupture, I think the risk of rupture with the valve is really low. On the other hand, if you do rupture with the 26, I think the potential for the surgeons to fix it is better because you don't have a stent keeping the rupture open. So there's better chance that maybe they'll be able to fix it, because in a lot of cases, annular rupture is fatal. Because
Do you perform a simultaneous injection aortogram in 26 millimeter balloon inflation?
yeah, you have to make sure that you fill the root, and so the aortogram is important. But I think to me the most important thing is I don't want to see any movement in the balloon. If the balloon moves, then you know that you're not enough.
Using 26 sapien, one of the concerns is the PVL, so it depends, but
Yeah, I would say that I would rather have a PVL and put a plug in than have an aortic root rupture and deal with surgery.
all right, great discussion. So this session is how should I treat? So we would like to invite next speaker. How would I treat this case by Dr. Chen, please?
Good morning, everybody. I think many experts have answered the question of how to treat in this section, but I will show how should I treat in this section. And I'm Cheng-Chung Cheng from Tri-Service General Hospital in Taipei. So for TAVI case, I was starting with several ways from device selection, valve sizing, and the access route. The most important is avoid the possible complication, and the post-procedure medication is also very important. And the first case, we must make sure what type of the cuspid of this patient. Now, I think this is a bicuspid case because I have seen from the aortic root to the STJ, and we can see this is mostly a type 1 aerotype bicuspid valve. And we can see some calcification of the raphe. So the patient is a young age, and then 64 years old, and obesity, BMI above 33. And I think this is a type 1 bicuspid valve. So I was thinking possibly will from the bicuspid valve intervention. And since a young patient, and from the previous CAG, it shows a arterial plug in the proximal RCA, so the possible future coronary issue will happen. So we might make sure the further core intervention possible. And the most important is young age, the lifetime management of arterial stenosis is very important. It may be needed. I think a second valve is necessary. Maybe up to 90 years old, he need a third valve, maybe. From this chart, we can appreciate that if we choose the balloon size above 25, and the PPM possibility is around 19%, so it's relatively low. So if we choose 25 above balloon, I think PPM is not a problem. So for self-expanding or balloon-expandable valve in a bicuspid case, I think it's a large topic to debating, and I think from this small trial in 2020, published in Circulation, Cardiovascular Intervention, and we can see this trial shows that the balloon-expandable valve have fewer probability compared to the septic valve with significant difference. But it is a small trial, retrospective only. So for bicuspid valve case, if our valve is not well expanded, like this one, just valve in bicuspid valve, and the shape is more elliptical. So what can happen? So this may make the pinwheel effect and make the valve have more stress problem and make early failure is a problem. So for proximal valve is also the same. You can see the A series, the valve is not so well predilated, and the shape is uncircular. So the further problem will happen, maybe early failure or pinwheel effect of the valve. But for the proximal valve in bicuspid valve, you should very pay attention to that, the possibility of any rupture. So oversizing and too aggressive oversizing will make any rupture. This must we keep in mind. So for this case, 24 years old, I think the live management of arterial stenosis, we should keep away. And from this chart, we can appreciate either toe in show or show in toe. I think it's all compatible. But if first valve is the self-sustaining valve, maybe in some case it's a problem. So for my opinion, I like the simple thinking process. So for this case, I will go for the bronchospinal valve and for the further possible intervention of second valve or even third valve. And then if we have to check the supraannulus anatomy for this case. For bicuspid case, is very important. As we know, the taper type of bicuspid valve is very frequent seen in the bicuspid valve case, and the flare and tube also. So when do the sizing, we must depends on the smaller area. For taper, we use the supraannular area, and for flare or tube, we will go the annular sizing. So for device sizing, I think the CT evaluation is the first step, is very important. And we must check the size of annulus, the VOT, and the sinus basava, and the sinus tube junction. And also in the bicuspid case, we check the supraannular plane, including the intercommissural distance, short diameter, and perimeter. Also, calcification volume is very important. The overall amount and the distribution. How is the Raphe is classified, or the VOT classification, just like our case, and the Leaflet classification, all is very important. As we know, there are several ways to sizing the bicuspid valve. I think we cannot say what method is the best and what method is most accurate. Usually we do 2 or 3 methods to check the valve size, and we can make a summary. The first method, this is developed by the bicuspid registry of Hsin Medical Center, and they calculate that the cushion volume, if above 1,000, the oversize should be 0 around. And for the bronchospinal valve, the circular method is a very good method to check the sizing. And we put a circle from annular to supraannular and check which size is more fit the anatomy. The third is West method. Our West method is developed by our Zhenxin hospital team. It's a very good method, and I use it a lot in my daily prayer work. And they use the most classified supraannular plane and check the ICD and the perpendicular short diameter and find the average diameter. So if we use the several methods and we cannot make sure what size you are, so maybe you should go to balloon sizing. The first case, in this case, I use a circular method. I think for a 29 is okay for the annular, but if you see the supraannular plane, seems a little bit large. If you for this classification, is Leaflet classification or a Raphe. If you think it's a Raphe, so maybe it's larger for a 29. The 26 seems more fit to the anatomy, but it seems a little bit small. But we will go more detail. If we use 27 to make a circle, seems better than the 69, and the 28 is a little bit larger. If you use the West method, And we find the most classification plan about the superannulus. We find 2 plans, and the average size is 24 and 25 around. So if we use the ABC sizing protocol, which is published last year in Stroke Heart, and this protocol is specific to the SPIN 3, they use the annulus and the VOT and the commissural and the leaflet classification to check the valve size. For this case, we got a 26 around. The other thing we must pay attention is the VOT classification. It's very important. The extension bar in VOT is large and extending from LVD to the LT root and up to the 15 millimeter. So too aggressive oversizing, too aggressive post-dilatation may make the annular rupture or aortic injury is a possible problem we must pay attention to. So for this case, first I will go balloon sizing. Since I cannot get a very actual size from the several methods I previously used, maybe I will use 24 balloon pre-dilatation and then see is there significant regurgitation flow, yes or not. If there's no, we check the balloon waist. If no waist, maybe I will use 26 minus volume. The waist is very obvious. If we can see the significant waist, I will minus more. If the significant regurgitation flow exists, I will go from the 26, or even the balloon cannot fix in the aortic root and go up and down during the balloon dilatation, I will go 29. For implantation depth, since I think this is a bicuspid valve, I will go high implantation. Maybe the target depth will 9 to 1 or 10 to 0. I think the SS route is okay, transfemoral, no doubt. Most people will go transfemoral. And the complication, I think Dr. Tsai has mentioned, there's a low risk for the permanent pacemaker implantation since membrane is the distance is okay, and the coronary height is okay. Since the basal diameter is larger, so the complication of permanent pacemaker or coronary obstruction is not a problem. The post-operation medication, I think, since there's a atrial fibrillation case, I think NOAC was used, so keep NOAC using is reasonable. So in summary, what I will do, first, transfemoral approach and pre-dilatation, balloon sizing, use a 24 millimeter balloon. Maybe I use 26 balloon expandable valve, minus or plus valve, and even 29. Depends on the sizing result. And the post-dilatation, if necessary, and keep NOAC using. Thank you.
Thank you, Dr. Chen, for your detailed and insightful analysis. For the sake of time, we would like to again invite Dr. Tsai for the what have you done in this case?
Okay, and so this is a case with relative large annulus but heavy calcification. So in our center, we use the waist method. We use the average of the intercommissural distance and the shortest distance between the leading edge of the calcification at the outside LT wall to estimate the THV size. In this case, the waist method was 23.5 millimeter. So based on the waist method, the suggested safe size is around 23.5 millimeters. So I'm not sure to choose 29 or 26 or 23 SAPIEN 3 valve. So finally, I chose a 29 millimeter FS plus valve to down one size and pen to post dilatation to optimize the valve expansion. I think this way is safer way in this case. So this is the intraoperative T. At this level, waist mass was about 20.5 millimeter. So we first performed the BAV and used a 22 millimeter nucleus balloon. And so, okay, so we can see there the waist was at the balloon, and we can see the calcification protruding into the sinus valsava. So I think the massive size is around 22 millimeter. Therefore, I decided to down two size to choose the 26 millimeter evolute valve. So we deployed a 26 evolute FS plus valve. And here's the, after deploy, we noticed there are some paravalvular leakage, and the valve did not expansion well. So we did the post-dilatation with 22 millimeter nucleus balloon, and we can see that the calcification is protruding into the sinus valsava. And after post-dilatation, the paravalvular leakage was reduced, and the valve expansion was much better. And the hemodynamic shows residual pressure gradient was only 2 millimeter mercury. So here's a summary. Waist mass is a safe approach for assessing heavy calcification aortic stenosis. Balloon sizing helps to determine the appropriate valve size. Post-dilatation can improve the THV expansion and reduce the paravalvular leakage.
Thank you for your great case. I think you and your team mitigated the risk of annular injury using this platform safely with good post-dilatation and good hemodynamic improvement. So we still have a little bit of time discussion. We have online discussant, Masa. Are you here with us? Are you awake?
Okay, I'm awake. But last night I drank too much. Sorry. Okay.
Okay. Good morning. Can you give us your comment, feedback?
Sure. Very interesting case, and I think the inpatient undergoing bicuspid valve, most important thing is to define the position of the raphe. In this case, the raphe is located at the R and L. So RL fusion raphe. So in this anatomy, the raphe is anatomically restricted from moving towards to either RCA and LCA. That means the risk of coronary obstruction may be relatively low, and the future risk of the sinus sequestration is minimized, so that it's a relatively positive feedback for if we decide. Of course, if possible, it's a surgery is good, but TAVI is feasible for this case. In terms of this anatomy, I think not only a second TAVR in TAVR, but also the third TAVR in TAVR procedure may be feasible. And also the valve choice, if we choose a self-expander valve, the commission alignment is so important and the operator is perfectly aligned. So that congratulate for this case. Thank you for your very educational case. Thank you.
Yes, as Masa mentioned, I think in the cusp overlap, you want marker on the right-hand side and 2 on the left. So even though this is a type 1 bicuspid, I think the coronary ostium takeoff is almost from the middle of the cusp. So I think you also achieved not only commissure but coronary alignment. Any other final comments? Yeah, DW. Yes.
I have one question. You introduced the way method. It seems like to me, using the mean diameter. So what is the advantages of way method compared to another conventional method using the area derived diameter decision or any sort?
Yeah, it's very important to use the waist method because people don't know that it's really it can post-dilate, increase more diameter. The waist method developed that's maybe 6 or 7 years ago after we ruptured the annulus. And at a later moment, we realized that when you over-dilate the annulus, it will be ruptured the annulus. So that's the waist method try to find the most calcification site and do the measurement. It's quite similar to the Baba method, but BAVR, there's a DDA development method is only checked for 4 millimeter height. But sometimes the calcium extends lower, maybe the 2 millimeter or higher is 8 millimeter. So waist method just give you how to choose a smallest one. And after the valve anchoring, no matter you use the balloon expander or the self-expanding one. And after balloon anchoring, you can use the post-dilation, double tap to the sapien valve, increase 1 cc more or just the same size. You can see here that because we always go on a general anesthesia, so TE is over there, and we found a lot of times the calcium almost protruding to the sinus basaba. So that's why we still use the waist method. And now it's more and more people use the ABC method. ABC method just give you a number, that's 26 valve. But it's a little bit too aggressive. So that's when I just joined a meeting in Southeast area, they say that when you use the ABC, sometimes we will become too aggressive. So that's they try to downsize a little bit with the ABC. And I know that Park and another method you can use that, but it's too complex, so that you need the app to calculate that. So that's why the ABC become popular, because everyone can download the app. If you try to develop an app, you should have a app to let the people know. But the waist method is quite simple. You just have 2 lines, so you don't need an app to calculate that.
And also from this point, I want to ask Dr. Lee if it's because from the Dr. Chen's for about the balloon expandable one, initially when I didn't see the LVOT extension of the calcium, I would choose the balloon expandable. But after that shows that actually the calcium is extending, so I feel more conservative. So, and when comparing these 3 methods, I think the waist method gives us the more smaller size. So do you mean that when we encounter such kind of cases, probably waist method can give us some choices? I mean, the measurements for at least to balance between the expansion and also the parvalve leak.
Yes, you can still use the 26 self-expanding the sapien. And for this one, I will down the 2 millimeter or the 2.5, and after we always call the anchor valve and do the post dilation, make the best outcome. So for this case, if I do the sapien valve, I will implant a little bit higher, and that's a working area is upper, so that's we can flare upper sides more and to gain more area for the sapien. But for this case, is I think no matter you use the self-extending one or balloon expander one, you can do that and achieve just about the same. But in my center, we talk about the patient-process mismatch, so we use the self-expanding. But we can use the balloon expandable because we have actually a number. So that's 22 little leak and little waste. So it got very difficult in Hangzhou solution. So you need to know that to layer any space you can expand more. And for me, that's a 2 size downsize is a little bit too more, but you can down it. That's implant valve higher.
I have a question for Professor Pop. Usually when we do balloon sizing, we usually choose a smaller balloon than the valve that we plan to implant. But from your comment, I noticed that when you plan to implant a 26 valve, then you decide to use a 26 balloon for sizing.
Usually in our hospital is mainly based on the CT scanning measurement, and we are use area-derived diameter, and also is the sizing is just 0%, or such like a very severe calcium is 0% sizing. So, and we don't rely on much balloon-based sizing, even though such a severe calcified region. Sometimes even you put the 20 balloon and there is no AR, and we cannot rely on balloon sizing itself. And we are very meticulously based on the CT measurement.
Yeah, I think we have to move on, Andrei. Okay, so thank you so much for your great case.
So thank you for this case. Next, we're going to invite Dr. Ying-Hwa Chen to talk about redo TAVR in self-expanding valve failure. Welcome, Dr. Chen.
Good morning, everyone. I'm Dr. Ying-Hwa Chen from Taipei Veteran General Hospital. I would like to discuss with you the challenge we are facing increasingly redo TAVI. Our patient is a 78 years old male who underwent TAVI with 29 millimeter cold valve in 2015. Unfortunately, he presents 6 years later with worsening heart failure. Echo shows severe central AR and severe functional MR. His surgical risk is considered intermediate risk. From the literature, the choice of the second valve is crucial. The redo TAVI registry show that if using a self-expanding valve as the second valve, will result in lower mean pressure gradient, 10.3 versus 15 millimeter mercury with balloon expandable valve. Using self-expanding valve as the second valve also associate with a lower incidence of residual mean pressure gradient greater than 20 millimeter mercury. The recent publication, Pandora Registry, provide insight into the hemodynamic performance of various TAVI combination. The death and heart failure incidence is comparable, but it seems that showing combination has the worst outcome, although it doesn't achieve significant difference. In the lower panel, you can see the occurrence LT valve mean pressure gradient greater than 20 millimeter mercury occur in 70% of toe-in-toe combination, but as high as 26% in show-in-show combination. The LT regurgitation and parabolic were comparable between various combinations. The most significant technical hurdle to redo TAVI is to make sure the patency of coronary artery. We have carefully accessed the near-skirt plan and coronary risk plan. The coronary risk zone is defined as the space between near-skirt plan and coronary risk plan. If it is more than valve to aorta distance, more than 4 millimeter is classified as low risk for coronary compromise. 2 to 4 millimeter classified as intermediate. Less than 2 millimeter is high risk for coronary compromise. So I would like to explore the possibility of toe-in-toe approach for redo TAVI to achieve superior hemodynamic performance. I find 2 criteria. The first is index near-skirt below sinotubular junction. And the second, the distance between index THV and sinotubular junction is more than 2 millimeter. For this patient, his near skirt is below sinotubular junction. The near skirt of 29 millimeter COVA is 26 millimeter. Both the sinotubular junction plan for LCC is 29 and RCC is 27.9 millimeter. So both are above the near skirt. And the distance of prior COVA and sinotubular junction for right coronary artery is 4.3 millimeter. So it's safe and no risk for coronary obstruction. And for RCA is 2.4 millimeter, has intermediate risk. So I will do coronary protection for RCA. How to size the redo TAVI? You can see in the index procedure, the annulus derived parameter is 25 millimeter, so we choose 29 millimeter COVA. But there is a big calcium in the between LCC and RCC, result in under expansion of COVA. So this time you can see the parameter, the right diameter is just 21.3%. The COVA didn't optimal expanded. So we use CT simulation with 26 and 29 millimeter Evolut platform. You can see the CT simulation confirm the 26 millimeter Evolut is the proper size for redo TAVI. Okay.
Okay, thank you for this presentation. So everybody is okay with supraannular here?
So I think, you know, TOR is also option, but it's considering the sinus saturation and the nails cut NSP is lower than sinus tubular junction, sinus saturation risk much not higher. But this concern is if you put the TOR coronary re-access, I think nearly impossible. So it's, if this patient is my patient, I would like to prefer the shorting TOR in the subfamiliar.
I think the redeeming feature in this case is that it was a left-right fusion initially, so the evolut is pushed away from the coronaries. So you might be able to re-access afterwards, but I agree with you. It's going to be potentially challenging. It's hard for me to say how I would size it because I don't see all the measurements. I usually measure at every node, and that's how I decide how to size it. But I think, again, in bicuspid left-to-right fusion, that makes life easier because it pushes everything away. The other thing, it wasn't very obvious in the coronary height measurements, but in the rotating images that were shown, the index valve was implanted relatively deep, and that actually works in your favor. So, okay, how would I treat this case, Dr. Ho Chae?
This is a 79-year-old male who had core valve failure. So I think about the surgical treatment may be optional. The redo TAVR is also optional. If you decide redo TAVR, the planning of second TAVR procedure is very strictly. And then what about the severe functional MR? I think this functional MR should be observed to clinical follow-up after successful TAVR or something. So TAVR explant of the self-expandable valve is not that much difficult. It's one of the options. But the valve-in-valve multicenter registry showed redo TAVR with balloon expandable valve is safe and effective. And also TAVR registry showed with the balloon expandable valves has great outcomes. And also this is prospective multi-center registry, and TAVR with the balloon expandable SAPIEN 3 THV platform is safe and effective reintervention strategy across diverse field THV types. So I think in this patient, I think TAVI is reasonable. So we have to think about the NEERS cut and then STJ coronary height and coronary risk plane and THV to STJ. This slide was given to me, and so actually the commissural level is 26, and as you so explained by the Dr. Cheng. Okay. Anyway, so this is the sinotubular junction height, but actually the first valve is core valve, not evolute. So from the spec of the core valve, the inflow diameter 29, and the frame height, inner skirt, and then constrained part is a little bit different, but it's roughly same. But you should know the node 0 to 6 is 24, not 25 in the evolute valve. So in this patient, we use the toe-in-toe, if you use toe-in-toe strategy, the NSP is 24. So the CRP is 21/18. So I think even though all the scenarios, the coronary obstruction is very high. So I don't think a toe-in-toe strategy is good for this patient. But how about the short-in-toe? So if the NSP is different from the depth of the second valve, short valve, so if we choose node 4, the NSP will be 16, and then the CRP is 21 and 18. So NSP located below the CRP, so it's a little bit safe for the in terms of coronary obstruction. But the distance from the THV STJ and the especially in the right side, 2.4, it's a little bit high risk for coronary obstruction. But as you can see here, the right coronary is located in I mean the spatial orientation. Well, I don't have any information about the commissural alignment in the first valve, so the leaflet modification is possible or not. So I don't know, but fortunately, there's some space like here, so we can engage the right guiding catheter and the coronary wire to protect the right coronary ostium, because if we are trying to use balloon expandable valve, the self-expandable stent frame may be expanded further, so it can be one of the risk factors for the right coronary occlusion. What about size of the balloon expandable? This is some kind of example. We have to know cross-sectional areas of all the levels like this. This is very important to select the second valve size. But I was just given this slide. The index procedure, the diameter was 25, so 29 core valve was chosen as reasonable. But right now, with the TAVI, the annulus perimeter derived diameter is 21, and then area is 336 square millimeters. So I think SAPIEN 23 is a good choice in terms of internal diameter and also in terms of the stent frame height, not to make the nail scut plan the higher and higher. So 23 will be the best option. So The selection of second valve, for my opinion, 23 Sapien 3 is reasonable, and the coronary protection avoid RC guiding and the guiding extension and wires. And the predilation will be needed because this patient has regurgitation was major, but 2-digit pressure gradient was exist in the failed valve. So I think I need the predilation, but there's no exact CT measurement for the internal diameter. So I think a 20 or 22 millimeter balloon predilation will be enough. And the location of 23 Sapien valve, node 4 is good for this patient. And then sizing of the balloon expandable valve, if we are using nominal or plus 0.5 cc, it's 24% oversizing compared to the failed valve. But actual diameter of the valve will be 23.6 if we use plus 0.5 cc. So I think this will be reasonable. And then I think the post-dilation is not needed. But if there's a 2-digit pressure gradient, I will use the post-dilation. But I think this will be enough for this patient. Thank you for your attention. Thank you.
Great presentation. Several things. So I think in cases where you have aortic insufficiency as a failure mode, obviously you can implant lower and you allow leaflet overhang, but it seems at least acutely that it doesn't make a difference. In terms of predilation, when they have insufficiency, I don't spend a lot of time predilating because I feel that I can get the valve delivered. I also don't think it makes a big difference how much volume you add because the evolute frame will come back and it will try to bring your Sapien down. I post-dilate 100% of these cases because I think the gradient on the table is very deceiving, and the evolute frame is not circular. So I think you want to make your second valve as circular as possible. The other thing I would caution is when we're looking at this registry data that tells us about self-expanding, and balloon expandable and balloon expandable, there's so much variability. I mean, in this case alone, do you implant at node 6, do you implant at node 5, do you implant at node 3, do you predilate, do you post-dilate? I don't know that the registry data captures any of that complexity, and I think that makes it very, very unreliable. So, any other comments from the panel?
I think I 100% agree, and your comment and Professor Chae's comment, and he proposed the node 4, and somebody think about some much different implantation. So in this very case, the saving coronary risk zone is much better, and still concern about the overhang is we don't know about the long-term impact of overhang on hemodynamics and durability. We require more data, and I 100% agree with Professor Chae's suggestion.
There's a question for Pop in the park. Do you worry about the alignment of the previous cover? Because I think there's a moderate misalignment.
If you're not going to do leaflet modification, I don't think the alignment matters. I think the other thing that I'm very nervous about is this green, yellow, red classification for valve to coronary distance. And, I measure every one of these CAT scans myself, and the difference between 2.4 millimeters and 1.8 millimeters is a pixel. So for me, anything that's less than 4 millimeters is something that I worry about. And a lot of people look at this and they say, oh, it's 2.4 and it's 2.5 and it's going to be okay. But the reality is it's not even, there's no clear agreement on where you measure the coronary, right? Is it the ampulla? Is it right at the ostium? There is going to be a consensus document coming out looking at leaflet modification, and the way that this was derived, they asked a bunch of people who do a lot of leaflet modification, and they asked the questions iteratively, and it turns out that there's no agreement, and it turns out that there's no data. So I think whenever you're in doubt, you're better off protecting for sure.
So having said that, would you protect the left for this case, not only for the protection purpose, but also for as a marker of the left main height?
I think if you're going to protect the right because you're afraid of it, you can use that as a height. And then, but I think that your point is very well taken. I think even in cases where there's absolutely no risk of coronary obstruction, putting a wire down the coronary helps you know where to implant, because during rapid pacing, everything moves and it's impossible to know what node you're at. Okay, well, let's see what Dr. Chen did. Welcome, Dr. Chen.
As I mentioned, I explore the possibility of EVLU in EVLU. As I mentioned, the patient fulfilled 2 criteria eligible for EVLU in EVLU. Then you can see we cross the guidewire with PTL easily. And exchange to a Confida guidewire. And we protect RCA first because it's a borderline risk for coronary obstruction. The guide crossed the straw easily, and we place a guide wire and balloon in the mid portion of RCA. Without predilatation, because the patient had severe AR, then we deploy 26 millimeter EVLU. You can see we have to make sure the inflow of EVLU is in line with previous inflow of COVA. After final release of EVLU Pro, we do an RCA angiogram, and there is no coronary obstruction. And I retrieve all the coronary balloon and guiding. This is the final angio. Okay, The patient has been followed up for more than 4 years. You can see the hemodynamic change. At 21 days, his LV mass decreased significantly, and the benefit sustained for 4 years. There is no parabolic or his functional severe MR also disappear. And we do CT to confirm the strut-to-strut commissure alignment. Here you can see every strut is in line with previous COVA. Two years later, the patient presents with chest pain, and our chief resident do the coronary angel for him. You can see even our chief resident can engage LCA rapidly within 2 minutes, and RCA non-selected within 3 minutes. In conclusion, toe-in-toe reduced TAVI is feasible that provide favorable hemodynamic performance and may enhance long-term valve durability. Optimal outcome require rigorous patient selection, incorporating new skirt height, coronary risk zone, and evaluation of coronary alignment. Careful CT analyze of anatomy and use simulation are crucial to optimize valve sizing, ensuring commissure alignment, and preserve future coronary access. Thank you.
Yeah, great presentation, great case. Few points, I think. One is when you protect the coronary, I think the balloon is great, but if anything happens to that coronary, the balloon is not going to help you because it's a self-expanding frame. So even if you balloon it, it's going to come right back. So I would always protect this with a stent. Thank God these days stents are a lot cheaper, so you can put it in, and if you don't like it, you throw it away. The other thing that was interesting to me is the valve landed a little bit above the inflow, and there was a significant frame gap on the left coronary side. I applaud you for doing CT. We do CT in every single case that we do TAV in TAV because we just need to understand, and nobody really understands exactly how this behaves, so I think it's very important. And then it was interesting to see that the struts aligned, but I don't know if there's any way to predict that. I think the commissures, you can try to align them, but the struts is more a matter of luck. So any other comments from the panel?
Yes, I also have a question about the landing zone, because could I implant higher or just inflow to inflow in this case? Maybe Dr. Cheng can solve the problem because he tried to implant a little higher. His idea is for hemodynamic or just keep everything higher in the plane.
Video, you can see actually it's inflow to inflow. Now, in the initial phase, I deploy the valve very slowly. So when the valve descends, you can see finally the inflow of newly implanted valve is aligned with the prior COVA.
Keep going, next picture. I'll keep going. Yeah, it's very hard to see for sure.
So intention to do that or just about defense?
Next picture.
Flow to inflow. Yes.
It's very hard to see. I can't tell for sure. You may be right. It could be there, but you certainly see a big frame gap there on the left coronary side. See, and
From another view, you can go back to previous view. Before final deployment, the inline is inflow is in line with inflow of the new valve.
okay, any other comments? Well, thank you very much.
Yeah, sure. So thank you so much for joining this very exciting session. We learned a lot from these two cases. First, bicuspid case, how to size the valve, how to choose the platform of the TAVI device. For the second case, with a failed evolute case, we also discussed the valve choice and how to implant the valve in a precise position in the specific device selection. So thank you so much. We'll finish this session.
Okay, the next section is scheduled to start it right now. Notice in next sections.
Welcome to this session. Taipei WAF 2026 is live transmission session. And so it's my pleasure to be moderating this session together with Professor Wang, which is coming in a minute. Also, we're very happy to have an expert panel with Takashi Matsumoto, man, gender, female, Suhohi, Ajushi, Zhang Yuan, Dr. Chen Qiwei, Fei Li, Zhang Haifeng will be joining online. So we'll start off with the lecture first before going to the live case center. So may I introduce Dr. Ajushi. The title for the lecture is Mitral TEER, PASCAL and MitraClip for degenerative MR and degenerative MR and moderate MR. So welcome on stage.
Yeah, thank you very much, Simon, and thank you very much for having me in this exciting session. So my topic is about the mitral TEER for DMR and the moderate MR, but it's not about really competition of devices, but it's all about how we optimize the outcome and how the field is moving forward. So some disclosures. So we all know that the TEER edge-to-edge repair has evolved from just an alternative to a mature repair strategies based on some device iteration of the MitraClip devices, and procedural time has been dramatically reduced and the procedure success has been improved. Currently, based on some registry, almost 90% of patients can achieve residual mitral regurgitation or less after the procedure. And now we have also PASCAL precision system, which offers some unique features, including central spacer, as you can see in the middle of the slide. Central spacer helps you to create a tissue breach and also reduce excess stress on the leaflet. And nitinol construction allows you to have flexible and also gentle grasping of the leaflet. And also one of the most unique features of this system is elongation capability, where you can navigate the system even in a dense cold day, and also reduce the risk of device entanglement. And the CLASP 2D trial is a randomized control trial comparing a MitraClip and the PASCAL device system, demonstrating that non-inferiority of the PASCAL system compared to MitraClip devices in terms of major adverse event, MR reduction rate, and also symptomatic improvement. This is a data randomized control trial, but in the real world setting, there are certain situations where one device would have advantage compared to the others. For example, excessive flare leaflet. In such situation, I would prefer to go the PASCAL system, because in PASCAL system, what you can do is you can elongate, or you can go diamond shape, and using this shape, you can engage the leaflet, and then once you engage the leaflet on the device, you can down the clasp all the way to the device arm, and irrespective of the angulation of the device arm. And also you can align the shape of the device throughout the grasping maneuver, which facilitate effective grasping. And then based on some unique feature of the PASCAL system, this system showed that a really good result even in a patient with anatomically complex degenerative mitral regurgitation, and a similar result has been also reported by MitraClip G4 system. So that these data suggest that both contemporary platform, MitraClip G4 and PASCAL precision system have expanded the anatomical spectrum that can be treated successfully. But what does the procedural success mean? And what is the optimal outcome? So we need to keep in mind that a residual MR moderate is associated with worse clinical outcome or increased risk of recurrent mitral regurgitation in the long run. So, how can we achieve the really optimal result? I mean, how can we achieve the residual MR mild or less after the procedure? The first question starts with the anatomical selection. So this anatomical question or patient selection is getting more important because now we are going towards a lower risk patient or a younger patient of DMR. So these patients generally live longer. So we need to really have a durable MR reduction. So tool score such as like Ocean DMR score may have identified anatomies likely to achieve MR mild or less. And also device selection is really important. This is my personal preference, not evidence-based, but I would prefer to go PASCAL system if patients have commissural MR or leaflet TEER or perforation or fragile leaflet. On the other hand, if patients have small mitral valve area and also have a high risk of mitral stenosis, I would prefer to go MitraClip. Many patients with a DMR with central pathology or billowing propast, I think the both devices works really well. So now we are shifting to the topic of moderate mitral regurgitation. The question is, are we early enough to treat MR? So 3 randomized control trial, we all know there are 3 different results. Co-op trial showed really demonstrated risk reduction in heart failure hospitalization and also mortality, but not in mitral FR trial. And the reshaped heart failure 2 trials showed the symptomatic improvement and also risk reduction in heart failure hospitalization, but not in mortality. And if you look at more detail of the reshaped heart failure 2 trial, this is really interesting. The patient have EROA of 0.25 quarter centimeter. And the physician may think this is just moderate mitral regurgitation at baseline, but the reality is these patients are really well selected, having clinical relevant MR based on not 2D images, but also moving loops based on not single metrics, but actually based on merge metrics. And also, most importantly, these trial patients were really symptomatic, have history of a prior hospitalization, and also reduced KCCQ score and increased BNP level at baseline. And after the procedure, they show symptomatic benefit. And here's a baseball picture. I put this picture on my presentation because I know the baseball is also popular in Taiwan as in Japan. So we are on the bat box. We have a MitraClip or PASCAL, whatever. And historically, we only swung at red zone, so severe mitral regurgitation. But the reshaped heart failure 2 trial suggests that there's also chance in the yellow zone. Some patient in the yellow zone may already be clinically relevant. So this concept is also supported by the sub-analysis of the EXPAND-G4 registry, showing that the LV reverse remodeling and the QOL improvement after mitral TEER in patients with moderate mitral regurgitation at baseline. And a similar result is also confirmed in the Bicuspid study, showing the really durable MR reduction, and also they showed a symptomatic improvement. And here's the data from the Ocean Mitral Registry in Japan, suggesting moderate MR is not always benign. Among around 2,600 patients, 70% of patients had moderate MR at baseline based on trans-thoracic echocardiography. They were considered as having a relevant MR because of severe MR and TOE, and also abnormal PV flow, positive stress, TTE, and also heart failure hospitalization within 1 year, and so on. And actually, they had an increased left atrial pressure at baseline, and after the procedure, the pressure decreased dramatically, and they showed a reduced risk of heart failure hospitalization. But also we need to keep in mind that the optimal goal is not achieving the residual MR mild or less, but also we need to keep transmitral pressure gradient 5 millimeter mercury or less. This is confirmed not only in degenerative mitral regurgitation, but also functional or secondary MO. Of course, we all know that there's no randomized controlled trial in truly moderate MR patients, so we need that. But data suggests there's also chance to tackle with a moderate MR. So this is take-home message. Both MitraClip and PASCAL provide excellent outcome in degenerative MR, and optimal outcome require good anatomy selection, appropriate device selection, and high-quality repair. Moderate MR may represent the next frontier of transcatheter mitral intervention. Thank you very much.
Thank you very much. It's an excellent lecture. So maybe have some discussion among the panel and audience on these two topics. First of all, device selection for MTEER, and also the approach to moderate MR, intervene early or to wait until they turn into severe MR. So can I have a question first? So please take a seat. So if it is a moderate MR, I think it shows that the results are good if you choose moderate MR. Is there a difference between degenerative MR and functional MR? And the other thing, I want to go across the panel. What is the bad side, the downside of treating moderate MR? So these two, maybe we can open for discussion.
Yeah, I think when it comes to moderate MR, especially for functional moderate MR, from the imaging perspective, it's actually one of the most challenging ones, because as you know, functional MRs is dynamic. When is the best time to actually assess? And then even when we assess, there are multiple limitations with one modality. So a lot of time we actually take the patients, both the clinical information as well as the imaging information. So in where I practice in Singapore, we normally just make sure that they are optimized medically and then watch them very carefully. A lot of time when we assess the true severity is when it is in the baseline. So not when they are decompensated. So I think that's just something that from the imaging perspective, it's what we need to take care of. Yeah, maybe I open to the rest for comments.
Following this question, I have a question about the severity of MR, because we know the MR is dynamic, especially functional MR. So how to evaluate the real severity of mitral regurgitation? Should we put our patient all in exercise, then do cardiac echo, or something? I don't know what's the reality you experts do.
So I think I answered that earlier. We actually make sure that they are stable, and then you reassess with the transthoracic. Now, you watch them very carefully, and you make sure that you actually dose the medical therapy optimally, so increase as much as you can. And if the patient is still symptomatic, we exercise them. Because if you have a baseline transthoracic that's mild, but patient is symptomatic, you need to look for why. And that's why exercise is very helpful. And when it comes to exercise, treadmill or not pharmacological.
Okay, so I think this is a very good discussion, and we may carry on it during the case and afterwards, because it appears that the live case center is now ready to broadcast the case on MTEER. So hi, hi, it's from Hsin Hospital. Hello, can you see us? Can you hear us? So ready to go live case. Can they hear us?
Hi.
Hi. I'm Simon here, and
hi,
also
Simon.
Hi.
Welcome.
Hi.
Do you have any jet lag?
No. I did not change the jet lag time. I keep adjusting for Taiwan. Yeah.
Okay. Today initially we prepare MTEER case. However, later we will show you that the patient is functional and mitral regurgitation because of atrial and ventricular dilatation and the dysfunction. However, the patient has concomitant atrial fibrillation and LV dysfunction, and after 2 months of medical treatment, the patient's reason converted to sinus, and the LV function improved. So the MR just regressed to mild degree, so or even trivial degree. So later we will show the case to you. I think it's a very educational case. When should we intervene the functional mitral regurgitation? You may discuss later. But today we switch to another TAVR case. And this case is also full of surprise. We have done PCI for this patient, and I show you the case. Together with me is Dr. Tsai Jia-Ju and also Xu Jinxuan, Liao Jialing, our technician and nurses who are major in structural intervention. And we also have Dr. Liu Junting as echocardiographer. So can we show the case first? Okay. Dr. Tsai?
Okay, next. And this is a 74 years old female with chest tightness and dyspnea for months. And the main problem is the critical is and the SDS score was high, about 30. Next. And the echo showed preserved LV function with LVF about 62% with moderate MR. And the LT valve area was about 0.69 centimeter square. Next. Next.
So that's a moderate MR. So we asked Ajishi whether we want to treat that. And also, if you have any data on treating mild and trivial MR, maybe they can just get the case back and please say yes or no for that. Okay, so just joking. So I think this patient has a severe AS and but moderate MR. So but we don't have the slides. Can we keep the slides going, or is there a transmission problem? So can you hear us, Professor Ying?
Yeah.
Yeah. So
yeah. Well, the computer gets stuck, so they are fixing.
So
just now we had a very good lecture on the moderate ML, and so just asking whether mild ML can be treated, so we can have one extra live case.
Simon, we show our
TAVR
case first, and then the mitral case, then you can discuss the case. Okay.
Okay.
And here is the angiogram. We can see that we have a stenosis at the RCA ostium. Next.
The patient have, previous one. As you can see, the coronary angiography show intermediate stenosis at the LAD middle, proximal to middle, and there is a critical lesion at the middle circumference, which is about 80 to 90, and also another critical lesion at the ostium or right coronary artery. Well, according to the guideline and the algorithm of our center, unless the patient has severe critical stenosis of the left main stem or the proximal segments, we will do it up front. This patient, the severity of stenosis of the LAD is, I would say, it's about 70 or 75. So we will leave it today. Regarding the circumflex middle lesion, although it is tight, but I think we can do it later, after TAVR. The only one we want to tackle is the right coronary ostial lesion. However, today, this morning is full of surprise because I show you the angio and what we did. 你们可以秀这个荧幕吗? As you can see, can you see the angio? Yeah? Okay.
Yes.
Well, we think it should be a simple lesion. Maybe the rest stenting is okay, but actually it's not the case. You see, the non-compliant balloon cannot open it up. It's a non-dilatable lesion, and when we use extension catheter inside the right coronary ostium, the pressure just going down, and the patient develop hypotension and bradycardia. So we switch to rotablation. And initially, the rota cannot cross the lesion either. Next. And we have several attempts. Next. Okay, finally we cross it and polish the lesion and stand it. Next. Yeah, stenting. Okay, this is a 2.520 SMT stent, which has a thinnest strut thickness, 68 micron. So after that, you can see the vessel is patent. So we move to TAVR. Today we will use FX Plus. Why we choose it is because of the large window. So maybe in the future, coronary access will be easier. So please, Dr. Liu, show the echo this morning.
Oh, okay. Hi, doctors in the ceremony. Can you see the picture?
Oh, yeah. Yeah.
Okay. In the parasternal long axis view, the aortic valve leaflets appear markedly thickened and calcified with severe restricted excursion, and consistent with advanced aortic stenosis. However, the two highly mobile masses, each measure approximately 4 millimeter and 2 millimeter, were attached to the non-coronary cusp. Given the mobility of this lesion, careful wire manipulation and valve crossing are recommended to minimize the risk of embolism. And that is all about the patient.
Okay, we have a floating tissue on the leaflet. So today we want to try to avoid too many manipulations in the annulus and the leaflet level.
Yeah, that's an excellent case. May I ask, Cyril, for the mass that is mobile, so an echo point of view, how often do you see that? Is it part of degeneration? Is it calcium or is it vegetation or something?
Yeah.
Yeah, that's an excellent transesophageal view of the echoes of the aortic valve. And this is actually, to me, a degenerative calcified nodule, which happens quite frequently in the calcific degenerations. In the patients who is not infective, this is quite typical. And my question to my interventionalist is, you know, we think about the high-risk features, but this is really high risk in terms of embolic. And I wonder whether anyone will actually do a sentinel or some sort of protection.
Yeah, that was what I was thinking too, that probably if we have a choice, I think the syllable protection device probably might not gonna help, I think.
Professor Ying, do you have a protection for this specifically because of that anatomy, this mobile mass? Do we put in embolic protection for this?
我听不到.
Oh. Yeah, I think, yeah.
没有声音.
Probably for some cases like that, maybe not this, maybe a vegetation like mobile mass, I may direct implant instead of balloon, then put in a valve. But I think it's subject to different scenario, and I think This case may need a BAV first. Professor Yin, are we going to plan for balloon predilatation for this case?
No, we don't want to do that. We just want to deploy the valve straightforward and compress or outward stretching the leaflet and the annulus, so the tissue can be compressed under the valve frame.
Yeah, and try to avoid recapture and things
Try to avoid any resheathing or something like that. I think Dr. Ying-Hwa has this kind of experience. When you resheath too much, sometimes you will catch the debris, and you will just go outside.
So this case under general anesthesia, TE guidance, and so this FX. What is the size of the valve that is going in?
Let's show the case, please.
Do you think entangled with the sentinel?
And stay on the
this patient has a perimeter of 69. So next, and not too much calcification. Next. And the coronary high is acceptable. The calcium volume is 456. Next. If you want to use Sapien 3, we will choose 23. Next. But today we are going to use 26. As you can see, that should be fine and no major issue in this particular case. Next. The vascular axis is borderline, but we think with inline sheaths we can do it smoothly. Next. So our plan today is to do the TAVR from right femoral artery, pacing from the left femoral vein, and pigtail case from left common femoral artery, and using cerebral protection device because of the high risk of embolization of the tissues on the leaflets. And as I shown you, we did the PCI for RCA, although it is unexpectedly heavily calcified ring. Fortunately, we can overcome that with rotor stenting. And now we are proceeding to TAVR procedure. Today, the first operator will be Tsai Jia-Ru. The second operator will be Lin-Hwan Jiu, who are our new proctors of the heart team. We hope to have an implantation depth at 3 millimeters.
First, some comments from us.
I'm sorry, can we see the aortic arch again? Because
as you can see, the hand marker is on the gray curvature side.
Question later. Maybe the
so I think we can achieve.
So this is the cups overlap view, right?
Cups overlap is a center front and a little bit on the still central front.
位置暂停好了。
不要急，慢慢放。
140哦。
没关系，慢慢来，慢慢来。
6，
慢慢来。我觉得还可以。Well, please align the 3 dots. It's, I think, 4 or 5. How do you think?
It looks great. This is Atsushi Sugiura from Japan.
Oh.
Do you check the depth of the device only based on the fluoro, but or do you also assess the echo? Because you are on a general anesthesia, you have a TOE.
Yes. Yes. Dr. Liu, please see the echo to identify the distal frame.
At long axis view, I can see that maybe this side of the TAVR valve is a little bit same level or higher than the annulus, because I think this side is a little bit risky, but this side is safe.
Well, on the NCC side, that would be almost 0. But on the other side, it's 5 to 6. Maybe we can put it 1 millimeter lower. So we retrieve slowly.
Man, you have a comment? Yeah, please.
I would do the same. I think it's a little too high. Yeah.
To
Even though we try to avoid
make sure
it.
the holes will face the ostium at the same level, right? But I think it can go down a little bit. Yeah.
Yep. So the bottom part of the hole or the window for the FX plus is 13 millimeters.
OK， 放。哎，太深了。
To be honest, I'm not so good at measuring how do you say membrane septum based on the TOE. Is that actually possible? No. It's just based on the eyes. Yeah.
That's right. 好。不，你还是要回到刚刚那个 view 了，不是，你要回到 aerial tricuspid view。 因为刚刚你是在那边看的。
It looks safer.
那个 T 出来一下。
走开了，好。
OK. Yes. Well, I think this position is better. How do you think?
What do you think, man?
Yeah, I think I'll be happy with this one. I mean, in this particular case, I don't want to recapture.
Are you
too many times,
happy
right?
with this position? The patient is already 85, as I remember.
But there's some bundle branch block probably affect a little bit on the blood pressure.
Yeah, there's no complete AV block, just widened QRS. The patient is now a bit under hypotension. I would go.
KY 它就会自己出来，对，再拿打 caster 好 ，OK. Then we decide to deploy the valve. Amanda.
So even though just now it's a recapture, but it's very stable recapture without lots of excessive movement. So I think it's a very nice illustration on how to recapture in a proper way and without much manipulation, especially there's a risk of mass embolization.
It is by one by one. Slowly detach pacing? One by one.
Do you do pacing for this part?
Pacing off. Yeah, usually we will do pacing during final releasing. And as you can see, it can stabilize the system very well. Now we check the echo to make sure the valve is fully open. Dr. Liu, please.
Yes, long axis view plus X-plan view. We check the valve. Implantation depth is quite good. And the valve is very function.
And only minimal regurgitation.
I would ask, in terms of the moderate mitral regurgitation, this patient has just moderate mitral regurgitation, but it's quite often to have patient with kind of multivalvular disease, kind of severe aortic stenosis and moderate to severe or severe MR. How do we optimize mitral regurgitation after TAVR procedure? Is that how is that relevant Do you have some comment?
I think the key is that what happens to the mitral regurgitations after a TAVI in a patient with a moderate, at least to start off. I think the real question is you have to look at the etiology of the mitral regurgitations. If the mitral regurgitation is one of a functional, then I think I would expect that after a TAVI, it may improve. However, if a patient is a degenerative in old people, sometimes you have MAC, sometimes you have restrictions because of calcium, that may not actually get better. So it really is the mechanism of the mitral regurgitation.
In this case, you can also reassess it later on. You have fixed one coronary artery, and you fixed the AS. Probably you want to have some functional assessment of LAD and circumflex, and then reassess the MR. So I think you can just wait and see the patients are quite stable.
In our center, if it's obvious degenerative MR, sometimes we do TE as a TEER screening before TAVR, just in case we need to do it afterwards. But nonetheless, we will wait for the clinical, the MR severity change after. But sometimes upfront screening is not going to
So the question back to the case, now we deploy, I think the level is good. So the question would be, do we need to do something in addition, post-dilatation? So Professor Yin, how would you assess this patient? Echo now about degree of leak.
We are just discussing, should we do post-dilatation? And how do you think? I would like to hear your opinion from you.
Okay.
Xiamen, will you do it?
So, okay, so gradient and also leak assessment, right?
Yeah. Mild paralytic.
Yeah, I think.
Dr. Liu, can you show the paralytic?
But I would also interested to see how the hole is facing the coronary, and probably for this kind of case, I would try to use a catheter to engage to RCA to see in the future we need to do some re-engagements with coronary for assessment or PCI, how well we are with this device and how it is aligned with the coronary ostium. But I think the leak is very small, and there's some conduction, likely transient, but this add to values that you may not want post-dilatation. I think it's well expanded on the short axis view. Gradient is something that we have to look at. That is not cannot be done at eyeball, so maybe need some measurement. It seems okay.
It did. Can you show the hemodynamic? The gradient is 4. How do you think? I think we can accept this.
Yeah, I think it's perfect.
And the circularity index is okay too. So, all right. Then we take out the pigtail and do a coronary angiogram to the left side.
A question.
Could I ask the expert panel? The problem with this is not about implanting. I think it's not severely calcified, but the really mobile, what looks like a calcific. So would you think a balloon expandable where there is not much manipulation like this would have been a preferred choice? Maybe in the expert hands like that, maybe they can do no contact quite quickly, but in a center that doesn't do so much, what would you advise? Because there's a lot more manipulation with this valve resheathing, and even in the expert hands, they had to resheath it. But perhaps with the balloon, so there's less manipulation on the calcific mobile, reducing embolic stroke. What are your thoughts?
Probably I can start, but I think if you do every device properly, you can end up with this, because I would say if the balloon expandable is more easy to understand, it's one shot and there's no way coming back, I think would be a good choice. But you do self-expandable, you have to do as this nice illustration to do it like very stable deployment, minimize manipulation. So I think there's no right or wrong, but I see the idea that if it's balloon expandable, then it's more one shot and less of manipulation. So I think that is a good point. But I think that this case maybe some added value for better hemodynamics would be important for this case, and also calcification around the STJ, and also the calcium degree of the leaflets that will add value to the use of self-expandable valve. Yeah. But I take your point. I think it is a good point. So next question, I would like to know whether the calcium is caught other. So this is one question I want to know, and also the coronary access. Are you going to show us the sentinel? Maybe someone can help to prepare to get the filters.
We will do that.
What's the next step now? Are you prepared?
Now we are engaging the left coronary artery.
Okay. So any tips and tricks and after putting in a e-fluid,
Actually,
for example?
for FX Plus, we don't have any tips and tricks because left coronary artery is coronary seeking catheter, just as we did in normal situation.
It's a very nice illustrated going there easily, right?
有扣打就好了。对啊。好，你刚刚那
Any
个就
tips
好
and
了。
tricks? Maybe a wire sometimes to downsize the guiding catheter.
Well, actually, if you choose a smaller size, it is because of the constraint of the valve frame. So usually you can undersize a little bit. For instance, if you usually use JL4, then you switch to JL 3.5, downsize one side. As you can see, the circumflex middle is still have a significant lesion, and the LAO proximal is intermediate stenosis. We will just stop here for this particular case today. If you want to do any PCI on the left circumflex, we can just do it easily, as you can see. Today's commission alignment is really good. Dr. Liu, please show the commission alignment on the echo. Okay, here is the leaflet commission alignment. You can see it's well aligned. Dr. Liu, would you please to explain the echo?
The commercial alignment with the left coronary ostium angle is about 60 degrees.
Where is the LAD? Oh, I'm in Lebanon, here. Okay, can you see that? And the leaflet. Yeah. So commercial alignment is really good. So it is easy to re-access the coronary with FX Plus. So that's why we think that this is a very good new design of the self-expanding system. All right?
Yes, it's a very nice illustration, I think.
We come out. And then we would like to ask Dr. Lin to show you the case we plan to do today, but the MR is much improved. Can you show the slide? Yeah. 是这一位，是这一位。对。Okay, Dr. Lim, please present this case.
Oh, dear expert, this is the case we would like to perform MTEER for this patient 2 months ago. However, after the guided direct medical therapy for 3 months, this patient mitral regurgitation has downgraded to mild. This is the full chamber view. As you can see on the left side, this is the 3 months ago, the image performed at 2026 in March. And now this is the, and the right side is the image for just 2 days before this, this conference. So as you can see, the mitral regurgitation is downgraded to mild. And next, please. Next slide. This is the 2-chamber view through the transthoracic echo. As you can see, the mitral regurgitation has significant downgrade. So in this patient, it demonstrates the GDMT can help and with shrink the size of the left atrium and decrease the degree of the atrial functional mitral regurgitation.
Thank you.
So it's really amazing. So will you consider a AF abrasion as well, just to further optimize it? Because sometimes this patient MR may be dynamic, and yeah, I think so. Yeah.
Well, I would like to ask the opinion of the panelists, because it is interesting that we have already submitted application for MitraClip for this patient, and we have already got the approval from the insurance company. However, in such a circumstance, we still decide not to do it. Maybe
we should not do the AF. Just
the
wait
approval,
a few years later.
Yeah, the approval have a validate date of 2 years. So in 2 years, maybe if the patient's mitral regurgitation get worse, we can do it anytime.
But I think it's also had a longitudinal assessment for this patient, because just pre-op, a lot of pre-optimization things that may not reflect what actually this patient is having during daily life. So maybe a lot more longer-term assessment for this patient and would be good. And I think this patient may need somehow some intervention in the future. Okay. So thank you, Professor Yin. So we need to move to the other center.
Okay.
Yeah, but this is a really great illustration on all the TAVI steps and also best use of this device. And please get a big applause to Professor Yin's team.
Thank you.
Yeah. So so now we are going to Professor Yang Wang Center in Xiamen. So we start off with a video from the center. Hi. Hello. Greetings from Taipei.
我觉得现在这个位置
Can you
挺好
hear
的。
us?
Yeah, very clear.
Yeah, it's a great pleasure to see you. And so can you tell us the case history and what's the plan for today?
帮转到会场。
We have Professor Ying Wang with us, and also myself, Xiamen, and our expert panel. And online we have also Professor Li Fei and also Zhang Haifeng.
So, 王斌可以听到我们吗？
哎，院长可以听到的。
OK， 开始吧。那就这个你
OK
介绍一下。哎，可以。OK。
Okay. Okay. It's good morning, everyone, the moderator and the panelists, and this live demo case from Xiamen Cardiovascular Hospital, Xiamen University, and this is Dr. Wang from the Xiamen Cardiovascular Hospital, and it's my honor to introduce the team of this live demo operation. It's Dr. Lu Fangling from the Shanghai, and this Dr. Yao, and we have the interventional fellow from India, Dr. Andy, and we have the echocardiologist, Dr. Chen Xu, and the angiogenicist, Dr. P. Yan, Yan Pian Pian. And so I like to invite the Dr. Andy to give the case summary of this case. Okay.
Good morning, ladies and gentlemen, fellow colleagues. So today I will give a brief presentation about the patient which we are doing the TTVR today. So this patient is a 80 years old female with a medical history main complaint of recurrent dyspnea and edema over 6 months. This patient have been done examination, and we see that the patient have a massive tricuspid regurgitation, already have a permanent atrial fibrillation with the NIHA class of the heart failure is class 3. This patient also previously already done a permanent pacemaker in 2018 April, and then replaced 8 years after that in March 2026. The laboratory test shows a very high NT-proBNP, and the echocardiography shows a torrential tricuspid regurgitation 4+. We suspect this is a CIED related with the RV size and RA size is also large and a high pulmonary artery systolic pressure with a borderline right ventricular function. The left ventricular still quite good, but the left atrial already also enlarged with a good LV ejection fraction. Previously, this patient already done right heart catheterization, and we have that the MPAP is 27, and the wedge pressure is 15, with the PVR is 2.94 Wood. So this patient already also assessed the surgical risk, and the surgical risk, according to the STS score, is 9.84%. This is the result of the echo. We can appreciate here the TR is quite torrential, actually already 5+ now, with the etiology we suspect is CIED related. Okay. And we can see also the measurement of the annulus and the length of the leaflet or the leaflet here in the screen. Next. This is the result of the CT scan. I hope you can see all the numbers here. We already performed many measurements for this for the preparation of this procedure. Next. This is also the CT scan result. We can already see the CT scan already can determine all the angle that needs to be for performing this procedure. And this is also the CT scan for the access. We know that this procedure needs a quite large bore sheet, so we also have to carefully prepare the access for the procedure. Next, so the CTA, the conclusion is that the peripheral, the jugular, specifically have enough access for this procedure, and there is no severe tortuosity and no calcification and no extreme angle, which is this result actually quite suitable for this procedure. Okay, thank you.
Okay. Okay, thank you, Andy. So can transfer to the floor.
Yeah, so thank you for the case introduction. So maybe just very quickly, just any comments for the case. So I know the plan is for a replacement. So is any role for TEER as a first line in this case, or just overview, because we don't have a lot of image to assess. So what is a general feeling of this case, Takashi?
It's very good case. Actually, right heart function is preserved. Its TAVI is 16.5, and PVR is under 3 Wood, and it's safe to treat a TEER. And when we look at the gap, it's calculated at 6.5 millimeter, I think, but looks like more, I feel. So maybe TEER is a little bit challenging for this case.
Yes, thank you.
I think from the anatomy that you show, I think, and also I saw your device already, I think Lux would be a good choice. For this case, the screening seems appropriate for the case.
I think when it comes to a lead that I see, the lead is really quite, seems to be obstructing the septal leaflet. So imaging-wise, at least what I saw on the echo currently, it's going to be very, very challenging if you are going to attempt an edge-to-edge repair.
Agree. So when this comes to a lead, so usually we have a lot of assessment for the lead. For example, what is the etiology? I don't think it's a bystander. I think it's just pushing towards the septal leaflets. Whether they're perforation, whether it's movable, it's stick together, So for us in our center, I would try to see how mobile the lead is, because you can see the laxity. I think it's okay, but I would try to see, because one technical concern may need to ask Professor Wang and also the team. It comes to lux valve, the anchor mechanism in the septum. Would that lead affect the lead anchoring? Because it seems to be coming in the way on the septum. So probably I need some advice from the team and also Professor Wang.
I think this is a case also a candidate for key clip also, annuloplasty technique. And this is also we can do the TEER. Maybe we can, but it's difficult because of the lead. And another thing is seems a lot of shadow there. It's difficult to, maybe with the eyes we can do a good TEER technique. But I think it's also a good candidate for a valve replacement.
The gap is the lead that push.
Yes.
And then we need some spacer effect or something.
Yes. So I just introduced the Lotus valve. It's our honor to already. Is Dr. Lu Fangling there? Okay,
Yeah.
Dr. Lu there, because he's the inventor of this device. It's a very smart device with without the hour size. So today we select 6, right? Lotus valve?
16.
16, yeah.
60.
It's maybe around 5, less than 10 hour size. After this is pacemaker rate is very low. The anchor of the valve is most important. The pedal against the septum and fix the valve. So I think Wang Bing, 你们可能已经开始做了吧？你能就继续continue to procedure and say
Okay.
Because of the live.
Okay.
Yeah.
Okay. You can see the echo. Okay. We now just insert the lux valve into the RV, and now we make sure the position of the catheter are in the center of the annulus. So we just want the Dr. Chen Xu to show the position of the catheter. You can see the echo. So you can see from the RV inflow outflow review, it's maybe a little bit close to the septum.
Yes. From the outflow is a little bit close to the septum. Yeah.
So we need maybe we need to turn the whole system clockwise a little bit. Okay, say it's better. Yeah, it looks better.
Yes.
Right.
Immediately.
So and okay, so I maybe we can measurement the depths of the valve into the LV cavity. So maybe we can. 那个 Dr. Chen， 你帮我们测一下那个我们那个大鞘进入那个半环以下的这个长度是多少
？Can you show us previous RV angiogram? It's very important to use the X-ray to guide the position.
Remote control. Okay. Sorry. 7? Sorry. Oh, this one. So this is the angio. RV angio.
Yes. From this angio, we can see clearly the tricuspid annulus there.
So this is the coaxial view. You can see we liner the annulus of the tricuspid valve, and you can see a very clear jet.
Is it
routinely
performed?
RV?
Is it angiogram routinely performed in lux
yes,
valve?
It's routinely performed. So X-ray is also very important.
CT scan to determine. You can see the groove here. You can see where the landmarks is. So the 2 leads across the annulus, am I correct? So the 2 pacing leads.
Okay.
And then one is more mobile, one is more straight.
AP?
Yeah. So just for audience, the access is a jugular access, and that's why they come
You want
from
to
the
have
head
AP?
side to the patient.
宝贝，你把它调到 AP 位，正位，正位再照一照，正位再照一个嘛，正位 ，OK，
Can I ask?
好的，
Is the
啊
trajectory important? Maybe
Okay,
Professor Wang.
go.
Yeah. So we can, according to the fluoro and X-ray, you can see now, this is the apex of the right ventricular. It's the apex that should be lower, right? It's almost we put it higher 1 or 2 centimeter. The trajectory is very good now, and you can see the echo.
这个是吧？往相当于往右时面去一点是吧？
Almost in the middle, right? A little bit near to the posterior. So I think this side is the posterior leaflets and the septum. It's almost between the middle.
哦，这个啊，
So previous is
就相当于
too
这
close
个
to
嘛，
the septum.
不联动了嘛。
So it moves there. So its trajectory is good.
Yeah. So because from an imaging perspective, if you just look at the echo, you won't know how is it coming because you look at the explained, which is the RV view.
Yeah.
It looks like it's away from the septum from the top, but actually it's from the bottom, and it doesn't give me the kind of good overview of the trajectory. In fact, I think the fluoroscopy was something that I depend very much, even coming from an imager with an echo, is not something you want to rely completely on.
Usually we do it on the MPL because we're better explain but I think this you can actually look at two together. You will see even you explain you can assess good alignment.
多少？23。
So something like you pull it back would be more anterior, push it down would be more posterior. You can flex more and just according to the X-ray and also echo.
再退一点是吧？你的意思？
Also, my question is, in patient with reduced or
再往下降去一点。
kidney function, you
那我
can
还要联
also
动哈。
skip the angiogram.
哦，这个再往下降去一点啊。OK。哦。
You don't need repeated injection. You need one injection, maybe pre-assessment, and then maybe pre-deployment. But yeah.
Not too much contrast.
我慢慢展开，慢慢推翘了哈，要固定住啊。
We need to go down to the LRV usually.
We can see a mark over there. There's a mark below the tricuspid annulus. That's okay.
X-ray.
We release it.
X-ray. 啊？
So unlike the E4, we don't need a wire in the L.
I don't need wire. The distal no wire.
Sorry.
Because the very distal it's soft. Yeah.
那我们现在now we back forward the shades to.
First, we release the two rapid air, right?
Yeah.
Because the distal, the two dark things are going to up. One.
感觉那个角度在往增加了。
对你推的时候，好像刚才现在变成90度了，角度在增加。
没有，这个位置还好吗？但这个角度有增加，是吧？
Are they doing an unceasing maneuver?
Yeah.
Yeah. Okay.
You can see the two dark lines, like a V shape. So there are two arms that are going to hug below the posterior leaflet and anterior leaflet respectively. So we named it the rabbit ear.
Okay.
But unsheathing, they will come out. You can see that just like the wings of a bird that extend.
感觉很紧啊，很紧啊。
可能有点紧，没事，可以了。You can now it's gradually released. Yeah, you can see the inside the big sheath. There's a dark thing. This is a rabbit air are going to.
We will ask Professor Wang and Xiamen. So for the big device such as this, any particular tips and tricks compared to smaller device when you release the rabbit ear?
The size, the profile is I think this is 34. Yeah, from the jugular vein.
I mean, in terms of big device, anything to be cautious compared to smaller device?
很大的数量。好的。
The talk that's stored inside is different. If a very small device, sometimes you touch a little bit, it just come out. But then for this, you really take time for the things to come out a little bit by bit. So probably this is the difference, but this is a very minor difference, I think.
Yeah, coming out. Should be slowly, because it's now it's open, right? Yes, very slow. Yes, good. Yeah, the two rapid air still in the left,
Is it okay?
Right ventricular. Now it's around 180 degree. Should be below the. Yeah, we can check here. You see? The rapid ear in the posterior leaflets, below the posterior leaflets.
And what if we don't have it? We don't engage the leaflet in this situation. Can we still go dive into the right ventricle to pick up the leaflet?
You release it. It's a rabbit ear from angle and open up back to the below the annulus.
Okay.
So we should see clearly. Use the echo. Say you say it's a leaflet there?
Yeah. We have leaflet on the device, but
we
my
try
question
to
is, what
find
if
another rapid ear over there to say it's also below there.
Okay. Usually we go down a little bit to have margin, so that everything will be pulled up, so that we had a contact with from below. And the angle are predetermined, so that when the rapid ear opens up, they will always look like that. So one is up and one is down, and to save contrast, we have also reference, so we know the atrioventricular groove. So the next task is to assess whether the alignment, co-alignment is good, and the two rapid ears are just right below the leaflets.
我们有看那个超声，有一个在后叶和前叶那个已经靠得比较近了，可以了。那个 septum 那边的应该也还好。
这个是后叶吧？后叶在下面。
对。
这前叶，这是前叶啊。
后叶的对，后叶或者前叶没关系，肯定是在它下面嘛。还有一个 rabbit ear， 应该也在它的下面的。 现在那个程序和素正是在找那个
胃底啊，
在找那个吗？
对，我们在找，然后有一个耳朵肯定是在。
Maybe the shadow we can't see another rapid ear, right?
To be honest, I do think a 3D MPR will help this situation.
Yeah, we can use MPR
to show the entire orientation and also leaflet engagement. Don't you think so?
I also think that for us as an imager, usually, we like to see things in the three-dimensional aspect as well, and that reassure. Sometimes on the explain, we may miss because of the shadow, but on the 3D rendering pictures, it kind of give you the confidence. And I wonder whether do you usually use a transgastric view, sometimes move in and out to it and explain, does have a good septal as well as posterior if you explain the right.
Transgastric is helpful in some situation in which the image is not perfect.
找那个胃底的切面，直接用那个不用3D，你就按胃底的切面看一看。
Two important thing to assess. One is that both the ears are below, and they comes in a good alignment. They're not tilted. So I think this is something is worth to put some time for assessment before the next step.
Wait, Dino, yeah. 威迪，我们可以看到那个 rapid air， 一个在 septum 那边，还有一个在指着好像是 anterior 那边呢。
哦，怎么样
I think it's below the
稍微下去一点点。OK， 太靠上腔了。嗯 ，OK。
And also the other topic, but how the conduction disturbance rate after the lax valve implantation, is that so high, like 15 to 20%, or it's okay because of the anchoring system of septum?
这是后叶，是在
conduction problems after lax valve.
Okay,
some shadow.
那个方林教授，as I remember the pacemaker rate after the valve is around less than 3%. It's very low. Yeah.
Okay.
Yeah, very low. Because it's almost no oversize. Yeah.
It's advantage.
We rely on the pedal to anchor the septum and fix it. No, not yet. We already finished the single arm thrombus rate.
太靠后格了。
Yeah.
So usually we anticoagulate this patient afterwards.
啊，那我
是可以的，是在那个下面的半夜下面的，没问题的。
新手区一点的，那就联动了。联动这样转，扶的，哎，
扶的，
这个。
Well, RV.
对。
A little bit more.
对。嗯。
Is it okay?
Are we using the picture?
可以。
Are we using the pigtail as a landmark, or when should we remove it? The pigtail.
You can remove it in the last stage.
那个
Okay.
Yeah.
So
那个
is
谁啊
it used as
然后你用个 marker 笔啊，在那个
to point to the
在那个
RV
那个
apex?
半环的地方画条线，可以
Usually no.
Just for angiography.
Yeah.
And we can even totally deploy the device and final do a right ventricular and with the wire to pull back. Is this okay?
找个马笔在那里。
Actually, you can see the AVA group. You can use a marker to mark on your on the screen, and then you just follow the landmark.
这肯定是在下面嘛。
table.
后叶肯定是在半夜下面啊。
那个没问题。
但是还有点远呢。
后叶
OK
不远。
有吗
？So everyone confirm.
Yes, I'm sure it's below the posterior leaflets.
你画两条线哈，它收缩器要输上去的啊。好，看到吗 ？Yeah, right. 对 ，OK， 你再动起来啊，等一下，你看，再画错了，来，再往下面画一点。
So just you have
they are not very sure about
下面
the
一点，再下一
echo.
点，
Another in case
再下一点
try to use the X-ray.
再下一点，你看那个
below the
对啊
areolas.
Just you have experience on other system for TVR as well.
看到没有？对。
So in general, do you feel a little bit different in the approach or the?
没问题的位置合适的。王明
OK.
I think also need a lot of assessment. 360 degree for all the anchor, the supporting wires.
已经你看啊，它已经处于这个状态了。这快放它快速的插上。
是
你要有一个助手帮你固定上，然后一个人快放。
Assessment of non-anchor below the leaflet. Yeah, for sure. For that, 3D MTEER is very useful.
然后你快速的
to just go around.
踩这些。
还是往 retract，
顺时针，对，顺时针。
Put an assistant to fix the device and you quickly release it. Yeah.
我来放了哈，那个
Yes. Quick.
Okay.
Good. 好 ，stop. Stop. Play. Replay.
Good.
Was that final deploy?
Yeah,
Deploy the
not
body.
yet. We need another pedal to fix the septum. Not yet. Not finished yet.
Okay.
Oh, you can check the PVL.
So one good sign is you can see the wings of this bird is flying, was moving, which means it's moving together. So there's no need to hug to the very base of the leaflet. Just leave some margin, just touching, and you can deploy it. So this safety margin, although it's very meticulously looking for the contact, but it's actually very safe and with a good margin.
你看那个 color， 把那隔音那个 color 看一下，我那个
超声再看一下，对。
往右边近一点点。
哦。再近一点点。
还近一点啊。
So now is to assess whether there's a leak. Because you put it there, you want to optimize the alignment. You need to rotate and make a good contact of the wall.
Yeah. If you find a little bit jet, a little bit regurg, you can maybe it's come from the septum or posterior, anterior. You can a little bit adjust now.
Adjust. You can adjust.
You can turn this side to fix it. And if it is okay, the final we put that pedal. You can see two rabbit ear move up and down with annulus, right?
不是这个，拔出来，顺时针转，不蓝色的把往外拔，哎，好，顺时针转，不抓着这个，看踩线看，抓蓝的，转蓝的，
转这个啊，
踩线看，顺时针转，顺时针再转。
Yeah, this means fixed very well.
好，
This sign is
往里
very
插，
important.
好了，可以了，往里插下去，
这个哈，
对，蓝色的，哎对。 好，
So for
然后
example,
我
you
觉
see a
得
leak
要
at the
松一
septal,
点
then you
点
just manipulate
弯，
so that it
然后
hugs or
稍微
push
往
towards
上
more
去一
septal.
点点。
If you
踩
can
着
see
吗？
one wing is slightly tilted, you just correct it by the knobs. So the fixing mechanism for lux valve is depending on the two rabbit ears that go below the two leaflets. But the final one is the anchor. Then you can see a plate that is we had an end fast view. So before putting in the anchor, so we're now optimizing the position before we put the final
这个没
anchor
什么
in.
啊。好，哎，正好这个位置，我看时间要片，来，你逆时针转，我这里给你松开啊，逆时针转，对。
Do we still
对
need to have PICTAIL in place?
我们让它贴靠好一点是吧？
对。
啊，你看到我那个贴片哈？
对，往下压。
啊，你就是刚才那个讲的间隔。
刚刚那个位置。
刚才那个位置，我们要把
超声回到。
好，就这个位置啊。逆时针转啊。
One thing is the septum. You try to against it. Yeah. Here.
啊，好，停。哎呀，然后粘多少？这个转一圈。
这个哈，
哎，灰色的，对 ，mark 到 mark。
他是把那个打针的出来是吧
？OK， 够了。好，
好，这个往下推，这个灰色的system there. So below the, is everything there. It's never happened because of the anchor to got a bundle branch. Never. It's relatively low, always in the middle of the septum.
我故意的。
好，这边
打针不太整是吧？我还转一点，那你退出来。
这个好，这个拉出来哈，
往外拔好了。
那个 anchor 已经下了吗？
我们稍微转一点再下。
然后你，对，再回来一点，然后我给你转一点。
Professor, what do you think about the pacing lead, which is sandwiching between the anchor plate and the RV? Would it affect
the lead, right?
The lead, yes.
We should carefully when we deploy it. Maybe after we place it, the lead position, the curve position may be changed, but the fix there. We got only one patient. The patient's lead pacemaker did this 8 months ago. We got 那个脱离了。
这样的。
But all the case with the pacemaker is okay.
What if the anchor is touched with the
这个贴片
pacing
那几个
lead?
眼
It's not, maybe it's not detached, but it just interact with the pacing lead. Will it affect the pacemaker function?
No.
So for us, we had one extra step. We used steerable guiding catheters to pull it out of the way for the, because we still worry about there's a space occupying thing between the plates. But this is theoretical. I don't think this is a big issue, but we try to move away the leads.
septum 已经被顶上了，大家可以看到the septum point to from the right to left a little bit tenting there. That means already against the septum. Yeah. 你看那个方林，你看看已经顶到那个 septum 了，随着心脏收缩舒张，已经有一个 tenting 了。
对，
所以 it's okay. We can put the anchor now.
Yeah, okay.
把这个拿掉。
Okay.
It's a little bit sign when the systolic, diastolic a little bit protrude here.
Yeah.
This means already
small
tenting there, touch there.
Is that possible to see? Is that possible to see the anchor diving into the septum?
No.
On the echo.
This is a pedal just against it.
Yeah.
And then we have an anchor system to protrude from right ventricular to the left.
Okay.
And like the anchor back to hold the system.
可以吗？
We're going to see.
拔到底。
Do you need to perform like pulling maneuver or something to ensure the anchor is really in the septum?
We need to X-ray can see the anchor already out. The metal things out.
没有。
The pectoral is the removed latest.
We can put there and we can also pull back the pigtail.
顺时针转一点点。
Doesn't matter.
这个还好，看。
现在好像 anchor 的有一点点 space 了，刚才 anchor 的好一点。
这样太多了，
太多了啊。
对。好，然后。 哎，再踩着，
再踩着，实时的，
踩着了，
实时的。
你那个毛释放了吗？
释放了。
哦，难怪我说刚才那个 tenting 没了，
哎，这个是实时的，
实时的，实时的。
Slide。你刚才放那个 anchor 扎那一下有没有踩个 Cini？
有的。
等一会儿
有的。
你再回放一下。
好的。
Now retrieve all the system. You can see very fixed very well without any.
猪尾忘拿出来。
有猪尾来。
没关系，猪尾忘拿没关系。
另外，
我们直接没拿出来，
我们先照一脚吧。
照影剂吧。
先照一脚，先照一脚。
打个照影，对。
先照一脚吧，好吧？先照一脚，先照一脚。
Yeah。
回抽一下，一点点就行了。
用那个 pigtail 直接照影了，可以了，
不要那个连着，就先照好了，
这样就行。
OK，
基本上平的。一点点就行了。
待会儿王斌把你那个用的那个毛 anchor 的那个动作，你踩电影了，最好能把它回放一下，因为大家在这边看不到，超声是看不到的，
这个。
哪里？在释放那个动作吗
？X-ray，
在这里。对。
Yeah，
这个找真的，Yeah。
现在怎么样？流量怎么样？啊？
可以，你先来个造影吧。
So maybe we have an angiogram to see, and probably we have to go to the next session after 5 minutes, but take your time.
好，我们还有一点时间，超声能看看那个 final 的结果。
Go。还好啊。
OK。It's good。Echo 看看。Echo 可以看看 3D 的，还有 color， 主要看 color。
要，肯定要的。走啊。把顶出来哈。
对。
Good. OK. Very good. 知道耶。
来，素人看看 color。
看 color 怎么样？
看看 color。那个是一点点的，是3间半的吗？
有一点点。
不是。
啊？
没有。
是吧？A mild
It's not either.
A mild regurg there, maybe caused by the lead or something.
Oh, this is the aorta cutter. Aorta.
It's the aorta cutter, yes. It's not the tricuspid.
Yeah.
Yeah, try to see. Yeah. 来看清楚那个苏主任把超声打到底是
陈主任在这里，
是在哪里？是 aorta 的吧？
对，主瓣的应该是收缩期的，主瓣的收缩期的一个
during the
color。
systolic is aortic color, not the. Yeah. It's good.
这的 angio， 你的 angio， 这个照影看还可以的，
照影是基本没有。
这个照影看还可以的，你看。
对，那个 color 应该是主瓣的影响的。
对。
And also with all the cases, we need to assess airway function, especially you take away all the TEER as part of the assessment. So you have a comment, Sui?
No, I was just wondering, you know, before you fully deploy, you will do a minor adjustment, moving septally. Can I ask, is it just moving septally or laterally, or is that tilt? Can you also orientate or adjust the tilt?
Yeah, we can also orientate to every angle we can.
So I think having the 3D on fast with the MPRs will really be helpful, because sometimes we can't really appreciate, even on the fluoroscopy, you know, whether it's tilting off axis or not.
Okay. So the final step, we can see very clearly the pedal against it, got a small tenting there in the anchor. This means definitely successful without moving there. So the mechanism of this device is we only almost similar with annular size selected, or 5% larger than the size. So that's why the pacemaker rate is very low.
Yeah, this is a really great result, and I think because of time, so probably we let Professor Wang to wrap up the session and say
thank you, Professor Wang Bing and Fang Ling. I would like to change the name. Everyone likes this lattice wire. I would like to back to the Lotus wire, because its inventor is Dr. Lu Fang Ling. It's better the Lotus wire. It's better. So it's a very good device, and think in our hospital we have finished around 30 or 40 more cases without any complication. Only one patient's got a pacemaker, and all as a two unforgettable case is RV function is not very good. The tapes one is 11, another is 12, and with pulmonary pressure is around 50 more. That two cases after Lotus valve, the patients got a hemodynamic down in the CCU. Left 1 month and more with the ECMO support, everything. But finally, patient's result is good discharge. So for that kind of patients with poor airway and relatively high, more than 50 pulmonary artery pressure, I don't think it's good for valve, because it's totally gone with any result. So have something is better than nothing. So, but for that kind of poor airway patients. Yeah.
Okay, so thank you once again. We have great cases with Professor Yin's
congratulations.
Also
thank
Professor
you.
Wang Center. Thank you very much. So please stay for the next session, and we'll come up very soon. Thank you very much.
We are about to start session 3. Could all moderator and panelists please come to the stage? Thank you.
For the next session. The next session is entitled Roundtable Discussion-Leaflet Modification during TAVR, valve and the redo TAVR. So in this session, I will chair with Xiamen, and we also have Cao Dianping, Li Yongzai, Li Wenling, and Xu Chen. As we know, in the future, I think in 5 to 10 years, we will encounter more and more cases of transcatheter or surgical valve failure. In dealing with those patients, on the aortic side, one of the major issues would be the coronary obstruction and sinus sequestration. So we have to treat it upfront with leaflet modification, maybe Basilica or Unicorn or Shortcut. On the mitral side, one of the major issues is LVOT obstruction. To deal with that difficult situation, we might need to do leaflet modifications such as Lapun, Batman, etc. So in this session, we will invite leaders in this field to discuss the details of the procedure and the outcome and the long-term outcome of the procedure. The first talk will be delivered by Dr. Li Yongzai, who is our leading operator in aortic and mitral valve procedures. His topic today is transeptal mitral valve, tip to base, Lapun. Dr. Li, please.
Yes, thank you, Professor Ying, and thank you all you here to share your experience in Taipei valve. And for this Lapun procedure, I think the neo-LVOT and the LVOT obstruction is very important. Most papers suggest that Lapun should be done at an area of 170. You can do a little bit lower, but however, you should pay attention to residual LVOT pressure gradient. And we have done 14 cases with, now we do done more, at least 20. And the outer mitral angle is around 114 with Lapun or without Lapun. And the neo-LVOT for without Lapun is around 260, and with Lapun patient is 126. This is quite small for most of people in there. And you know that this is a review article from Kang. He said that we need to use the fly-in scratch the wire because they do the in vitro test and show when you flush the wire, it can concentrate the electricity, and you can have a fly-in so that the knife becomes sharper. However, we did not do this time. So conventional Lapun procedure is to base. You pull out the wire from the left ventricle, and you should do the fly-in scratch the wire. That's water infusion. But the problem, when you do the fly-in, it got very difficult to insert it into the microcatheter or your catheter, because when the fly-in is stuck in somewhere, so you must push forcefully, so that it got very difficult. And sometimes aqueous water infusion, a lot of people forget that. So you need pay a lot of time and attention to make every procedure very correctly. But from our try, and yesterday we have the in vitro lab, we can show that no fly-in, no crash still have power, and we do not use the natural water flush. And multiple cut with 40 joule electrocautery it's different to Japan's idea. They use at least 50, and sometimes they use the 70 cutting energy. So it's a very strong energy. If the wire touch anything, you will burn out by the electricity. But that's from our in vitro test, the limited modification depends on two things. It's not only the electricity of the tissue, but also the thermal injury to the tissue. So when we use the electrocautery to the skin or the muscle or any other tissue, it's somehow the tissue will evaporate. So you can see when we use the electrocautery in OR, we did not use the cutting energy quite open, because the cutting energy is quite scary for most surgeons. So there's if you do not very skillful for cutting, and that's we will cut everything in the OR. So that's most people use the electrocautery. It stop breathing and cut the tissue most openly, and the energy is just 30 joules, but not the 40, even the 50, 70. So this electrosurgery use the acetate wire is quite strong, and use the high power to cut everything. But we found that if you use acetate without scratch and without bending the wire, the 40 joule electrocautery, and you still cut the tissue, and you can repeat it more open, and it's my idea of the modified Lapun procedure. So there's in this in vitro test for PIC heart, we can see when you pull the wire, acetate wire, it's always at the shortest way from the aortic valve to the transcatheter puncture area. So you can deviate the wire with Agilis or the JR or the multipurpose caster. And you just can modify a little bit, so it's a limitation of Lapun. And then they try to do best to tip, but best to tip need very skillful in puncture the tissue, and very careful and very experienced echocardiographer. But for the tip to base, you just pull the wire, and it got very easy, and can do a lot of things. So when the tissue was cut, you can see a lot of burning area. So before you start this procedure, tip to base procedure, you need to know the neo-LVOT and also aortic valve. Why aortic valve is very important? Because the wire is exposed to cut the aortic valve. It's noted very earlier communication of the Lapun procedure. Some guy cut the aortic valve and need to do the TAVR procedure immediately. So you need to know that the aortic valve quite easily injured by the wire. And the aortic mitral angle is also important, because aortic mitral angle, if the angle is 180 degrees, is sometimes a little bit difficult to do the Lapun procedure. But it's 110 or 30 is okay for the Lapun procedure, and quite easy. And you should have a multi-site CT to check the neo-LVOT and every other thing. And the most important thing, you should have a transesophageal echocardiography, and let your echocardiography have time to check the point and the result before and after the Lapun procedure. So this is a Roundtable, the tool caster, and we just remove the Terumo wire, just insert the acetate. In the original version, the Japan just pull out the acetate wire, but it is very dangerous, so it takes a lot of time. Even as we use the exchange wire, it still saves maybe 30 minutes. If you just pull out the acetate, you must pull gently, because the acetate is quite strong. So when you pull, you must watch the aortic valve, aortic arch, and every other thing. If you pull too quickly, it will injure to the aortic valve or any other place. And then exposure quite a little the area, so there's a very short area, and you pull up the wire, and you can see that if you have a very successful cutting and the regurgitation jet will aim to anterior, so it's got a successful recruitation, and then you can release the wire and check the 3D echo. If you did not success or satisfy the result, and release, rotate the caster, and pull again, you will have another incision. Yesterday we just cut the tissue, so you can do it quickly. Thank you.
Maybe we can have a discussion at the end of the session, because technique, some of them are overlapping. So the second talk will be delivered by Dr. Kapun, Redo TAVR using Basilica. Please.
Thanks for setting that up. So it's my absolute pleasure and honor to share this with all the electrosurgery pundits, passionate operators that we share as part of the APE electrosurgery that Simon Lamb's leading. So I'm just going to show a case of redo TAVI with Basilica, which may not in the future be the solution to redo TAVI, but in this particular case it seemed to have worked. So the patient was an 85-year-old female with recurrent heart failure. She had an Evolut Pro 29mm TAVI in 2019, 7 years ago. I think we are now seeing a lot more cases where we actually don't have access to previous scans. Before this particular case, every redo TAVI I've done, I've managed to get the original CT to understand the native anatomy. But this case, we were not able to, and I think in Australia anyway, after 7 years, some of the data will be deleted, so we don't have access to probably in the future a lot of cases, but no original CT, couldn't ascertain, but it was commented to be bicuspid. Apparently a very good result, mild paravalvular leak and no pacemaker needed at the time, 7 years ago. She's now represented with severe stenosis or heart failure, and the pathology is severe stenosis in the TAVI device with stenotic leaflets, still mild paravalvular leak. She was inoperable, and you can see the comorbidities, and she's still inoperable 7 years on. So to do redo TAVI, obviously in this learned audience, we need to understand the first valve, and there's some subtle differences, but from the R to the Pro, the external skirt, but the cells, the shapes, very similar, still very important to understand the underlying design. The Redo TAVI app is very useful, particularly understanding the valve design, and there are a lot of metrics we need to measure, but you can see on some of the procedural guide how the valve may appear and where to aim for, but there's actually a lot of measurement that they recommend. But I think the main point here is the key for a supraannular self-expanding valve is obviously to avoid coronary obstruction as the first thing, but also a lot that we need to learn and share about where to place the valve and how to measure the sizing or choosing the size of the second device. But you have the neoskirt plane above the coronary risk plane, raising the risk of a coronary obstruction on the left coronary artery. You can see some of the dots. Thankfully, this is commissure aligned to the coronary artery, allowing perhaps more reliable leaflet modification than a misaligned valve. The right coronary seemed less at risk. We were not keen to do double leaflet modification, so we thought, well, take the risk on this one, but focus on the left. But you can see every valve is different insofar as their placement, how it's expanded. That's why so much measurement when we do redo TAVI, and in doing so, choosing the valve size for the short and tall, for example. So I think this has been mentioned a few times in this conference. We are back to 2010 TAVI, where we do general anesthetic TOE or TEE guidance with redo TAVI, minimize movement, optimize imaging. Hopefully this will show again, but to have completely coaxial perpendicularity on fluoroscopy, as well as doubling up on the diamond to make sure that we're on the right plane. I think depending on which artery is at risk, you can aim for a perpendicular left main view. On the right is obviously a lot harder. I think we talked a lot yesterday about sentinel, but if you're going to do leaflet modification, there needs to be a reason not to use a sentinel. Cost may be one thing, but in unsuitable radial maybe the other, but generally sentinel, I think it's reasonable. And with the measurement of the annulus, or so-called neo-annulus of 380, we thought a 23 Edwards in a 29 evolute, plus 2 cc. So we thought leaflet modification will be necessary. We're very comfortable with basilica. We thought about unicorn here as well, but I'll leave that to Simon, who's an absolute expert in this. But we did basilica, planned here basilica with an AL1 catheter. We engaged the left main. You can see the leaflets going quite high, the evolute leaflets going quite high, supra coronary ostium. We had a pigtail here on the right, and then an estatal wire going through. We did a balloon-assisted basilica, and we'll come back to that, why it's important. A 5 millimeter balloon only. Some are now doing 8 or 10 millimeter, almost a hybrid approach. And then on the right side, there's a conventional pull to lacerate. So I do want to let this play in real time. This has been mentioned a few times yesterday. The importance of very, very slow implant inflation. And when I proctor, I would say you might as well do CPR afterwards and having an embolized valve. So slow pace, and respiration hold as well to minimize movement, because there's now a recognition of how short and tall can be tricky, as was mentioned yesterday. But very slow. I was the inflator there. In the end, I lost patients, but did blow up a bit faster at the end, but we were sure that it's not going to embolize much or at all. So does basilica or even BA basilica work in redo TAVI? And I hope I can emphasize this particular point. All the original work, bioprosthetic and native, as was in the acronym of basilica, was a valve that they lacerated with only post in the bioprosthetic space or native. In any redo TAVI, you have a whole frame there. Okay, you have a whole frame of the leaflets being trapped. However you cut, the leaflets will be trapped by the frame. So if you look at some of the diagrams here on the left, you can see a traditional basilica, all you get will be a slit. Maybe with BA, the theory was that you can use a balloon to open it up a little bit more. The reason being the leaflets are longer than surgical valves, almost always. But on top of that, you have this frame that will trap the leaflets. It's not going to splay extra large. And this is concerning, and in fact, in a few days, there's going to be a whole issue dedicated to this topic, redo TAVI, leaflet modification, and JAK intervention, where we will learn from Xiamen and his group and Canada how redo TAVI leaflet modification may work, may not work. But this is sort of sobering. This is essentially my case. With BA basilica, you have coronary perfusion, potentially, but you may not have coronary access again. You have a slit to maintain coronary perfusion, but re-access will be challenging, one would suspect. And this is probably more fraught with danger than other leaflet modification in native or bioprosthetic valves or surgical valves, because your margin for error is a lot less. But this was supposed to, well, I suppose in our case it was successful, but this will be a major concern going forward. And this is why I do want to piggyback on Simon's talk. Maybe other means of leaflet modification will work better. So this is a paper that will be coming out, or it's come out actually, split line from Gilbert about where to cut, how to cut, where is it possible to cut. If you cut not in all these TAVI devices, multiple diagrams in this publication, where is it going to be feasible? The traditional paradigm is obviously at the bottom so that your split is as big as possible. If you cut up here, obviously the split will be not as much. It's good to see that most of the valves are now, there's an attempt of a commissure alignment, because if it's non-commissure aligned or there's a commissure tap, there's no way to, at least with the current technology, to modify the risk for coronary obstruction. So in short and tall, where you are supposed to use, in Unicorn, where you're supposed to use a balloon expandable, maybe this Unicorn is better than balloon-assisted basilica. We got away with it, but it doesn't seem to be as effective on bench testing. So in these cases, maybe Unicorn is the way to go, and I'm sure Simon will mention that. But in commissure misaligned THV, how are we going to fix it? Lots to discuss. We don't know how to do it. Is split really the way to go with all the shortcut and telltale, and do we need to have leaflet removal? That will be the ultimate goal, almost definitely, although the concern, of course, will be hemodynamic compromise if you have a lot of regurgitation. So I'm just going to shout out to, in the audience on the panel, there's actually a lot of collaborators who have contributed to this APE electrosurgery. Publications are coming, and I would invite you all to shout out to us, and we can incorporate you to our registry to have more data in our regions so that we can continue to punch above our weight. So thank you very much for all the contributors as well. Thanks.
Okay, we proceed to next talk by Samuel Lim. What we involve TAVR with Unicorn.
Thank you. So this is a short talk on Unicorn. As we always mention, we need a toolbox, and in this toolbox, there are different techniques. So we have to pick the techniques for individual patients. So I would say Basilica is well established, and we should learn all the techniques and tips and tricks. And most of the cases actually works well, and would be my default. But you should also think in some scenario, for example, very misaligned transcatheter heart valve, very narrowed VTC, or some scenarios you may want to have better clearance. Unicorn is something that you can consider and take it out from a toolbox. Leaflet modification, I think mainly would be modification by electrosurgery, or sometimes a mechanical way to do it, or combination, and in the future probably more aggressive leaflet excision. So Unicorn, to develop this technique, so the first thing is the basis is a balloon expandable valve. It's opened up through an intra-leaflet fenestration. There are modifications, for example, using self-expandable valve with side-by-side balloon recrossing technique, or there are also variants that we can apply in scenarios where with the bilateral leaflets that have the risk of coronary obstruction, then we can have combination of techniques in those scenarios. So the setup is relatively simple. If you adhere to the conventional basilica, Unicorn, the idea is to use the E-sheath right at the beginning. And that E-sheath will do everything. So first of all, that E-sheath goes with the traversal microcatheter and the wire. And secondly, that sheath go with the balloon, which is a coronary balloon. And third step is to go with a peripheral balloon, and then S3 through the safari wire. So all will be on this axis. So the radial axis is for sentinel embolic protection. On the other side, you can have a pigtail. Our routine is to put a guiding catheter with wire protection. So because most of the time, if you do valve-in-valve or TAV-in-TAV, you have a lot of landmarks. So we disengage guiding catheter with a powerful contrast is usually good, and we do IFS for every case with an access that's maintained throughout the procedure. We have no hesitancy to do why not do an IFS, why do it? We just put it in a routine protocol. To cross the valve, you can use Estato plus the microcatheter system, and VersaCross J-tube is something also be useful. So this is the puncture point, which is universally correct for no matter it's basilica and unicorn. So what we mean by electrosurgery, you need fire, you need sound. So this is what we do in bench tests. So puncturing at the basal center area, this is an example using the VersaCross, is what we want to achieve. If you use a starter wire, it's the same concept. You have this put in the very basal position so that the subsequent steps are controllable. So imagine if this step is not correct, if you puncture randomly at the tip or at the side, the balloon may just rupture the leaflets very earlier on from the edge of the valve instead of open from the middle. If you make a basilica, you put it at the very tip. You just split the tip. It doesn't mean it helps with coronary protection. So this is concept which is universally true for basilica and unicorn. Imagine this is self-expanding valve. This is degenerated. And this is the crucial step for unicorn. For example, you can see this S3 is intra-leaflets. So this is there's a bridge here. So which means we don't upfront lacerate the leaflets before putting in the valve. So that's the reason why meticulous selection of balloon is important. It's not randomly choose a big balloon to tear it and put a valve. It's not that simple. And unicorn should not be considered as a simple, strict, user-friendly version of basilica, because to maintain intra-leaflet deployment, there are tips and tricks, and you need to really go for that and aim for that to get the more predictable results. So this is the bench testing. So first of all, you need the valve to go through this hole already prepared by inflation of the peripheral balloon. It open up. And suddenly you had a giveaway. This giveaway will be a little tactile feedback. The valve is already go to the other side, which means the leaflet opening and entrapment of leaflet at the intra-annular level occur at the same time. So this is the concept. So summary of the list, the different variations, but essentially you need a wire that go through the leaflet. You need guiding catheters, microcatheters, coronary balloon, and peripheral balloon, and the valve. These were all published in our APE collaboration paper for electrosurgery. You can download it, and also you can modify it according to what you have in your cath lab. Just show an example. So this is an example where we may consider unicorn. For example, this patient has a trifecta valve that input in 6 years ago. The leaflet are mounted outside, and so the coronary height is very low. It's on the right side. So these are all factors that you may think about using something other than basilica to have better clearance. And also, if you imagine if the VTC is around 0, if you open the leaflet, there's no space for the leaflet to split. So that's the reason why that would be a consideration for unicorn in this case. And you can see with basilica, you need a workup angle from the CT to isolate the right. And you can see it's so extreme, you cannot achieve with your fluoroscopic angle. So TEE is always our tool for every our cases, except a few cases with 3D eyes, but TE and meticulous imaging is also very important. So you can see the coronary height is very low. It's a very dominant right coronary artery. So this is a reason why we need to do leaflet clearance. So we call S0 is the 0 step, which is similar with basilica and unicorn, in which you need a guiding catheter that had a well support at that position. You don't want when the wire go out, it just leap away and go elsewhere. So you need usually an AL2, AL3, plus a guiding, for example, a catheter that helps you direct towards the basal area and then goes to LVOT. So we learned from Professor Ying's and Professor Cheng-Chung Cheng's team to use the cut pigtail in some of our cases. Or if you VersaCross, you can use a NaviCross to do that. So this is a J-tube VersaCross wire as an example. When the wire goes through, it already turns into a J-tube. And then it just very safely, you can land it into LV without trauma. So this is the same wire that we use for transeptal puncture for our MitraClip or TMVR case. But the configuration for this version is a J-tube instead of a pigtail tube. So this is the way to go. Some people ask, well, can we use the pigtail tube? It doesn't work that well because you can imagine the tube has a degree of is firm. When you put in the catheter, it will distort the catheter a little bit, so that angulation, everything may change. So J-tube is recommend. So thank you for this illustration by Chiu, Alston. And this is the balloon, coronary balloon that is S1, which means we use a balloon which typically is 3O. So this balloon, the purpose is to get the peripheral balloon pass through. You can see we are very conservative. For every case, we do coronary protection, and you can see we do a wiring and an RCA. And just in case, pre-assessment, we do IFIS, and afterwards, we can always keep this entry open. So the first step is to coronary balloon through a 0.014 wire. S2 is the step 2, which means peripheral balloon. And this is also a very important image. First of all, this is already a sulfuric wire, so which means anything after this would be a valve implant. So you had all the valve prepared, everyone is warmed up, the pacemaker is in place, everything is there. And then you had the balloon inflation, and this is a good sign because the balloon is leaning on one side, which means it's giving intraleaflets. If you choose incorrect balloon, or sometimes maybe the valve is so fragile because the mode of degeneration may be a tear, torn, infection, it will just pop up. So this is a sign which we want to achieve, which is an intraleaflet palliation. The purpose is to create a hole here so that you want to maintain the intraleaflet. And that's the reason why the puncture point is so important. The first step is S3. So step 3 is S3. So there is a deployment of the sapien valve. So you can see when it expands, then initially you had some resistance that goes away. So this is a deployment. So how you land the valve and how to put the valve in it, note whatever. So this is actually the main dish. So don't forget, you will do the unicorn or basilica, everything got excited and get tired after that. But don't forget, it's still ultimately patient's outcome will depend on how you put your valve, how is the valve in mouth done properly. And then you can do assessment, and then whether you want to post-dilate it. Usually any post-dilatation we want would be based on IFIS assessment, and you would test the coronary patency, and you would try to see if it engage the coronary. And sometimes from eyeballing, you cannot see anything. I would do IFIS. Sometimes you may have some surprise. So that's the reason why a meticulous assessment is still very important. And I would say for this kind of case, it's so challenging. So there's no reason you just be relaxed with, there shouldn't be any coronary obstruction occurring because of this technique. So get prepared, get ready, the stents. For example, get the guiding catheter in place. You ask one of the colleagues. One is, for example, during the procedure, with one team for leaflet modification, one person or 1.5 person ready for deployment. And third would be get ready for coronary protection stenting, because you need a coordinated work. So this is one example that we done in EuroPCR a few weeks ago, a bench live demo, so that you can see what we mean by new skirt. It's on the left side. So this is a patient who put a sapien valve in, and the old valve, the skirt actually goes up, and it's very solid. And we rotate it on the side in which leaflet modification, and in this example, unicorn was performed. You can see a better coherence. So theoretically, if you had an opening of coronary artery that is not exactly in the middle, or in the case of, for example, short interval, in which the split of the leaflets is limited by the frame at the waist of the T3, this may be of additional benefit. Important facts, for example, you need to know about the baseline commercial alignment. If it is extremely misaligned, don't give false hope to yourself. It's never work. Don't stretch the limit. If it's not well aligned, so no matter what you do, it doesn't work. And so you have to think about, for example, surgical strategies. You need to precise on the location for leaflet traversal. This is the crucial step because that dictates what happens afterwards. Crossing, versicross, or using Estato, both are very good techniques and good way to do it. Two-step balloon inflation. One is a coronary balloon 3O, and then a peripheral balloon deployment. Prepare the valve deployment. via the same y-axis. Current protection is, I always say, I would be very cautious. I would still do current protection in all of cases. So for example, first you should get it prepared. And because if you need a stent, for example, you should already plan ahead what kind of stent you want to put in, the length and the size, where you land. So this has already been rehearsed before the procedure. Then we can, in the future, we can talk about the crossover technique for self-expandable valve. Just a very a brief, like the catheters that we use Navicross, you can see this tube is a curve, which brings you back when you engage to the coronary sinus, it brings you back. Rather than going out when the wire is traversed, it helps you to go back to the left LVOT. So the pectoral, you can cut according to whatever way. And one of the good techniques I learned from Kyle is the anchor unicorn technique, for example. There are many ways. For example, this step have to be very correct. So that's the reason why you don't want to end up in a complication before you help the patient by decreasing the risk of coronary obstruction. So this setup is AL1 or AL2 with a modified pectoral and then fine cross and a startle. But if you do additional catheter inside your guiding catheter, you need a longer version of the versicross, of the fine cross, or use high track. You need a 150. So be familiar with yourself, the length of the catheters that you use or prepare for individual procedure. So this is a mention. We had some collaboration among different centers so that we can conclude what is the best way and share experience. So this is a typical question, how you choose between basilica and unicorn. First of all, native basilica, native unicorn has been, unicorn has been reported. I think there have been good publications on native, but in our center, so 100% would be basilica for our native valve. If it's isolated left side leaflet modification with very good commercial alignment, I think basilica is my first choice, and then unicorn in case the VTC is approach 0. There's no space for the open up. You need a space there. You don't need just a slit. If it's right side, maybe technically more user-friendly for basilica. I may have a tendency to go for unicorn first, but basilica works well. If it is misaligned, we say this picture, for example, if the coronary open in this way, so you cut it, you have done. If you want a better splay, you can do balloon assist basilica, but it is at the side way, you may need to have a wider split, then we may consider unicorn. Bilateral at risk, can double basilica, basilica's for unicorn, unicorn plus knuckle standing, so they're different combination, but we always stress coronary protection. Bilateral modification, okay, so it stopped. Okay, so maybe if interest, you can track about the recrossing technique that is not just for self-expandable valve. It's also been mentioned in an upcoming article of troubleshooting for unicorn. In case you cannot cross the balloon, you cannot, then you can have an additional route that you can help you. But it's very helpful with recrossing technique with side-by-side deployment. So there's upcoming in the Czech intervention, the collaborative work of APE, including the state-of-the-art paper for unicorn. We've collaborated with Professor Yin, Professor Lee, Dr. Mann, and Andrew, and also lots of colleagues in CARS, certainly. So the best practice troubleshooting. With band modification, you're going to have a sizing chart for what balloon, for what scenario, and what size of catheters goes through. With AP collaboration of basilica unicorn registries, and also there are multiple registry from US and Europe, and also Andrew have some alternative access for unicorn for ourselves. So just the APE is something that we collaborate. It's not led by me, it's actually where I'm just co-founder with Professor Ian and Carl, Eric, and also Ken and everyone here. So just an annual meeting and together with Hong Kong Valve, if you're interested, please come to support in October. Thank you very much.
Thank you. Let's move to the last talk of this session. Why unicorn fail? This is an important issue which will be covered by Dr. Li Qingwei from Taipei Veteran General Hospital.
Dear Mr. Chairman, ladies and gentlemen, so it is my great pleasure to be here. So today my talk will be why unicorn fail. So our case is an 86-year-old gentleman presented with a profound heart failure symptom, and he had medical history of surgical aortic valve replacement with the trifecta 21 millimeter, And he also had the stenotic degeneration of this bioprosthesis with mean pressure gradient up to 40 and AVA like 0.6. The patient had preserved ejection fraction and had medical history of CAD. So there are two tricky points. First is this is the extremely small bioprosthesis with the true ID like 19, and we measure the CT, it's about 18. Another tricky one is the coronary height. Even though there's a generous space over the right side, but as you can appreciate, the left side relative have lower left coronary and narrow space of the VTC as well as the VTA. So the first question is, what is the true ID? As we always, when encounter a valve in valve, we will check the app, and you can see for this particular prosthesis, you will see the true ID is like 19. But if you notice that there's a small information button, if you click on it, you will find out the true ID provided by the app is by assumption. That's because if this valve is porcine valve, then it's directly -2. So it's like 70. So it's not from the bench, it's from the assumption. So there's even though it's very, very close, but there's still some difference. So we can learn from the European Euro intervention published data. This is the measure each bioprosthesis from the lab and use the caliber. And they found that's very interesting. If you look at the trifecta 21, like from the left ventricular side and outer side is a little bit different. And some will have a larger discrepancy. So for this particular case, even though the label from the app is like 19, but we have to understand that the true ID probably they only have the 17. And also the trifecta is external mounted, so the coronary risk is relatively high, as you can see from the VTA and the VTC. So for this particular case, I think we definitely need to do something to prevent coronary obstruction. So there are three default settings. So for our institution, usually we don't use the upfront chimney stand for the intentional strategy, but it is still an important way to salvage if we have coronary issue. For the basilica procedure is our default setting in native anatomy, and also in some case of sinus extraction for valve-in-valve procedure. For unicorn, we use it as a default setting for valve-in-valve situation, which has already been illustrated very clearly by the previous two experienced operator. So I think the slide is quite useful for me. I think this is provided by the Jafar Khan from last year Euro London valve. And at that time, how to choose basilica or unicorn? At that time, the unicorn data is not so evident, so his comment is really little evidence. And also, as like Simon mentioned before, it's electrosurgery in the beginning, and finally tear the leaflet from the mechanical splaying. So it still carries some embolic risk. However, when to choose the unicorn? If the splay from the basilica might be insufficient, which will be a quite important issue. And if it is under-expanded SAPIEN 3, or not only SAPIEN 3, but also for all the THV, there could be a relatively redundant leaflet which may limit the splay by the basilica. And also if the coronary height is quite low and meets the line, which may also reduce the efficacy of the basilica procedure. So back to our case, the leaflet transversal is tricky, but without significant difficulty. We use the standard setting, and with this, I think it's proper puncture point, and we do the sequential dilatation with 4 to 12 millimeter balloon catheter. However, because I lost the fluoroscopy, so I use the AI to generate what the situation we encounter, that THV cannot be passed. And luckily, I heard that Simon said that they will address this issue in the upcoming publication, so that would be quite useful. At that time, I think we just flex the commander system and adjust the wire, but it doesn't work, so we retrieve all the system. We do the reballooning, but still cannot work. There are still some technique, such as distal small balloon inflation, or just like last year, the DDA performed very elegant procedure with unlock and push the balloon catheter only, but we didn't try these two methods at that time. At that time, we just think, can we just simply tear the leaflet up front? So to address first issue, why it is very difficult to cross the trifecta. And I research, and I do some search and found this very interesting paper. It's from the bench test. Not all bioprosthesis are the same. Even when similar calcification treatment, you can nicely appreciate the bovine valve exert higher calcium content, not only from growth, but also from a micro CT. As you can see, the calcium is much thicker and nodular. And among all the bovine prosthesis, trifecta exert highest calcium volume. So the second issue, can we just tear the leaflet up front? So this is the paper published in JACC intervention and also from the CCI to facilitate, to advocate one concept that we can just tear the leaflet up front. So at that time, I think it's reasonable since we cannot do anything. So we just tear the leaflet with a 20-millimeter balloon catheter. And at that time, our imager told us there's something is flying. And honestly speaking, I think, it's just flying, nothing big deal. We just put the valve. We can finally put the valve. So we do the 20-millimeter THA deployment with double tap, and the immediate outcome is good. But the patient's blood pressure become lower and lower. And you can see the leaflet is moving toward to the left main. So at that moment, we just put the ECMO and we try to PCI, but it is very difficult to penetrate the obstructive leaflet with multiple attempts. As you can see from the fluoroscopy, as well as the TOE, as you can see the obstructive leaflet over here. So we decided to go to the surgical rescue. So I think the surgeon did a very clever decision that he just excised the leaflet only without taking out the THV, which markedly shortened the bypass time. As you can see here, this is the obstructive leaflet and the clearance, and this is the excised leaflet. And after the surgeon closed the wound, we do the immediate post-sever angiogram. It's like a surgical shortcut. And you can see we can nicely engage the left main coronary artery. And luckily, we have the patient back and discharged home and recover well. This is the 4-month TT, transthoracic echo. So there's a paper which published by the Ole de Becker group. It very nicely show the importance of a unicorn. The concept is intra-leaflet deployment. This is the failed Acura Neo 2, and then they tear the leaflet and then put the valve, and everything's fine. But when they do the CT and found the flowing leaflet over here. So it's very dangerous. And they do the bench test and showing that if you tear the leaflet up front, the leaflet will go anywhere or will go to the coronary. But if you stay within the intra-leaflet deployment, then the clearance of coronary artery, Hsin, will be preserved. So my final take-home message is that I think the importance of intra-leaflet deployment is the essential concept for the unicorn procedure. So unicorn didn't fail, it's I feel, my fault. So, and the bailout surgical solution, I think is excised leaflet only if feasible. And I think trifecta is different. So our case will be published in the upcoming JACC cardiovascular intervention. So thanks for your attention.
Thanks for the 4 excellent talks delivered by distinguished speakers. So we may have 10 minutes to discuss this important issue. When will go start?
Thanks, Professor Yin. So I have some questions, obviously. So at the onset, I need your special technique of Lampern. You mentioned maybe cutting a few times. I mean, I've seen a few people doing multiple cuts now. Do you do multiple cuts? And do you find your technique without electricity a lot more tactile? Because sometimes when we do tip to base, you pull, you pull, you pull, you don't feel the heart stop. But because you don't have to do the V, do you pull harder or less? How have you, in your experience, how do you tell that you've cut well?
It's we just pull, and the TE say the position is good, and we do the cut, and then we release that. You can see the regurgitation, but you don't need to pull too much because when wire touch the leaflet, you cut, you will burn some surface. If the regurgitation is not good enough, you pull again. But it should be rotated the case a little bit, so it will cut in other direction. And when you use the drop-pass technique, you should pull at the same time in one hand. So the should not be used 2% maneuver because you use the one hand to pull, and it will cut the leaflet at the same. The wire won't, and the case won't move. If you use the two main person, so the wire will slip in at a moment. So there's for the cut effectivity is more is for the pull technique. But when we pull and the cut is more smoothly. So that's we'd like to do that.
Do you cut multiple times? I know some people are starting to cut multiple times.
Yes,
for
we maybe there's a 2 times or 3 times is okay. The hemodynamic won't treat too much.
Sometimes it depends on where you want to cut. So if the alignment is good, you just put it up and you will find the wire impinge on the leaflet. Then you just electrify and you will cut successfully. But sometimes it's misaligned. So you have to cut the leaflet from both sides of the post. In that way, you sometimes need to oblique cut or transverse cut to some extent. So in that case, you may need multiple cuts.
And with this technique, you have applied to mitral valve in valve and mitral valve in ring, I take it, like a native leaflet?
Yeah. For mitral valve in ring, we do it in 100%. But even so, we still have 2 failed cases. That means residual gradient after the deployment of the valve. It is because of the long anterior mitral leaflet. We developed a formula. If you use the anterior mitral leaflet minus the protruding part length of the device inside the LV and the length of the frame to septum, if there is still more than 5 millimeter length left, it still carry a high risk because it will be sucked into the LVOT even after valve deployment.
I think that's an important point. Mitral valve in ring is really higher risk than mitral valve in valve. But have you had to do rescue Lampern, where you've put the valve in and there's this flapping anterior leaflet?
Yeah, Jaffa has published a case to do that. Even a new LVOT, or I think it's more than 400 still happened. So it is good to do that, but we never do that.
I think you don't have an option. Once you have the valve and the anterior leaflet is longer or more dynamic than you think. The problem is that rescue Lampern, you're limited by the frame, so it may not work that well anyway.
You may try. The other way is to do septal ablation.
As one guy told me that just close the ASD, because when surgeon happened as a dynamic SEM, we just give the modem. So that's I don't remember who told me that you should close the iatrogenic ASD and see what's happened. Usually the LV volume become increased, so the heart rate becomes slowed down and the dynamic SEM will stop. And I have a question to Xiamen. That's the puncture side of the leaflet. Because I know that the Lee is still here and the song is still here. I think the puncture side is too base. So that for the puncture side near the throat, it's got very difficult because sometimes the wire will go to the throat. And the other problem, I think, is when the balloon inflate, it's got a very long leaflet. So it's possible to check that if the puncture side is too near the throat, it's have some problem, or this is okay. You should do it at the throat every time.
Yeah, so that will be addressed in our troubleshooting paper because it's different from surgical heart valve, sapien valve, and tall frame valve. First of all, if it's a sapien valve, short valve, or surgical valve, pushing is okay. But if you had a valve with a tall, short, soft frame, puncturing too basal, you will end up with framed metal balloon interactions when you put in. So it can be overcome, but one of the ways is to puncture at a point slightly away from that. So we had some suggestion in that paper. Usually it's 1/3 away from that. So secondly, for all these, we mentioned in the paper, but there are lots of troubleshooting things. For example, if you cross the balloon, but it doesn't go through, but for adjustment, then we also mentioned that paper. But one thing I want to put it out is, for example, you do short in tall, you can land in note 4, note 5, and note 6. So we will never land in note 4 because you need to go a little bit, at least at the leaflet level, at the upper end, in order to open it up with Unicon technique. For example, in that case with Oli Becker, for example, you can imagine the acroneal, the leaflet is so long, So if you open up the Unicon, for example, at a very low position, it doesn't work because you need to overcome the leaflet to make it split. So there are lots of technical tips and tricks, but we are learning through the process, as you mentioned.
Experience. Okay. Sorry. Can I also have a question to Dr. Lam? You said that if it comes to the native vessel, TAVI, you would start with the basilica, the traditional basilica. Is there any situation that you switch to unicorn for the native vessel?
Yeah, I have no experience, actually. Maybe Professor Yin has some experience on that.
Yeah, it depends on the distribution of the calcium. If the leaflet calcification is heavy, you do native valve, and the balloon cannot push away the calcium. You will just push to all the annulus, the injured annulus. But if the calcium is on the annular ring, that may be safer. Yeah.
You know, there's been modification of the classic Unicon. I remember the paper was in native. You shouldn't do Unicon because there's nothing to hold on to it. But as Professor Yin said, it has been successfully done all around the world, but whether that's a good solution for native valve, maybe from our surgical colleagues, I would think it's probably not the best idea. There's nothing to stop it, but I think the point was Unicon and basilica, your puncture point may be different. Your basilica needs to be as low as possible. Okay, you're not going to have interaction metal to metal per se. You want to split as much as possible. The lower, the bigger split. But Unicon, you don't want to be right at the base. And most of the time, when I proctor, people always go as low as possible. The reality is that the sewing ring, etc., you cannot go too low. It's just not going to cross. So you have to respect the sewing ring as well when you traverse.
So experience of the transversal of the wire startle. Once you apply the electrode cautery, the wire should be punctured through the leaflet without resistance. But sometimes once we have encountered resistance, and even we can advance the wire. But you have to be very cautious because the wire may go the other direction. And even if you use balloon to dilate the leaflet, that would be a complication. So I think the feeding is very important. And I have another question for Xiamen because the unicorn is basically for balloon expandable valve. If you implant self-expanding valve, the procedure is the same?
Yeah, so there's a recrossing technique that we published, and in our paper we also explained if you want to do a self-expandable valve with Unicon technique, you need some extra steps. So to keep the leaflet intraannular, without it flying around, and near simultaneous implantation of valve, because you will anticipate more upfront laceration, it will end up with more hemodynamic instability. But one message is it cannot open up in the fenestration with a self-expandable system. So there's a reason there's a difference between the self-expandable and balloon expandable. But let's work on it, which is the best way. But we had a suggest technique, which is a recrossing technique.
As illustrated in your cartoon, you should place 2 wires in the LV, one for ballooning, the other for valve. And the valve is already standby in the ascending aorta. Then you balloon it, and then deploy the valve. Okay, the time is up. So sorry for interrupt every one of you. But we really enjoyed this wonderful session with a good interaction and very fruitful one. Thank you very much for your attention. Let's move to the next section, section 4, transcatheter tricuspid valve intervention.
So welcome to join this section of transcatheter tricuspid valve intervention. I'm Song Hsin from Taiwan. We co-chair this section together with Men from Thai and also Dr. Lu Fanglin online. So we also have several distinguished panelists, the Kent and Ivan from Hong Kong, and also Dr. Li Qingwei, Zheng Bo-song from Taiwan, and also we have Pan Wen-Zhi, Zhang Yuan, and also Zhang Haifeng from China. So let's move to the first topic that we would have Professor Gilbertin to present the topic, tricuspid TEER versus TTVR, how to decide for my patient.
Is on TEER versus TTVR, how to decide for my patients. Here are my disclosures. So the latest ESC, EACTS guidelines show that for the first time, the transcatheter therapy appropriate for heart team discussion should be considered in terms of improving quality of life in high surgical risk patients. But why are TR patients so difficult to manage? Well, first of all, very few patients who had TR are treated today with surgery. You can see that here with the recent data. And the reason for that is that the patients tend to have high comorbidities, and the operative mortality, although it's better than before, is still relatively high, around 5%. And not just that, even if you survive the surgery, the prolonged ventilation is around 21%, and 35% of patients stay in the hospital for 2 weeks or more. The other issues with patients with TR is that they're sicker with limited guideline-directed medical therapy available. heterogeneous patient population. They have isolated right heart disease, concomitant left heart disease, patient with pulmonary hypertension. They often have cardiorenal or cardiohepatic syndromes. Isolated tricuspid surgery carries significant risk, including bleeding and liver failure. There are also challenges associated with pre-procedure optimization and post-op management. So the TRI score has been developed specifically to predict modality in tricuspid valve surgery and is now being validated for also transcatheter tricuspid valve interventions. And you can see that here in terms of the scoring system, low is 0 to 5, intermediate 6 to 7, and high meaning 8 to 12. And these patients probably likely will be futile. What have we learned about TEER and transcatheter treatment options? Well, the following key learnings are that there are 5 grades of TEER severity, and we now have new morphological classification. TE imaging is key, and now 3D intracardiac echo is now a critical adjunct. And anatomy and imaging determine the treatment plan and procedural complexity, and both TTEER and TTVR reduce TR and improve quality of life, but have important trade-offs between the two therapies. This seminal paper by Becky Han showed the 5-grade classification of TR severity based on quantification. Along the same token, we now know that the tricuspid valve is not just 3 leaflets, but have actually other segments. Of that, you can see that a third of the patients have the type 3B morphology being the most common. 3D reconstruction on TE has been critical now to optimize TTEER and TTVR procedures, and you can see this example of a TTEER procedure. And you can see that here as well of 3D intracardiac echo complements TE in terms of TTEER and TTVR, as shown in this example of a TTEER procedure on 3D ice with explained to help with grasping and confirm insertion. Currently, the TriClip G5 system is commercially available. You can see that with 4 clip systems, just like the MitraClip, to optimize and customize repair. And you can see this was a first commercial case that was done at Mount Sinai in April 2024. 1 clip, you can reduce the TR from torrential to 1+. Now, the Triluminate pivotal trial with 800+ patients was recently presented at TCT last year. And you can see that the procedure exceedingly safe with 30-day major adverse events is less than 1%, bleeding 3%, single leaflet device attachment or SLD around 6.7%, pacemaker is rare, and also all-cause mortality 30 days is exceedingly rare with low hospitalization and tricuspid valve reintervention. You can see that here the TR severity, however, that about 42% of patients have mild or less TR afterwards. However, despite that, KCCQ score did improve. Now, looking at the randomized cohort, you can see that for the first time it showed this paper from Circulation that TTEER does reduce hospitalization at 2 years, and recently ACC 2026 also showed in the TRI-FR study of the same impact of reduction in hospitalization. However, you can see that here the morphology and the number of leaflets does matter in terms of procedural success. And this paper is showing that if you have a 4 leaflet configuration, the likelihood procedure success is less. Importantly, we now have evidence showing that moderate TR may no longer be adequate. You want to get down to mild, moderate, or less TR to confer a mortality benefit. So alternatively, you can have the TTVR procedure instead of repair. And you can see this is the Evoke system, which is commercially available with 4 different sizes. And you can see the anchoring of the leaflets with the feet here. There are 9 anchors. And you can see this is an example of a fluoroscopic deployment. And you can see that here in terms of the 3D MPR deployment showing really TR elimination after the procedure. The TRISCEND-2 pivotal trial demonstrated improvement in KCCQ score of 6-minute mock test. And you can see almost everyone had mild or less TR. And you can see that the most recent ACC presentation so that if the patient underwent TTVR even at 1 year crossover, we're better off than patients who never crossed over. In the control group with the red line, you can see here the mortality at 2 years is more than double. Now, what about the real world? You can see that here in this JAMA paper showing that TTVR is not as safe as TEER with about 3% mortality, bleeding risk is higher, pacemaker rate is around 15%, and you can see there's also risk of device migration or embolization. However, almost everyone had mild or less TR afterwards. So how do I choose between the two therapies? I think that first of all, you have to depend on patient factors, including age, ability to anticoagulation, and pacemaker risk. You have to decide what to expect the TR reduction is. Is mild or less okay, or you need to be moderate, or it would be sufficient? Is TR elimination necessary? There are also imaging and anatomic factors such as tricuspid anatomy, TR severity, gaps and coarctation reserve. Can you see the leaflets? Is there a CIED lead? And in terms of CT scan, would be appropriate if the patient is suboptimal TEER candidate. But the question, of course, is the anatomy suitable for TTVR? So here the percentage trade-off. You can see that, certainly the workup is more intense with TTVR. I think anatomy imaging would be easier for TEER for simpler cases. Procedure time, however, is longer. Pacemaker risk is higher with TTVR. Also, acute RV failure is potentially possible, especially if patient with moderate dysfunction. Anticoagulation need is real, and you need to be at least on 3 to 6 months of that. Hospital stay is longer with TTVR, about 2 to 4 days. And if a TR reduction, usually at least your level mild moderate TR, but in terms of replacement, usually it's no TR. So in terms of algorithm, I would say if we can reduce the TR to mild or less based on the factors including anatomy, gap, lead, and imaging, I think TEER is still the safer and effective alternative. And this is especially true if the patient cannot take anticoagulation. However, if you cannot reduce the TR to mild or less, I think if you're anatomically feasible and can take anticoagulation, I think TTVR is a more effective option. So here's some imaging criteria that we published looking at TEER, consideration of the green, yellow, and orange-red zone in terms of anatomy and imaging quality. And we've actually published the imaging workflow. You can see that here during TEER about when to use MPR, when to use ICE. At the same time, you can see this seminal JACC review looking at anatomical feasibility for TEER versus TTVR in terms of multiple factors. This is an excellent review on TVR in terms of some of the options and challenges involved. In terms of surgery versus TEER versus TTVR is also an important decision-making, and this algorithm is an excellent overview. And we have also recently published a paper in JAMA Cardiology looking at the role of different specialists and also how to determine whether transcatheter interventions versus surgery would be appropriate in these patients. So in summary, complex patient population to manage patient comorbidities and heterogeneity makes tricuspid valve disease challenging. Surgical outcomes have improved but still have morbidities. Transcatheter treatment has become the dominant alternative, but it's highly anatomy and imaging dependent. TEER is safe but less effective in achieving mild or less TR, and TTVR does eliminate TR, but would require anticoagulation, has higher pacemaker and bleeding risk, and risk of acute RV failure and longer hospital stay. I'd like to thank you very much for your attention.
I think it's indeed a very comprehensive talk, but I don't think we have Gilbert online, so because it's midnight in the US.
You better ask the panelists instead.
Yes.
So what do you guys do in your practice now in terms of how to choose TEER or TTVR? Maybe different place, a little bit different. We'll start with you, Ken.
Yeah, thank you, Man and Adam. So I think Gilbert has very nicely summarized some of the important considerations. So in fact, yesterday, and also in my slides, we're also going to advocate 4 A's criteria for selection of TEER versus TTVR. First is talking about the availability, So because when we talk about different options, you need to make it available or not. Then the other thing is about the anatomy. So whether the anatomy is suitable for TEER, which is a safer option. And the third one will be whether there is a concern of afterload mismatch. Because in TTVR, the concern will be more legit because it's a complete elimination of TR at one go, versus TEER, most of the time you still leave with some of the TR. The last is on the, I forgot the last one. I said anatomy availability. So anticoagulation, yes. The last one is on the anticoagulation concern.
Yeah, regarding the anticoagulation, we know the data from the published, the cover valve and also the are showing that around 10% of patients will have asymptomatic, leaflet thrombosis. Just wonder, we know that probably if we can refer this phenomenon to the aortic valve, which may also carry risk of long-term durability. So just wonder, when majority of those patients have been put on standard anticoagulation, but patients still have leaflet thrombosis. What would you do when you have, leaflet thrombosis? Just keep regular anticoagulation, or do we need to, enhance or further, strengthen our anticoagulation? So maybe Eric, I know that Hong Kong also have, plenty.
Yes, I think thankfully we don't have any significant clinically relevant or subclinical leaflet thrombosis, but what we have is possibly bleeding problems after mandatory anticoagulation, because these patients, they often have angiodysplasia in their gut, they have thrombocytopenia from hypersplenism, and with one episode of overshooting, he could have experienced life-threatening bleeding. The other concern is the elevated infective endocarditis risk after a transcatheter TAVR because of the right side heart valve, and so that's something to be mindful of.
Another thing is that when you put a boundary between the TTVR and also the TEER procedure, we probably lost the assessment on the right ventricle function. We all know that it's really crucial for if the patient is going to have TTVR. So we know that in China they have annuloplasty device. So just wonder, maybe Zhang Yuan, would you comment if the patient have very bad RV function, but also the anatomy is not suitable for TEER? What would you prefer?
Yes, this morning we talked about that with Professor Lee. Also, the same topic. It's very important one to choose to do the correct patient selection. If the jet between the posterior and anterior, maybe we septum and anterior, maybe we try to do the TEER, edge-to-edge TEER. But if the jet is in the middle, maybe we can try the valve annuloplasty, use the K-clip. Normally, we can decrease the regurgitation from maybe 6 to 4 or 5 to 1. Thank you.
I think it's nice. Maybe we can combine the two treatment platforms for a patient who are not suitable for TTVR and also depressed RV function. So we can move.
Yep, let's move to the next very important talk also. It's a CIED-related tricuspid regurgitation. We'll be giving a talk by Eric Chen from Hong Kong.
All right, thank you, Dr. Man, Dr. Song, and thank you, Taipei Valves, for the kind invitation. I'm going to talk about CIED-related TR prevention management. I'll talk about mechanisms of CIED-related TR, the prevention as well as management. And a severe CIED-induced TR is quoted to be prevalent around 45%, 47%. I mean, a lot of these patients have right heart failure or left heart failure with a secondary TR, so they are just lead-associated TR. But after lead implantation or CIED implantation, significant leaflet impingement and severe TR could arise in around 10%, and that has resulted in a cellular TR evolution. The mechanism could be due to light leaflet perforation, subvalvular entanglement, or most of the time is leaflet impingement, especially the septal leaflet. On the right-hand side, you should see the color jet along the posterior side, and on surgical findings, you could see a lot of adhesions involving the lead and the subvalvular apparatus. prevention is better than cure. So we should consider preventing it by tricuspid valve sparing pacing strategies in patients with already significant, like moderate or severe TR, like His bundle pacing when the lead is in the atrium, but however, is less and less commonly performed because of the increased complexity as well as the high pacing thresholds. CS pacing may be possible because it spares the tricuspid valve, but it's associated with dysynchrony. Leadless pacemaker, I'll go into that later. It may also be associated with increased TR because of the mechanism like dysynchrony or mechanical interaction with the survival apparatus. For ICD options, we have subcutaneous ICD, extravascular ICD, surgical epicardial, and some authors actually implanted some ICD in the middle on this coronary sinus, but of course, defibrillation threshold testing is important. And sometimes we have to implant more than one pacing lead, and that should be minimized. And these are just the alternative pacing strategies like that we do in our center, like coronary sinus pacing, placing the lead in the anterior interventricular vein. And also, this is a case of heart block after Lux valve. Unfortunately, we need to perform this near-assisted leadless pacemaker implantation. This is a longer version. This is the AVIR, which is slightly longer, so we have to really implant it in a more apical position to avoid interaction with the valve leaflets. Prevention is important. There are some reported strategies like prolapsing lead technique, how you avoid perforating the lead by prolapsing the lead when you enter the right ventricle. And also some authors found that if we place the lead in the posterior septal commissure, it's going to be associated with least tricuspid regurgitation. However, there is no good way to do this. And Professor Vinny Bapet, which is our good friend, has devised some early feasibility study and some startup with these trajectory guide, basically some guiding sheath to help implant pacing lead and ICD lead, which will effectively put the lead in the posterior septal commissure and also may be helpful in protecting the lead in the case of tricuspid valve replacement to prevent the lead from fracture and compression. Prevention is also important if we suture the header of the device, because this is one case of ICD implantation after young patient with ARVC. You could see immediately after implant, there was good slack on the ICD lead. However, as the header drops, and then there was more and more tension on the lead, and then you could see the baseline TR got worsened significantly because of the less of the slack, and then the septal leaflet impingement, and now he's on transplant workup. And so how do we tackle CIED-related TR? Of course, naturally we think about lead extraction, but however, we have to factor in the risk of the procedure because lead extraction is also associated with further tricuspid valve injury, and then we have to think about the pacing strategy afterwards. Surgery is, of course, always an option, transcatheter TVR or H2H repair. In this study by Posaralgia, they found out that lead extraction may not actually improve TR, and severe TR may persist or even worsen in half of the patient. However, that might help further subsequent transcatheter tricuspid valve intervention. And another in registry in Europe, and then in over 100 patients undergoing lead extraction, actually over 60% of them did not have any significant improvement in the TR. And in this paper by Ambry or another US groups and using the EVOKE valve, actually 4 out of 52 patients had entrapted RV leads and the lead complications, including lead dislodgement, fracture 2 months afterwards, and endocarditis afterwards. And there are friends from Ambry, Adam Greenbaum, etc. actually also reported after EVOKE up to 20% of these patients had a fractured lead or a lead revision or jail lead and had sudden cardiac death. However, transcatheter H2H repair is very safe in the presence of CIED. And in this triluminous study where they studied the use of TriClip, actually a lot of these patients had pacing lead inside, 20%, but there was no reported CIED damage. So I'm going to show you some examples. This is a case of pacing lead through the leaflet or survival apparatus. You could see on TE there's this eccentric jack. Basically, the lead is passing through possibly the valve, but definitely through the survival apparatus. You could see on transgastric view and explaining it, you could see the lead going sideways. So it's not really going to the true RV apex. And on CT, we actually assess the course of the lead is actually trying to go to a high septum or alveolar flow tract, which is quite a common site for pacing by our EP colleagues. However, this patient had survival entanglement, and I performed the H2H repair of the TriClip device. The strategy was to do the same thing, but actually try to gel the lead along the anterior septal commissure or posterior septal commissure and to entrap the lead in one of the commissures. You could see before and afterwards, there was a relatively mobile lead, and then I performed H2H repair of the anterior septal coaptation, 2 devices over there. basically immobilizing in the subcommisure and resulting in mild or no TR. And this is just the post-TE and TTE results of the echo of the procedure. We have another patient with RV infarct. You could see his dilated right ventricle. He had history of VT, so he had an ICD. Again, septal leaflet impingement by this very rigid ICD lead with a massive TR. He required paracentesis for his cardiocirrhosis. And you could see his TAPS was very poor, very impaired RV function, TAPS less than 1, RVS prime 4. I gave levosimendan and dopamine and Lasix as a prehab measure prior to the transcatheter artery procedure. Again, my usual strategy is end to septal coaptation, try to perform bicuspidization of the tricuspid valve. And the reason for the septal leaflet impingement because the pacing, the ICD lead was not apical enough. Therefore, in attempts to put the whole coil within the right ventricle, there was some prolapsing segment. So that impinged on the tricuspid valve leaflet. And that was before and afterwards. And after tricuspid valve edge-to-edge repair, you could see significant improvement in the TR. I think we need to restart the slides because it hanged. So can we restart the slide? Okay, thank you. I'll go back to the page there where one was. And there was before. There was also reverse remodeling of the right ventricle. You could see it has shrunken in size after transcatheter edge-to-edge repair. So RV dysfunction is not a contraindication for tricuspid edge-to-edge repair with a TriClip device. You could see improvement in the TAPS and also RVS prime afterwards. However, he became hospitalized again with bradycardia and became pacing dependent by the single chamber pacemaker, and he has heart failure symptoms again because he doesn't like RV pacing. However, as we attempt to perform a CRT-D upgrade, it was complicated by, it was not possible due to the CTO of the brachiocephalic vein. So I could implant a new ICD or CRT-D over the right side. However, I will risk further causing TR. I could do the conduction system pacing, like his bundle pacing over the right side. I might reattempt the venoplasty, but there is a high technical expertise and infection risk. I could consider explant, epicardial, ICD. So there are many options. Leadless pacemaker, but he needs synchrony. So of course, medical treatment is always key. In this patient, we performed the atrial pacing for this patient because he was dependent because of a sick sinus syndrome. So leadless atrial pacing, then he could get away without another lead across the tricuspid valve. And we did not have to have an abandoned lead if we explant the left side and then put in the right side the CRT-D again. So we don't have to go through the leadless pace, go through the tricuspid valve again. And then his symptoms improve. You can see the A pacing spike, and that although the PR interval is long, he is not pacing dependent, and he has anti-BNP has improved it. So we have another patient with torrential TR with a septal leaflet impingement. You could see on the echo, you could see a huge coaptation gap, and she also has cardiac cirrhosis. And you could see significantly, basically the septal leaflet is all pinned down. If you look at the transesophageal echo, basically no target to grasp. You could see on transgastric view, the septal leaflet also pinned down significantly. So in this particular patient, we elected to perform transcatheter TVR with the Lux valve. And because we were concerned about possible pacing lead damage, because she's pacing dependent, we preemptively implanted the micro in the high septal position. And we understand that the septal anchor is so important in terms of the stability of the transcatheter TVR with the Lux valve. Therefore, in this particular case, we make a special attempt with a multiple pigtail with some guide wire. Alternatively, we will be used to use a steerable catheter like an Agilis in order to try to mobilize the lead slightly so that it's not in the way of the septal anchor. And in this case, we temporarily mobilized the lead, and then we performed the anchoring. And then there was a good result with a good stability, only mild paravalvular lead anterior and septal to the Lux valve. And she did develop acute afterload mismatch. You could see significantly impaired right ventricular function afterwards, but the dopamine was able to be weaned off after 3 days. Now we have another patient with cardiac cirrhosis, dilated cardiomyopathy. You can see bilirubin level 90, ammonia 163, recurrent hepatic encephalopathy. Normally we work all patients up for possible heart transplant and LVAD in Hong Kong. However, there are always contraindications despite a young age. Because of a poor liver function, he was turned down for these advanced heart failure therapy. And apart from tricuspid we also performed PASCAL transcatheter edge-stretch repair. Again, we PHAP'd with dopamine, Lasix, levosimendan, with 1 P10, actually 2 ACE devices in a very large 7 centimeter left ventricle. You could see from basically torrential MR to mild to moderate. It's worse on TEE, but actually it's much better on TTE. And the gradient was only 2 to 3 afterwards. And then we performed the he also has significant tricuspid regurgitation because of the ICD lead. Again, that's our usual strategy to perform transcatheter edge-to-edge repair approximation of the anterior and the septal leaflet. In this case, we performed put 2 ACE devices along the anterior septal coaptation. And on the left side, I did use this elongation maneuver in order to get away from the cord entanglement and also to avoid interaction with the ICD lead. And that was the result. You could see good MR and TR reduction afterwards, and then he got much better afterwards. So in summary, tricuspid valve pacing, sparing pacing strategy, careful lead placement, and appropriate lead redundancy may reduce CIED-induced TR. Transcatheter tricuspid edge-to-edge repair is feasible and safe option to treat even CIED-related TR with minimal or no risk of damaging the leads. And a transcatheter TVR is an alternative in selected case. We talked about that before, about the pros and cons of a replacement. But the long-term effects on the CIED leads remain unknown. For now, we have some patients with preemptive leadless pacemaker implantation in order to be extra cautious. But of course, with more long-term data, I think this step may not be necessary in our patients. Thank you very much. And apart from a leaflet modification center, we are also a center of tricuspid and transcatheter edge-to-edge repair, hopefully reaching around 400 cases this year. And we look forward to seeing you in Hong Kong Ops 2026. Thank you very much.
Fantastic. So, any question?
I'm Dr. Chen from Jianxin General Hospital, and a surgeon. We treated this in CIED-related TR with beating heart surgery, with angioplasty and to relocation that lead to the AS junction or to the PS junction, just like your TTR strategy. So I have a question. Is the TTR strategy can use all of the CID-related TR? And is any the post procedure with failure condition?
No, I don't think a TEER procedure can treat all CIED-related TR. I think in the case of like leaflet perforation or complete impingement, like the septal leaflet can be completely pinned down. It's like during even systole, it's all downward, then I don't think it's a good target for grasping. And of course, the septal leaflet has a certain length. I mean, part of it may be pinned downwards. The other parts of it may still be lifted up with a transcatheter edge-to-edge repair. So again, it boils down to individual anatomy. And I'm glad to hear that there are surgeons who have interest and expertise in performing these lead relocation, which can definitely be helpful in a lot of these patients.
Yeah, so therefore the pre-procedural image assessment on the lead in the interaction with the leaflet is very important. So thank you, Eric. Thank you.
Thank you.
So let's move to our next talk. So welcome to our good friend, Professor Kensel. He will present the advanced strategy and device selection for torrential TR.
Thank you, Adam. So I guess a lot of the content actually has been covered by Gilbert, but today I'm going to focus a lot on the patient that has torrential TR and also with large coarctation gap. So in fact, in our initial Asia-Pacific experience of the TEER procedure, we actually already demonstrated that patient that has baseline torrential TR, the outcome is actually not as good as those who are not having a baseline torrential TR. And of course, like with clinical experience, the result is actually improving. That's actually attributed to the increased operator and also imager experience. But at the same time, the anatomical selection of these patients based on the experience that we have is also very important. this was also illustrated in lots of the other publications, including having a coaptation gap more than 7 millimeter or baseline torrential TR. They are all related to a suboptimal outcome in performing TEERs. So which means that in patient that has baseline torrential TR and also with a large coaptation gap, the expected anatomical correction of the TR is might be less good. But the honest truth in our locality is that torrential TR with large coaptation gap is not uncommon. That is because a lot of our patient actually comes in very late. And at the same time, we are facing availability issue because not all devices that were commonly discussed is available across this region. Some of the devices not available, for example, like Evoke, that's commonly described as not actually coming into Asia Pacific, but we also have some domestic device. So the decision of which device to use is actually very important. So I'm going to illustrate with two cases to start with. So this is an 88-year-old patient, has CID infection. Our EP team performed the lead extraction. Unfortunately, on table, the patient actually developed cardiac arrest, and we noted that they actually, when pulled out the lead, they torn the whole papillary muscle. And the patient subsequently survived, but went into a cast for heart failure symptom. But this is not a TEER anatomy with large coaptation gap. It's also a huge prolapse segment. And at that time, we don't have orthotopic TTVR option. But the feature for this patient is the TR comes in very acute. The RV function is very good. The RV pressure is actually normal at that time. So the option that we have at that time for this gentleman is the trick valve, heterotopic TTVR, and we successfully implant the TTVR. And what we can see in this patient who is surviving 4 years after the operation is he is actually remaining in class 1 to 2 symptom, and antipropionic initially increased and subsequently actually improved. So this is a good option at the time of the TR development in the setting of acute TR, normal RV function, and availability of this trick valve device. The second case is a 70-year-old patient, atrial fibrillation, presenting to us 3 years of fatigue, poor appetite, mild lower extremity edema. Very common presentation, a little bit subtle at the very beginning. But when you scan the patient, the RV is already grossly dilated, and there is a very big gap with a torrential TR. And when the patient presented for intervention, she already went into a stage of cardiorenal syndrome for 6 months and recurrent heart failure. And you can see this patient has a coaptation gap of 21 millimeter, so TTR is not an option. But the good thing with this patient is on the workup, there is no RVPA coupling mismatch, uncoupling, and the RV function just from this image is actually relatively preserved, despite that it's grossly distended. And despite medical therapy is still very symptomatic. So a lot of presentation on this device, so I don't go into detail, but in this patient, we choose in Lux valve, which is an orthotopic TTVR option. Given the, despite the RV dilatation, the RV function is actually preserved and there's no RVPA uncoupling. So again, 2 years of follow-up, remain in class 1 symptom, and the RV and RA actually remodel very substantially. So do I actually refer that in patient that has baseline torrential TR with large coaptation gap, TTVR is the option to go? In fact, it's not. So in considering TTVR, there's actually quite a number of considerations apart from just the anatomy. So as Gilbert has mentioned, from the current understanding and publication, we know that TTVR is actually associated with higher peri-procedural outcome. So in fact, I didn't include our study, but in our multi-center registry, including Adam and also Chris Center, our accumulated experience with TTVR on a compassionate use cohort of patient is still associated with higher peri-procedural complication, which is actually very similar also in the European and also US experience. So apart from the peri-procedure complication, which means that we need to consider patients' tolerance and also comorbidity, the 4A criteria is also very important before we make a decision of recommending patient to go for a TTVR treatment option, including the tolerance to anticoagulation, whether there is a possibility of afterloop mismatch when you eliminate the TR at one go completely. And we also need to consider the anatomy because in TTR, we look at the coaptation gap, leaflet morphology, but in TTVR, there's also very stringent screening criteria. For example, like in the EVOKE series, the screen pass percentage is at the very beginning around 30%. Now probably they're increasing to over 50%. But Lux is better. The screen pass criteria is around 70 to 80%. So the CT screening criteria is still very important to recommend a TTVR. And last bit is, of course, whether the device is available or not. So the availability is also helping to make a decision on which device to recommend. So in the left-hand side of this slide, this is a recent publication of the risk of acute hemodynamic instability with TTVR treatment, which is actually very, very important because in patient that has large coaptation gap and also a baseline torrential TR, we need to evaluate very clearly whether they are running into risk of acute afterload mismatch that might result in acute hemodynamic instability. In that paper, they find out that a baseline kidney dysfunction, high wedge pressure, and also RVPA uncoupling is actually associated with an acute decompensated risk. So in fact, apart from the TAPC over RVSP ratio, which has been widely discussed, Nelfam's group actually recently published the value of PAPI in predicting the risk of long-term suboptimal outcome. They didn't actually focus on the acute instability, which I think the TAPC over RVPA ratio might be a very important consideration. But the PAPI is also very valuable in predicting the patient's subsequent outcome after a TTVR treatment option. So in Nelfam's paper, they actually find out that in patient that has PAPI more than 1.13, the 2 years outcome with TTVR treatment option is actually much better than comparing to those who has a PAPI of less than 1.13. So these are very important. In particular, as Eric has mentioned, pre-op optimization, which we label it as prehabilitation with levosimendan, dopamine, diuretics, are very, very important in this cohort of patient, not just for TTVR, in fact, also for TTR, which I would elaborate more. So if the patient is with the 4A consideration, if they are not a candidate for TTVR option, do they still benefit from TTR? In fact, it is yes, because in a lot of the publication, if you can successfully reduce the grading of the TR with TTR therapy, the patient's clinical outcome actually improve quite substantially. So this is a patient, 74-year-old, refractory lower extremity edema. So you can see that, I mean, the coaptation gap is not like 20, but it's still a very big coaptation gap of 9.3. And the RV is actually grossly dilated. You can see the RV pressure is actually, the septum is bouncing on the left side, so it's actually having a very high RA pressure in this patient. So baseline torrential tricuspid regurgitation, the good thing with this patient is majority of the TR jet is actually arising from anteroseptal and also in the central segment. Not much TR coming from postseptal. This is one of the important anatomical consideration. So not just the coaptation gap, but also location of the TR actually matter in terms of the TR reduction with TTR therapy. So this patient, we actually attempted with TTR therapy. But what is the strategy if we are going to do this kind of like more challenging cases? I think the most important thing is on the pre-op optimization. So in general, for these patients, we actually admit the patient 48 hours in advance for intravenous diuresis, plus or minus dopamine infusion. The ultimate purpose is to have the patient reduce in the volume status and also have the tricuspid annulus reduce in size, hopefully to facilitate any subsequent grasping with a reducing in coaptation gap. And the adoption of shifting technique is also very important. So in this patient, apart from pre-op optimization, what we try to attempt is to optimize the leaflet grasping as much as possible. And we started at the more commercial side, although that in that region, TR might not be apparent at that site, but the purpose is not reducing the TR at the very first grasp. We are trying to reduce the annular size, hoping to subsequent leaflet grasping will be easier and impactful in reducing the TR. So in this, we have the first device, XGW, at the more interceptor region. And you can see the TR is still there, not very substantial reduction, but the coaptation gap substantially reduced after the first device is inserted. And then we put in the second device side by side, another XTW device. And now you're seeing that TR is actually reducing. So we subsequently put in a third device, again side by side. So the starting eyes TR is actually still moderate to severe. And after the third device, you start to see that apart from the RV shunting, tricuspid annulus is actually reducing, and the TR is actually largely improved. And in this patient, you can see the anteroceptal commissure is completely closed, and there is reduced TR. What about if you don't have the substantial reduction in the annular size and sipping might not be a good strategy? Then chest wall compression and compression at the very beginning, in the early days, we still try to use this technique. Now we are using it less because of increasing experience with the sipping technique, and also the other thing is also availability of the alternative treatment. This is a patient with mild type of Epstein abnormality, so that's why he survived to 85. And refractory lower extremity edema with ascites. The tricky point for this patient is a misaligned and annular plane, as you can see from the white dotted line versus the yellow dotted line. So it's very technically challenging to grasp both leaflets at the same time. So what we try to do in this case, we're actually well illustrated. Anterior chest wall compression in this case is not very helpful, as you can see from the top screen. We tried multiple attempts. We are not able to grasp the both leaflet at the same time. This is performed in year 2021, so the independent grasping is not yet available. So, with the right side chest wall compression, you can see, apart from bringing the two leaflets together, we also sort of like align the annular plane in order to reduce in order to facilitate grasping. So at that time, we're not heading in the direction of reducing mild TR in year 2021. So we actually think the result is actually pretty good. But if we're to do it again, then I think we would put another device at that time. So there were other described techniques apart from pre-op optimization, intra-op diuresis, chest wall compression, and also sipping technique. People have also tried to use table tilting and balloon occlusion in the IVC. I think it's actually not quite working, but that was previously described. So there's also a discussion on the hypothetical combination of annular reduction with annuloplasty to facilitate subsequent edge-to-edge repair. It's actually a very appealing option, but we need more data and more experience because the K-clip works well in the post-receptor, but whether that will reduce the anteroceptal coaptation gap will need to be proven. So to conclude, in favorable anatomy, I would say TEER is the first option because it's a very safe option. In patients with large gap torrential TR, we need to think about TTVR as an option, but considering the 4A criteria to see for the eligibility. If TTR is to be performed, we need to plan ahead with pre-op optimization and also utilize some of the techniques like sipping technique, which will be very useful. And in these cohort of patients, reducing the TR even to a certain degree, not eliminating it, is actually very meaningful clinically to the patient, which we need to think about it. Thank you very much.
Thank you, Ken, for the very comprehensive talk. Question?
Ken, thanks for your very elegant talk as always. So I have a very clinical relevant question. So I know that you did the concomitant procedure for the mitral and the tricuspid, but there is a relative common clinical scenario is that patients have torrential TR and moderate mitral regurgitation. So what is your strategy and how do you evaluate the interplay with the LV and RV?
Thank you, William. I think I can't really answer your question because there is a need of more data coming. But first, this is again a very important and common problem. So in patient that has significant mitral and tricuspid regurgitation, we will consider concomitant procedure, but taking a lot of consideration first to see whether the TR is going to improve further. Second is also on the expected challenge in one of the procedure. So if we expect on one side the procedure is going to take very long then you might need to think about whether you want to space them out to improve the anatomical correction, the outcome. But in patient that has moderate mitral regurgitation, so currently, in fact, it's actually off the guideline. But there has been quite a number of publications to state that if you reduce the tricuspid regurgitation, the forward flow will increase, and the mitral regurgitation actually will get worsened. So we would also try to look at that, but there has been publication on that. So in that regard, in our center, I'm not sure whether you guys will do the same, but in our center, if we think that the patient has left heart symptom, and there is moderate to severe. In moderate grade, we won't touch that, but if it is moderate to severe mitral regurgitation, we will actually do a concomitant with trying to optimize the mitral left side pressure to facilitate an optimal result of the TR reduction and patient improvement.
Any other comments from the panelists? Kenton, I'm just wondering, let's say if the TriClip fails, do we have plans for the future? I saw some new device that can explant the clips and then deploy the actual TTVR later on.
Yes. I guess Ben and I were in CSI. They presented a case of a device that can completely extract a device, not just to cut, but also to extract it. So I think that's actually going to be the future, because the more device that we implant for in TTR or and also in mitral region, we're going to expect a certain percentage of failure. And in those cohort of patients, they might be very symptomatic. We need to think about different strategy. Extraction is one of it. Just sandwiching the device in situ is the other option. And we have tried that. I know Xiamen's team also has tried that with success, just sandwiching with a TTVR device.
Great. So very great discussion. Then let's move to the next talk. Transcatheter ectopic tricuspid valve implantation, TAVI, Who, When, and How by Yuan Sang, please.
Thank you, my distinguished panelists. So my name is Yuan Zhang. I come from Shanghai, Fudan University. So today I will talk about the heterotopic TAVR valve implantation and try to report the subacute early results of the TAVI pivotal trial in China. So before we talk about the TEER and the replacement, we have the two techniques already, but we still have a lot of untreated cases. So here we can see there are 23% of patients, they are unsuitable for TEER and replacement. At the same time, these kind of patients were associated with significant mortality and worse prognosis, maybe because of the anatomical reason or maybe very poor echo quality. So in contrast to orthotopic technology, so here is the data from 644 patients who underwent CT to evaluate the anatomical suitability for heterotopic TAVI with tric valve. And here, 87% patient is okay for the tric valve. So given this, the TAVI technique has its unique advantage, such as the intro procedure, the echo imaging is essential for the orthotopic therapy. But for the TAVI, just like the SVC processes deployment, it could be deployed only by the fluoroscopy. For the IVC processes, it's simple guided by the transthoracic echo. So for the patient, so here for the baseline parameter, I compare the two trials. So here is the triluminate with TEER, the transient with TTVR, the orthotopic replacement, and also the tric bicavo registry. So here we can see the TAVI patients, they are more sick. They have a greater percentage of hospitalization, and combined with the renal insufficiency and also the bad function class. So for the patient are more sick, but we can see here is consistent with the baseline KCCQ score is the lowest one, only 40 for the TRICAS registry with the tric valve. But we can see the delta KCCQ score could be 19 in the middle of the other registry. So the TAVI system is to implant two processes in the SVC and IVC. So the compact of the tric valve, the TAVI system impact on the right heart is worthy of attention. So this is a good demonstration. We followed 6 months, the CT that they show the right ventricle is smaller than the base value. And without significant enlargement or dilation of the right atrium. And also there's no clinically the right heart impairment. So maybe for this kind of patients, the TAVI would be an optional option. So here the tric valve system got the CE mark since 2021, and now we have this device in China, and the pivotal trial is carried out in China. So it's a prospective single-arm multi-center study, and the target of patient is 130, and 22 sites are enrolled in our trial. So here is the patient inclusion criteria. So the first is symptomatic, very severe tricuspid regurgitation. And the most important thing is the V-wave in the IVC and SVC, more than 10 millimeter mercury. And without very significant the LV and the RV function, and also not very high pulmonary artery pressure. And until this year, April, we have 69 patients enrolled already. So here is the baseline character that we can see the patients at high significant comorbidities. So 37.5% of patients with the pre-existing pacing lead, and also combined with the renal insufficiency in 2/3 of patients. And also the tri-score is 8, and the heart function is also in 3 and 4. So we have 69 patients in all, and intra-procedure success we achieved in 65 patients. So there are 4 patients. One patient he required the open surgery because of the IVC migration. And for 3 patients, they got the valve-in-valve implantation because of the acute malposition of the IVC processes. So here we can see we performed the right heart catheterization immediately after procedure, and we can see for the IVC and SVC, the mean gradient decreased significantly immediately after the device deployment. In the contrast, the right atrium pressure increasing immediately. There's another manuscript that they perform the right heart catheterization at 3 months follow-up. The pressure in the right atrium returned to the basic value when they doing the follow-up. And no patient have the hepatic vein systolic flow conversal. So when we do the echo, that we can see there's no significant, the tape slightly worsen. So maybe it could partially explain that the right atrium, it has a capacity to function as a reservoir. So here we have the clinical success at 30 days is 91.3. And we have 2 patients died of pneumonia. There's no cardiac mortality. So all the patients, even though they are more sick, but they could get the significant improvement of the quality of life, including the heart function, the KCCQ score, and also the 6-minute walk test. So here, the tric valve system could be delivered by the 27 French delivery system, and there are 2 sites for the SVC, 3 sites for the IVC. The shoulder pain is the most common complication. It primarily occurred maybe in the comprehension of the phrenic nerve branches at the level of diaphragm. So here is the deployment. When we do the deployment of the SVC, we do the angio. We put pigtail in the right brachial-cephalic vein first to get the roadmap, and then subsequently we place the pigtail in the left innominate to angio to ensure that the left innominate is not blocked. And normally we will put a wire or catheter in the pulmonary artery. So maybe for the upper right pulmonary artery is better, but if we place catheter like this, it's also okay. We just to make sure for the SVC, we should keep the belly above the pulmonary artery. So normally it's relatively simple for the SVC deployment. So the most important procedure complication is the IVC migration. Normally, it's primarily occurred in the patient with very greater angulation of the IVC and RA. So also we will place a pigtail in the hepatic vein to do the angio to ensure that the hepatic vein should not be blocked. And here we can see. So we have some tips to make the IVC deployment. So sometimes we should make the angio at RAO. That maybe we can get a better view of the bottom of the right atrium. And also we can make a wire in the right atrium to make sure where is the bottom of the right atrium. So why the deployment is very easy to occur to bump into the right atrium? Because when we release the processes from the 3-pedal, if it's too quick, that the valve is easy to pump into the right atrium. So normally it's recommended to release the IVC valve slowly and slowly. There are 3 reasons to do that. So the first, we can give the processes time to against the vessel wall. And second, we can make accurate position. And the third, even though it's recapture, but less recapture, we can faster the procedure. So trick valve bicaval implantation offers an acceptable safety profile in highly comorbidity population. And also it's resulted in meaningful improvement in function status. However, we should do the long-term follow-up to make sure the RV function and also the hepatic vein. Here is the perspectives. Ongoing trials are expected to improve the understanding of the clinical benefits of TAVI and also help us to make the better selection of the patients. And also, we will keep ongoing our trial, and maybe in the future, in 1 year, we can finish our trial and then maybe investigating the role of TAVI in the right heart remodeling. Thank you.
Thank you. Any comments or question from the panelists?
Yes, thank you, Zhang Yuan. I want to ask, is the current the data showing around 70 patients, right? And so where will you expect to have the complete enrollment for the trial in China?
It's difficult to see. If with all of you's help, maybe we can finish it in several months. And maybe because now it started already 1 year, and we have 70 patients already, and maybe only, I think at the end of this year, maybe we can get the number to the target number. Thank you.
Yeah, I have a simple question. Do you think that the cover valve is more forgiven in patients with severe RV dysfunction when the TTVR might not be a good option?
Yeah, thank you, Professor Song. It's a very important question that I always think about that, because for the severe tricuspid regurgitation, maybe the patient had very bad the right ventricle function. Sometimes we think about maybe the right atrium could be a reservoir, that maybe it gives us more space to the right ventricle function, but when during our experience, we found that the pulmonary hypertension is very important. In the other manuscript also, it's dedicated that around more than 2/3 patients, they have the pulmonary hypertension, even though maybe combined pre-capillary or post-capillary. But regardless the classification or severity, all the patients with the right heart, the pulmonary hypertension, they have more risk for the mortality and also very bad prognosis. So sometimes when we do the patient selection, the right ventricle function is okay, but we pay much attention to the pulmonary pressure. And the other key point is the left ventricle function. Sometimes when the more blood go to the left ventricle, if the eject fraction is not good, so in our trial, we keep the eject fraction more than 40. And sometimes when the patient's, the left ventricle is very small, in our center, we have a patient, an old lady, she's 92 years old, and the left ventricle is very small. The right ventricle function is okay, the pulmonary pressure is okay, but after the procedure, they suffer the very serious dyspnea, and we have to give him the NIV. So sometimes we pay attention to the pulmonary pressure and also the eject fraction of the left ventricle. And with the help of the right atrium, for the right ventricle, it's okay. Thank you.
But also the importance of V-wave pressure also, right? Yeah. I mean, that's also another important on top of what you just said. All right, maybe. Thank you.
Thank you. So let's move to the last talk of this section. We have Dr. Wang from Singapore to share the technique of TEER, zipping versus clover. Nian.
Thanks, Adam, and thanks for having me here today. I'm Wang Nian from National Heart Center, Singapore. So today I'll be focusing more on TEER and talking about zipping versus clover technique. And I also like to hear more from what the esteemed panelists and hear what you all think about this. Yeah. So as we done quite a number of TEER procedures, there are two kind of principal strategies for how we do TEER. One of them is the zipping, or what we call a bicuspidization kind of technique. And it's putting like clips in the anterior septal leaflets to cause a bicuspidization and reduce the TEER. Another kind of technique is sometimes do is the clover technique, where you put one clip in the anterior and septal leaflets and another in the posterior septal leaflets to form kind of like a clover kind of clover leaf kind of anatomy. So in the early days of TEER, there's quite a lot of favoritism to more of a clover kind of technique. And some early studies in Munich, like 69 patients, where they look at patients who underwent a triple orifice technique or a clover technique versus those who undergo bicuspidization technique. And you find that those who underwent the clover technique had kind of like a numerically kind of better TEER reduction, although not significant. But the tricuspid annulus dimensions actually reduced significantly at 1 month for those with the clover technique. So showing maybe a possibility of a more annuloplasty effect with two clips that are separated more further apart. However, clinical improvements are equivalent with both techniques. And hence, there's a little bit more suggestion that, hey, maybe putting this one in the anterior septal, one in the posterior septal will create a better and a more uniform kind of annuloplasty effect on the lateral wall and pulling it in, rather than just putting like two clips in the anterior septal position, where you exert more of a more anterior kind of annuloplasty effect. So that's the thoughts about it. However, a more contemporary registry from the Spanish centers of almost around 300 patients, where this is not a randomized trial, where patients who underwent TEER and they look at those who underwent the zipping technique versus the clover technique and compare how are the outcomes. And you can see that the majority of them had a zipping technique, almost 70%, 2/3 of them, and 1/3 had a clover technique. And they look at, and they define what is complex tricuspid valve anatomy as those with two or more of the following: having a 4-segment tricuspid valve leaflet morphology, coaptation gaps that are 7 or more millimeters, and the presence of a jet in the posterior septal origin. And if you look at the baseline characteristics between the two groups, yeah, they are balanced in some aspects, but if you look carefully, is that those patients who had the Clover technique had kind of like a more complex tricuspid valve anatomy. They have gaps more than 7 millimeters. More of them have that. More of them have type 3B morphology. And also they have more massive and torrential TR. And if you notice that clinically, they are also a little bit higher risk in those who underwent the Clover technique. They have a higher tri-score and a trend towards a higher NT-proBNP level. And on surface value, these are the clinical outcomes that was reported, is that the zipping actually achieved a better TR reduction compared to Clover at discharge. And however, the clinical outcomes were quite similar between both techniques. But if you look carefully, the initial better TR reduction with zipping eroded with time. Even though the discharge TR was better with the zipping technique, but after at 1 year, it kind of quite similar between the groups. And what predicts residual TR 3+ or more? It's not really the procedural strategy itself, but rather the clinical factors, which is the larger renal contractor and a wider coaptation gap. And as mentioned, those who underwent Clover technique had more complex anatomies and possibly more advanced disease. They also end up having more procedural complications of SLDA. So maybe it's the type of anatomy that actually dictates the strategy in this kind of registry studies. So I'll just give a case, a relatively simple case that was done recently to maybe we can discuss how we're going to approach one of these kind of tricuspid cases for TEER. This is a 70-year-old male, end-stage renal failure on dialysis at a previous transplant that had failed, thrombocytopenia, liver cirrhosis, atrial fibrillation, quite a typical kind of severe TR patient. He had moderate to severe TR for quite a number of years, but started having more and more symptoms, breathless exertion, low limb swelling, borderline blood pressure, and the TR progressed to severe. The RV is dilated and the RV function is impaired. Didn't have any significant coronary artery disease. The PA pressures are elevated, which is quite common in many of these end-stage renal failure patients. It's usually quite a dirty or mixed kind of picture. Usually it's usually a mixed pre and post capillary kind. But you can see the TR indices on the right heart is all pretty elevated. The V wave is 36, mean is 24. And the TE shows massive TR. And I'll show this is the baseline TE that is done before the procedure. So you can see massive TR extending from the anterior all the way to the posterior septal regions. The coaptation gap, fortunately, was not very wide, maybe 4.6 in the anterior and 3.4 in the posterior. Yeah. So this was a case of severe symptomatic TR, high surgical risk, and we found that anatomy is amenable for TEER, and hence we went ahead with TEER. And as what many of the speakers have mentioned, prehab is really important. So usually we bring patients in like 3-4 days before. We either aggressively diurese them, but for end-stage renal failure patients, we usually contact the renal physician and say, we need a sequential dialysis before the procedure. So we usually bring them a few days, and every day they go through dialysis to try and draw as much fluids, and sometimes even with a bit of vasopressor support. And this is after 3 days of dialysis. You can see the TR has come down quite significantly from massive, maybe in the severe range. If you don't have the pre-procedure images, you can see, hey, the anterior septal TR has reduced tremendously, and now it's mainly posterior septal and central. But the coaptation gap has almost kind of closed up from 3 to 4. I would say it's hardly there, but there's still quite a bit of TR. So we like to use 3D MPR quite a lot, and also the transgastric imaging to really understand the tricuspid valve anatomy well, because you need to know, firstly, tri-leaflet or not. But it's not just tri-leaflet or 4-leaflet or 5-leaflet. It's also how big each leaflet is relative to the other leaflets, the position of each of them, to help you decide what kind of strategy you want to go ahead with. So you can see this is a very nice kind of relatively straightforward tricuspid valve anatomy with small coaptation gaps after prehabilitation. And the jet is mainly central and now posterior septal, but bear in mind there was anterior septal in the pre-procedure imaging. Also the transgastric imaging. So maybe I'll pause here for a short while. Maybe I'll just ask the panelists and what you all think and what kind of strategy will you use for this case? A zipping or Clover? If I don't mind. Maybe who will do a zipping technique? Okay, and Clover for the rest? Okay, Yeah, so I thought of doing clover too because there's quite a bit of jet at the posterior septal location, like what Ken mentioned, that the jet location really matters quite a bit. So that was my pre-procedure strategy. So went ahead to put the first clip, XTW clip at the anterior septal region. Yep. So using 3D MPR helps to guide the position of the clip, both in location, trajectory, and also the perpendicularity. So quite straightforward. Gaps are not wide, so pretty easy. Yeah. So put in one clip in the anterior septal region. So after the first clip, the anterior septal jet, it's gone. There's nothing in the commissures. It's now consolidated mainly posterior for the first clip. So after we put this first clip, then I was thinking, hey, so where should we put the next one? If you look carefully at the TR, the posterior septal TR has actually reduced quite a bit, and the TR is actually quite close to the first clip. So we use 3D MPR again to actually see where exactly you want to place it. So if I put a cursor here at the posterior septal region, looks quite nice, quite like a low-lying fruit to actually grasp it. But as the jet was quite close to the anterior septal clip, so move a little bit, try looking at the anterior septal location, is there any place to clip? Looks a bit challenging. You can see the first clip coming in and out of the view, so maybe a bit difficult because of a possible interaction. So I thought, okay, maybe let's try and put a posterior septal clip and see how it goes. Yeah. So using 3D, also once again, you can put a posterior septal clip. It's quite far apart from the first one. However, you can see, look at the TR after the posterior septal clip. All consolidated in the central region, but I think it looks a lot worse than even the pre-procedure TR. So this does not work. Yeah. Hence, we may have to force it to go as close to the first clip as possible and grasp at the anterior septal location, converting what I initially planned to be a clover to a more of a zipping kind of technique. So you look at the first plane, go as close as possible and make sure that the clip is located where the maximal TR jet is. And actually there may be some leaflet there to grab. And you snuggle very close to the first one. And once again, I think when you want to go very close to the first clip, I think echo is not that accurate in telling the spatial kind of relation. I think fluoro helps guide how close you can move to the clip. Yeah, the echo will guide how you're going to grasp the leaflets. And so, with two clips placed in the anterior septal, the TR is a lot more acceptable now with just mild TR. So just some personal thoughts on strategy. Yeah. So I think the device strategy matters a lot. Some factors that matters is the anatomy, the location of the jet, and also the intended annuloplasty effect that you want to achieve. But currently, I think it's pretty hard to conclude if one strategy is still superior to another. So a thorough understanding of each individual tricuspid valve anatomy is pretty important. And having a 3D image of the tricuspid valve in your head is really important to understand the relationship of each leaflet to another, how the size of it matters a lot, yeah? So it's not just the number of leaflets, but the size and relationship. And from there, we derive a preliminary kind of a TEER strategy, where those with a large anterior leaflet, a jet that is predominantly anterior septal, will kind of favor a zipping technique. But those with a type 3B, or significant posterior septal jet, we may have to end up doing a clover technique. Most situations, the first implant will be between the anterior septal leaflets, but we must be flexible and adapt during the case because you assess the TR of the first implant to decide if continuing with the preliminary strategy. If you have a very good reduction of the TR with zipping, we may consider stopping. If the clover technique worsens TR, like in the case that I presented just now, you consider zipping or stop. But we must be mindful that the clip in the posterior septal location is especially prone to leaflet distortion and altering anatomy because it's quite difficult to really get a very nice perpendicular view. So be mindful that you're not distorting the valve before concluding that you have failed in the clover technique. So then the big question is, if there's no significant TR after zipping, does putting another posterior septal implant help with annuloplasty effect and durability? Conceptually, it makes a lot of sense. Sounds very sound, but I think clinically we still do not know for now. Yeah, I'm not sure whether we will have some answers in the future as we look at long-term data. Maybe, but this TR is still a very heterogeneous population. There's still very hard. There's so many factors that can affect this durability. So, but we hopefully there's more data in the future. And the predictors of residual TR are so far a lot to do with anatomical variables rather than technical variables. And in complex anatomy, maybe you have to consider TTVR. Thank you.
Thank you, Lian, for a very comprehensive talk. Any question?
I guess just like yesterday we discussed with Hsin, that I guess most of the time we cannot determine which technique until you put in the first clip, right? And it will change a lot sometimes the orientation or the morphology. So I guess it's always have to decide after the first clip, I guess.
Yeah, completely agree.
Yeah, but can I talk? Can I say that from you, the registration from Spanish, showing that actually the Clover technique has more durable effect compared to the zipping technique? Can I say that?
Seems like it, yeah. If you look carefully at the data, but they didn't seem to want to say that, no? Yeah, I'm not sure why.
Yeah, but so I think that zipping is quite useful and also very. The procedure is much simpler than Clover technique because it carries a challenge to deal with the posterior septal grasping, and also the orientation might be the key. So nowadays, I usually combine. You can put two clips and the anterior septal, and then followed by the last clip. Even the patient have very limited residual TR, but you can foresee that patient who has pre-existing posterior septal gap might have recurrent TR at that part. So usually after two clips, I will also mandatorily put another clip at posterior septal. You can see that after two clips, the posterior septal gap is 0, and I think that would be much easier to have another device.
No, I also agree. I think my clinical practice is so I tend to favor what Adam does also. But sometimes if the posterior septal clip worsens the TR, and after that, then that becomes a bit of an issue sometimes, yeah. But I agree, yeah.
Yeah, thank you. Okay. Any other comments? Otherwise, I think for the interest of time, we'll conclude this session. I think it's very good tricuspid session. Thank you, all the panelists, all the speakers. Okay, it's time for lunch. Okay.
Let's move to the section 5. TAVI beyond the comfort zone, complex anatomy and bailout strategy. Let's welcome Professor Cheng-Chung Cheng to share a few words with us. Welcome, Professor Tsai.
Okay. Thank you so much. I'm Cheng-Chung Cheng from Tricuspid General Hospital, Taiwan. It's my honor and privilege to be here to co-host with the, thank you, to co-host with the Dr. Zhang Qizhen and the Dr. Eberhard group. Eberhard group come from Germany. Yeah. And we also honored to invite Dr. Minong-Ki Hong from Korea, Dr. Yang Go from Korea, Dr. Daisuke Hashinoha from Japan, and Dr. Zhiyang Zhan from Taiwan, Dr. Wang Bin and Dr. Yang Qing. Okay. Online, yeah. So this section we totally have 5 topics. Our section 5, the topic is TAVI beyond the comfort zone, complex anatomy and the bailout strategy. During perform the TAVI surgery, how to have the bailout strategy is very important. It's a very important section. Now, maybe I introduce first and the second speaker. You introduce Sir and you introduce fifth, Dr. Dr. Zhang introduce you, and you introduce Sir and fourth. Okay. Why don't you do that? Okay, I can do that. Okay. Okay. So now we start our section. Our first speaker will be Dr. Ye Jian. I briefly introduce the Dr. Ye Jian. Actually, Professor Ye is our senior and a good friend of Taiwan for many hospitals. I briefly introduce Ye Jian is Professor Ye Jian is a clinical professor and the director of cardiac surgery research at the University of British Columbia. He is also a cardiac surgeon and the director of cardiac, mitral, and tricuspid valve program at St. Paul Hospital and the Vancouver General Hospital. His subspecialty is complex mitral and tricuspid valve repair and the transcatheter valve therapy. Today's topic is TAVI, applicable to aortic insufficiency, current device technology and evidence. Let's welcome Professor Ye, please.
Thank you, Professor Tsai. Good afternoon. So I think my procedure that doesn't need a bailout. It's a pretty safe procedure. Okay, so the title is TAVI applicable to aortic insufficiency. So I think nowadays we try to use aortic regurgitation rather than insufficient because AI is confused with AI. So now it's more use. This is my disclosure. So as you know, I think this already presented quite a few now. Basically, off-label THV is the main problems, as you know. I think regarding new generation, old generation, I think this incidence is still pretty high. Of course, you can oversize a lot, like 20, 25%, or even some people up to the 30 or 40%. Yes, that's probably was successful, but the problem is, I think still there's a risk. Of course, I will change my mind. Yesterday is a live case from Zhongshan Hospital. Maybe I will change the slides because seems like almost 100% success with self-expandable. So probably particularly that valve has special features, so that's why you can be used for the AI patient. But overall, not great outcomes. So this is a sort of my experience in TAVI with dedicated THV for pure AI since 2010. And the first device, I'm not sure everybody heard about this device. It's actually developed by Edward. It's called the Hilo Dock. And the dock plus the XT valve at that time and early generation. And this one actually worked very well. We did a few first in May, and then unfortunately this project stopped. I think at that time probably is more efforts want to dedicate to the AS patient, and also because people think AI patient probably not really good market. So I think this was shut down. And then I used the Yen valve. Yen valve, after Yen valve, I used the J valve, but now is a CAN valve, so it's a Chinese valve. So HeloDoc is basically a principle same. Basically, put the separated the dock system and put it outside the leaflets, and then you put the Sapien 3 valve inside. It's just sandwich the leaflets. So the concept is the same as a clipping device. But this problem is the initial developer, they use the two system. So one is need either transapical or transfemoral. So you need to do two access, or need both side transfemoral access. So that's why make a procedure is a little bit complicated, but the concept is good. And the outcome is great. And this patient, actually, my patient, coming back for the eight years, and he's still very good at the valve function. And the leak almost is no leak because they have 6 anchors. So you're missing 1 anchor, still no problem, still will be anchored. So it's actually, the outcome is great, but unfortunately this was a stop. You see that the anchoring very well. No issue with the paravalve leak. So after that, I used the Yen valve. That's actually pretty early. I used for the AI patient rather than AS patient. Actually, at the beginning of these kind of valve, they are not say this is designed for the AI. Actually, we say that this kind of clipping device is designed for it. Initial design, they are not really say specific for AI. It's basically they put the locator is basically want to help to positioning. But now, because we use it for AI, I found that this is clipping is very good for the AI. But the Yen valve, I think when I used it, has some issues. Mainly is perforation of the leaflets. Very common. I found that there's a perforation leaflet because it's so pointed. So and then that's why in the next generation they cover this tip of the feeler. So that's changed in the second generation. So overall, it's a pretty good outcome, but there's a difficulty to capture the 3 leaflets at the same time. The main reason because this is the locator cannot open it fully when they're trying to catch the leaflets. So it's a little bit difficult to particularly catch the left side of the leaflets. So once they captured, everything's pretty easy. So next one is a J valve. I think in China they do lots of J valve. But I did also put quite early years. So this is a very good. As a locator is very good for the positioning because it's a half circle. So it's more like automatically sync down to the annulus. So it's different from the Yen valve. And also because the valve is located separated. So usually fully open. It's very easy to capture 3 leaflets at the one time. So that's why procedure is much faster compared to a first generation Yen valve. So outcome is overall is very good. No issue. The CAN valve is, as I think, also Chinese valve. Now there's lots of developer in China. So this valve is also very similar to the Yen valve. The difference is a tip a little wider and also covered. And also there's a sealing skirt at the bottom. So trying to reduce the regurgitation. Honestly, AI patient actually paravalve leak is pretty small, generally speaking, if you size appropriately. So this valve is also currently this transapical is pretty easy to implant it. There's no specific different. So this is I just put a table here, and for the 1 year outcome, I didn't list as a further. Some valves much longer, but I just give it a comparison. The Yen valve initial generation, actually the success rate is pretty low. I think there's a few things in my experience are just difficult to capture all 3 leaflets, and that probably caused some issues. And in terms of pacemaker implantation, you can see that the J valve usually is smaller. I would give you some reason why the J valve is less than, like pacemaker rate, less than the other valve. And the stroke usually pretty low. I expected the stroke rate should be much lower than this 1%, 2%, because there's no really calcification. I don't know why they still have some calcification. Maybe there's some thrombosis, and because the ACT is pretty low, they're trying to use a 250. I'm not sure. As a surgeon, I always concerned the 250 is really enough for prevent any micro thrombosis. So pelvic valve leak is pretty low, overload. So the next generation, of course, transfemoral dedicated to THV, and then once everybody knows is already approved as a Trilogy, the basic Ying-Hwa valve is a new generation. Design slightly different. And the second one was G valve, and now there's a Chinese one, it's called the Pioneer. And the Ying-Hwa valve is pretty similar to first generation, but it's a bovine pericardium now. The frame is different, and the tip is covered. So, but in terms of the capture leaflets, a little better now because they can use the coaxial movement. So that's allowed to capture leaflets, trying to resolve that's a problems. So this is better than the first generation. But the size is still limited, still 3 size. So that's another issue. So you can see that the 3 leaflet pillar, like a locator, is not fully opened, even in this generation, not fully open. For the AI patient, usually aorta root is larger, so that's why it's difficult to capture. So you have to adjust it, so they have as a function, so to adjust it, that's why easy to capture. So J valve transfemoral system, actually I used this first one, the first generation. First generation, I'm not sure everybody's seen. There was actually the holder for the locator is different location. So we did in the humans. First one was really difficult to load it, and then we changed it to the middle of the locator, so make it much easier. And the main benefit is the locator and the valve is separate, so allowed to fully deploy the locator before the valve deploy. That's the main advantage, and the size is bigger. And the procedure is pretty simple. Generally speaking, is that you just push down, and then most times you can capture 3 leaflets. It's pretty easy. There's no really major difference. So we did this for the transfemoral, transsubclavian, actually left the transsubclavian very easy to do with this, particularly horizontal one, the transsubclavian is really good. So overall, it's a great outcomes. And now we are using the Pioneer, the THV, trying to use this one. And this one is a valve, you look at it, very similar to the Trilogy valve. The only difference is I just highlighted here. So basically, the only advantage of this one is that the locator can be individual controlled. So you can that's allowed easy to capture the leaflets. So I will demonstrate in the next one. You can see it. So you see that you can lift it on the left side, and then you also can lift it on the down. So that's allowed to easily capture 3 leaflets because the Trilogy I already mentioned that the locator is the same. They are not fully open. So trying to capture the 3 leaflets in the AI patient, not that easy. For AS patient, no problem. So this one is trying to resolve this problem. So that's why it allows the 3 locator independently controlled. So allowed to better capture the leaflet. So the early outcome is I just say device success is pretty high. So all transfemoral system now the device success is high. Now it's probably even higher with experience and device modification. And in terms of pacemaker rate, you can see it. Other valves still pretty high, but with the time, I think reduced now as a Trilogy, I think down to the 15 or something, 15%, but it's still high compared to AS patient. I think the pacemaker still not acceptable for this, and the share valve was slightly low, but our experience should be lower than that. And the leak is pretty low, generally speaking, very, very low problem with pelvic valve leak. So the reason why the pacemaker, that's my thought, why the pacemaker is high. Sorry, I almost done. So pacemaker, why is high? You can look at it, Trilogy valve and also the Pioneer valve. The bottom part, the inflow, actually is larger than the annulus. So when you choose the size, Your annulus matches the annulus size, but it's below the annulus. Actually, your diameter is bigger than the annulus. That's a problem because you put it down, you will cause the obstructive. The J valve, you see the cylinder. There's no any enlargement. So overall, generally speaking, you don't need to enlarge the like oversize. For this kind of valve, you don't need to oversize. So should the pacemaker rate much lower, but there's a high because I think that's my opinion. This design is the issue. Second is you see the ratio. No one said this before. You see the ratio here from the tip to the bottom inflow. These two valves really the distance is pretty long compared to the J valve. That's why when you implant it, because this is a ratio there, so they're always deeper. They're deeper. If deeper, that's a cost problem. So that's why you can improve the pacemaker rate, but I think it still will be a problem for this valve. I don't think you can really down to the single digit with this kind of design. But anyway, that's my thought. But I'm not sure this is correct or not. That's my belief. I don't think you can reduce very, very low. So this 10 years J valve is 5 years. Overall, but the number is pretty small, so we cannot really say too much. But overall, is a real operation is pretty low, and the hemodynamic is relatively stable. And this is 10 years, but number is still small. So, but the looks are pretty durable, actually, pretty durable. And long-term outcome led to a good. I think promising, at least say. So last slides. So I think that we learned from all these different generations. I think the leaflets anchoring is really changed the game. So I think it's very safe, very producible, and very safe procedure, I say. And large annulus, I think J valve pretty good. It can cover most. And 10 years, numbers too small, but I think we need more data to support that. And pacemaker, I think some of the device probably need to change the design, allow the pacemaker low. Otherwise, it's not accepted in the young patient. So I think the overall, I think the nowadays dedicated leaflets very good for the AI patient. I don't think there's any problem. So the femoral system available, I think this method will be adopted widely. But our caution is that we don't have a long-term outcome. Yes, we're very careful to use in the new patient, particularly your pacemaker is a double digit. I think that's not acceptable in the young patient. And off-label TAVI should not be used unless you really have no choices. Thank you.
Okay, thank you very much for Professor Ye's excellent talk. Because every topic is very different, so we separate for discussion. Our speaker or Professor Ye.
Are you avoiding questions?
We discussion topic by topic.
Can I ask a question?
Oh, please,
James. This is a very. I mean, obviously, I was burning to ask you what do you think is the reason for the pacemaker rates. Now, in the surgical literature, we have to say comparing surgery for AR versus surgery for aortic stenosis, the numbers are always also a little bit higher. I never thought about the design issue, which I think is very interesting. I have to look at it now that you mentioned it. Do you really think that because the inflow is larger than the waist, if I may say, that might be the reason that it scratches the interannulus, the membranous septum? Is that what it is?
Yeah, you see that the distance quite. The problem is your locator is really determining how deep your valve go, right? Because even the implant high with the pressure, you still can push down, because it really is the locator to hold the position during the diastolic. So that's my belief, because your locator is and the bottom of the inflow, there's quite a long distance. But you look at the J valve, there's no really distance. So I don't think this valve needed too long. The inflow below the locator doesn't need that long stent. So I think it will change the pacemaker rate. And also, when beginning, yes, the 25% is with try, and then down to about two digits, 17 or 15, right? That's because people initially they oversize too much, because when everybody is scared the valve will move, so they oversize a lot. So that's the cause of the pacemaker. Now they learn that they reduce the oversize the pacemaker down to the 15, 17. But you can really down further, you know, to the 5% or 7%. I don't think, that's my belief, but it may be wrong.
The incidence of the permanent pacemaker rate is higher, should be lower, they agree. But actually the anchoring of a valve is in the AL patient is really difficult, because there is no calcium. So may I ask if you, with size is smaller, if there is a more increase the chance of the migration of the valve?
Yeah, so basically, initially we always trying to be like a 10% oversized, or sometimes down to 5% oversized. And later on, we do basically zero oversize. The reason is I think the pressure is more on this diastolic pressure, and then systolic pressure actually is pretty small, right? So as long as you locate it down to in the sinus, I don't think it will mobilize. Unless there's one potential situation is a dilated aortic root. If you have aortic root aneurysm, the valve may push up, because I have one patient. Initially it was fine, but with pressure, I think the leaflets are higher than the locator. So when they push, they just move pushed up. So for the enlarged aneurysm, you need to be careful about the valve. Thanks.
Excuse me, do you have any data about paravalvular leak? If you use the TAVI for the AR, any data for paravalvular leak?
Really low.
Very
low. I would say that moderate probably is 1% or less. If you are probably selected, unless you really undersize a lot. Particularly for J valve, actually you can undersize. The reason is because it's located different. Because a half circle, they push the leaflets in. But for the other valve, because they're only on the central part, not on the commercial part. So may have a little issue if you undersize too much.
Okay.
Professor, you just mentioned about the lower part, the inflow, the design of the trilogy. That's the part of the reason that increased the pacemaker rate. But but you don't think it's very important for sealing, or you think it seems that the sealing rate, PVL rate is quite similar between different.
Yeah, the sealing, as I said, for their valve maybe need a little longer, because they not compress the whole leaflets. For the J valves, compress the whole leaflets in. Is it because of circle? So for the trilogy valve is on the middle. So that's why your commercial may leak if you're not oversized a little bit. So that's probably is a valve design itself. But I found it's a J valve because I'm not sure that they have lots of experience. I think it's J valve is because the half circle is really pushing, so it can seal.
Okay, thank you so much for Professor Ye. Now we proceed to next talk. Next talk will be by Professor Yang-Gu Guo. I briefly introduce Yang-Gu Guo. Is an international cardiologist, interventional cardiologist at the Severance Hospital, Seoul, Korea. Is affiliated with the Division of Cardiology, Severance Cardiovascular Hospital, Yonsei University College of Medicine. His clinical and research interests including interventional cardiologist, coronary intervention, structural heart disease, transcatheter valve surgery, therapy, and cardiovascular clinical research. Today, his topic is outcome of second valve implantation as a bailout strategy for acute valve migration during TAVR. Let's welcome Professor Guo.
Yeah, thank you very much for kind introduction. So it's my great pleasure to come here, and I feel honored. My topic is, for me, a little bit unpleasant, and it's a bad memory, painful memory for me, but I think we can learn from our painful memories too. So valve migration leading to significant AR or valve embolization is rare, but these events or the bailout procedures can result in fatal complications. Implantation of second valve is commonly employed as a bailout strategy to restore valve function and maintain hemodynamic stability. However, data regarding the immediate procedure outcomes and subsequent clinical course following second valve implantation remain limited. These are the baseline clinical characteristics of our cases. In 7 Korean centers, TAVI centers, we implanted more than 2,000 valves between 2013 and 2025. And we had a total of 28 cases of valve malposition requiring rescue second valve. This is 1.4% instance, and about 56% of cases were self-expanding valves. When you look at the clinical characteristics of our patient, actually nothing stands out particularly. But when we look at the echo and CT data, then we see that something significant. So because of the small number of the cases, we cannot perform, detailed statistical analysis. But we see that in our cases, the bicuspid aortic valve is only 10%. So I think it is another important factor in our cohort. Combined moderate and severe AR was about 30%, and small annulus and horizontal aorta were present in 75% respectively. And the most of the cases were treated with self-expanding valves, so over 90%. And predilation was not performed frequently, so only performed in 20% of cases. When you look at the types of valve malposition, so migration occurred in 78% cases, and embolization occurred in 32% of cases. The initial implantation depth, suboptimal implantation depth was only in 18%, and more than 50% of cases had spontaneous valve migration. And the final location of the first valve was in aortic valves as a valve-in valve, and 25% of cases had the first valve in ascending aorta. When you look at the early and late events after the procedure, so ocular rupture, annular rupture was only 1 case, and tamponade dissection occurred in 2 cases, cardiac tamponade in 2 cases, complete AV block in 5 cases, and 1 case required conversion to surgery, and 2 cases required ECMO, and the all-cause mortality was 21%, very high, and most of the cases was cardiovascular death, and stroke occurred in 10%, and rehospitalization due to heart failure was 1 case. And after 30 days, actually the clinical event was not frequent. There was only 1 case of all-cause mortality, which was not cardiovascular death, and there was 1 case of stroke and 1 case of rehospitalization. And when we look at the echo data, then the palpable leak, moderate palpable leak was found in 4 cases after the procedure. However, in follow-up, only 1 patient showed moderate palpable leak, and there were no cases of severe palpable leak. And moderate to severe PPM was not observed in our cohort. So when there have been several reports on the valve embolization or second valve implantation, and the previous reports reported self-expanding valve and bicuspid aortic valve as a risk factor, and also horizontal aorta was a risk factor in one of the reports. And in our series, we found the horizontal aorta and self-expanding valve and the small annulus were risk factors associated with the valve migration, malposition requiring second valve implantation. And at 30 days, in our cohort, the mortality was 21%. It is very high, but it is comparable with one of the previous reports. And other reports, the mortality rate is about 10%. And stroke was reported to in between 5 to 10%, and open surgery from 3 to 20%. So it's very variable. But in all the reports, the later outcomes were relatively favorable. And so we can say when we overcome the valve malpositioning or the embolization, then with bailout strategy without complication, then these patients can survive the long term. So it is very important to perform the bailout procedure very cautiously. So I'd like to show several cases, and this patient was treated with self-expanding valve, Evolut Pro, and as you can see, as we released the valve, slowly the valve migrated upward. So I think we have not released the tension completely while we deploy the valve, and after complete deployment, the valve located above the annulus level. So in this case, the coronary flow was now obstructed, so there was no worry about sinus sequestration when we implant the second valve. So we proceeded with the second valve implantation. So here, the second valve was implanted without any complications, so this patient survived this event. And next case was treated with balloon expanding valve, and actually initial positioning was okay, but during the implantation, the valve was not deployed in optimal position. It was a little bit higher, implanted higher, so we thought we need to implant the second valve, and also the implantation of second valve was performed with balloon expander valve, and this was completed without complication. But in next cases, this patient showed the horizontal aorta, and we treated this patient with the Evolut 29 millimeter valve. And again, while we deployed the valve migrated slightly upward. And again, I think because of the very horizontal course of the aorta, the tension caused the tension of the delivery system caused the migration of the valve, and we can when we look at the valve position, then still the valve is anchored at the annulus level, but there was at least moderate probable leak, and also the valve is not fully expanded. So at the moment, we decided to perform post-dilation. Retrospectively, I would like to have not performed this, but at the time we did balloon dilation, and then this caused the upward migration of the valve. So we needed to implant second valve. And at the time, there was a problem. So because of the angulation of the ascending the aortic root, we had a friction, when we delivered the second valve through the first valve. And at the time, we did not notice anything. But when we checked the aortogram here, then you can see this strut is out of the aorta, and there was some dye outside of the ascending aorta, and I think the first valve perforated the ascending aorta, but the second valve was deployed without any further problem, but the patient showed low blood pressure, and so we need to perform pericardiocentesis, and this patient required surgery. And fortunately, this patient survived this surgery, and the patient is still followed in the clinic. And this case was treated with accurate neo-2, and the initial position was okay, and also deployed in the right position. But here, while we, removing the delivery system, the nose cone come in contact with the valve, and I think we did not pay attention, at the time, and we should have, withdraw the wire, and using the curve of the wire, we can avoid this kind of complication. But at the time, I think we did not pay attention to that, and the valve was migrated. But the additional problem was this: because of the severe angulation, we could not, withdraw the delivery system, and we had some trouble to remove the delivery system. So finally, we applied a large balloon, and then keeping the first valve with the large balloon, then we could remove the delivery system. And after that, we used the second valve, but because of the friction, we tried to hold the first valve with the snare, and then we successfully deployed the second valve, and there was no further problem. But this valve, migrated further upward, and finally it stuck, the aortic arch, and this patient showed still the second valve in aortic arch, but this patient doing well. So malpositioning during TAVR is strongly associated with self-expanding valve use and challenging anatomy features such as small annulus and horizontal aorta. Valve malposition and the need for bailout second valve implantation are associated with the substantial risk of early complications. However, successful rescue procedures are associated with favorable midterm hemodynamic and clinical outcomes. So bailout second valve implantation requires meticulous device manipulation to minimize procedural complications such as aorta injury and sinus sequestration. Thank you for your attention.
Thank you so much for your talk, Professor Guo. Now the topic open for discussion. Or any question? Professor Zhang.
Yeah, thank you for sharing that challenging complications. Let's say if you have embolization of a valve, what's the best strategy to locate the embolized valve? Do you a suggestion? But I realize that the last case you leave the moving the device in the arch. Yeah, we had unfortunately we had very similar experiences. If that happens again, what's the best strategy for the embolized valve treating the?
Yeah, I think the next speaker have a better idea, but it's not. I cannot intentionally, locate the valve in somewhere where I want. So it is related to size of the aorta, and another case which had the embolized valve in ascending aorta caused stroke because of the friction with the ascending aorta. So the best solution is to avoid this kind of complication, and so yeah, it's a good lesson, I think.
Actually, this case was a really catastrophic event. So what is the best way to fix it? Prevent. So to avoid the whole such kind of situation, if this kind of the event is just one time, really painful. So but the company and the expert usually recommend the high level to avoid the PPM. Usually that, but the one case of this kind of, no, I really hate it. Even though I will choose the increase the rate of the pacemaker rate rather than this kind of catastrophe event.
Professor Zhang.
Question: it seems that maybe 2 or 3 cases you sharing. The immediate after the valve deploy, it's tilting, and it's asymmetrically opened. So do you think for those cases, if you do a pre-dilation, it could be helpful?
Yeah, I think first of all, I think if a patient shows a horizontal aorta, then I think it's better to use more steerable, delivery system. So maybe balloon expandable, steerable delivery system valve is better. But also, if we have this kind of horizontal aorta, if there is not much calcium, then there is also the anchoring is not optimal. So I think in such cases, maybe too high, shallow implantation is not a good idea. So you have to think about this kind of complication.
Short question. It seems all the cases you use the same valve for rescue. Any cost?
Yeah, that's the reason. Yeah,
Cost.
and also to prepare the other valve system is take time. So yeah.
So regarding the moving THV, embolized THV, so that is sometimes called dancing THV, but sometimes there are a few case reports that may cause aortic dissection afterwards. So we usually, not usually, but so we want to saturate to the ascending aorta or other parts. But maybe Professor Grube have some opinion, or you don't know.
Okay, thank you. Because time and limitation, thank you so much for your excellent talk, Professor Ko. Then we move to the next topic. Next topic will be Dr. Daisuke Hashinohe. Daisuke Hashinohe is the chief of the cardiology department of Sapporo Cardiovascular Clinic in Japan. He specializes in interventional cardiology. Today, his topic is what should we consider after aortic fixation of an embolic THV? Insight from the CT flow-based analysis. Welcome, Dr. Hashinohe.
Yeah, thank you. Thank you very much for a kind introduction. Yes, I'm Daisuke Hashinohe from Sapporo, Japan. So at this session, I'd like to talk about embolized valve. And afterwards, something occurred. So I want to share my case. The case is a female in her 80s, severe aortic stenosis with paroxysmal atrial fibrillation. And TT and the CT measurement are as shown. So and you can see some severe calcium chunk at the non-coronary side. So in this case, the balloon, pre-balloon dilation balloons ripped out again and again. And this insufficient VAV leads to THV and expansion. That was aortic flow plus 26. And finally, THV embolized like this. So that may be, this is a dancing THV. So finally, we accelerate to the ascending aorta, and the second valve was implanted like this. So this is not a main issue in this presentation. So 3 years later, so up to 2 years, there are no events, so uneventful. But we could identify filling defect here and here. The upper edge of THV on greater curvature and lower edge almost near the leaflet, the lesser curvature, on the lesser curvature. So as you can see, here and here is the probably suggestive of thrombus formation. So we did computational fluid dynamics supported from CardioFlow design company. So at first, the TAVI valve position was meticulously registered against native CT. So that is co-resist like this. And this is just a premise. So boundary conditions are defined using population average. So from average data, physiological data. So flow rates were designed to the aorta and the coronary arteries. So aortic flow rate is more than 4,000, and the left coronary artery and the right coronary artery is like this. This is just a population average physiological data. And where pressure were assigned to the brachiocephalic artery and the common carotid artery and the subclavian arteries. So this is a simulation setup. I'm sorry, this I don't know precisely about this setup simulation. So this is a streamline. So this is like speed. So streamline can visualize the direction and the velocity of the aortic flow as it navigates the aortic arch and interacts with the prosthetic frame. So like this. So the global flow is remained like this. But streamline reveals localized velocity reduction like this. When look at inside THP, so minor vortex formation like this. So directly adjacent to TAVI deployment zone during diastolic phase. So this is a vortex zone. And the next one is, as you know, from coronary arteries and aortic disease. So wall shear stress is very important issue. So if wall shear stress is low, that means stagnation zone or flow separation. So that promotes plaque growth. And if wall shear stress is high, that means strong friction. So that may cause plaque rupture. So this is the wall shear stress of this case. The higher wall shear stress is concentrated around the THP frame boundaries, so indicating a focal biomechanical loading on the adjacent native aortic wall. So the next one is OSI, so oscillatory shear index. So OSI indicates the proportion of cardiac cycle during which the direction of blood flow deviates from the primary flow direction. So that means fluctuation. So if high OSI, it means back and forth flow is very high. So if high OSI, so that means strong fluctuation. So that may produce the reactive oxygen species. So that may induce the vascular lesions. So in this case, this is a systolic phase and a diastolic phase. So this red circle and this red zones reveal the significant direction flow instability across the cardiac cycle. Biochemical marker linked to endocellular dysfunction, accelerated plaque vulnerability. So this is very also important. And the final one is velocity stagnation volume. So areas that consistently dark like this throughout cardiac cycle are regions prone to chronic flow stagnation zone. So the diastolic flow stagnation associated with TAVI placement carries a risk of becoming an origin for localized thrombus formation. So making it a very important indicator for planning post-operative antithrombotic therapy, etc. So in this case, this is a systolic phase, and this is a diastolic phase. So both systolic and diastolic phase, persistent stagnation zone can be identified. So where blood is repeatedly trapped, so creating a hemodynamic environment favorable for thrombus formation. So actually, this stagnation zone corresponds to the site of thrombus formation in this case. So looking back at this case, so up to 2 years, so because patient had a paroxysmal atrial fibrillation, so we prescribed edoxaban 30 milligram for normal dose. But up to 2 years, no event. So primary doctor reduced the edoxaban dose from 30 to 15, so very low dose. And we could identify the thrombus formation at 3 years follow-up. And we increased again to 30 milligram. And of course, this thrombus persisted, but that decreased, so compared with 3 years. So this anticoagulation therapy is sometimes very important for such kind of case. So in conclusion, computational fluid dynamic analysis demonstrate that, so despite preserved global flow patterns, so local hemodynamics disturbance developed along the implant TAVI frame. And these disturbances were characterized by elevated wall shear stress and increased oscillatory shear index and persistent low velocity stagnation zones, all of which may contribute to thrombus formation. So maybe heart development in ordinary TAVI case. So patient-specific computational fluid dynamics may provide a novel approach for identifying thrombus-prone regions and supporting individualized post-TAVI anticoagulation, particularly in case with non-ideal palm deployment. So that this extent and distribution, these abnormalities may vary according to valve positioning, and suggesting that suboptimal implantation depth or orientation could potentially increase thrombotic risk. So this notion may improve our understanding of the hemodynamics mechanism underlying leaflet thrombosis, even in routine TAVI cases. So thank you very much for your kind attention.
Thank you. Professor Hashino, my question is about, you talk about thrombosis. How about hemolysis? Do you have any data about the migration or embolization of the THV, hemolysis situation?
Yeah. Hemolysis. So there are no hemolysis in this case.
In the paper review or in your clinical practice, if once we encounter a situation of embolization, how about hemolysis situation of the patient?
So you mean the embolized THV? Actually, I have only 3 embolized cases, but I don't have any hemolysis case. So how about Professor Ko? So do you have data?
Do anyone want to share the experience?
I experienced, some thrombocytopenia, after TAVI procedure. I guess there was some mild palpable leak, and in a very old age, I experienced several cases of thrombocytopenia, but I haven't experienced hemolysis.
So probably the streamline, so I mean the speed is very high. Sometimes that may cause hemolysis. So,
because I'm cardiac surgeon, usually in our clinical practice, once the foreign body into the body, the foreign product into the body, once the position is not correct, very precise, hemolysis is very often for the patient. So not only thrombosis, it's our clinical experience. I share to all of you. Any other question, Professor?
Thank you. Thank you. Very exciting to see your beautiful analysis. But in our hands, we opened it the next day to remove the moving object. But I will always think it's possible to percutaneous to treat that. I don't know if there is possible to put a aortic stent inside the valve to maybe reduce the possible thrombosis because open the parenthesis. Otherwise, you can. I don't know if that possible. But anyway, I will not comfortable to have a moving object in the aortic. But anyway, it's a very beautiful presentation of how you precisely measure the hemodynamic change.
Okay, thank you. The problem from the floor, please.
Yes, it's a very nice case and a very good presentation. So, good understanding the mechanism, short-term and long-term result is very nice. And the question is not only the thrombus we worry about the the malpositioned valve between the valve. There's a diastolic pressure there should be lower, right, at that part? I mean the coronary flow. Do we worry about the coronary flow there? When the heart rate is quick or when the patients do exercise, is there possible to the low coronary flow?
Yeah, probably, but we can't measure at the ascending aorta, so we don't know exactly. But so that is one issue. But fortunately, the only greater curvature side leaflet is stuck. Yeah. The other side is open, and global flow is remained. So actually, that may not affect. So in this case.
Okay, thank you. Because time limitation. Thank you so much for excellent talk of Professor Hachinosa. Now we proceed to next speaker.
Okay, so now we're going to move to the next topic. I think it's a very interesting, very challenging topic. Bicuspid aortic valve modification before TAVI. This talk will deliver online by Dr. Hsin Yohei from NYU Valve Center. So let's welcome Dr. Hsin.
Can you hear me?
Yeah, clearly.
Very good. I actually now I'm at Cedars-Sinai Medical Center in Los Angeles, so other coast. But thank you for kind invitation, and I'm sorry I couldn't be with you in person. I see many friends there with me. So this topic I'm very excited about is bicuspid aortic valve leaflet modification before TAVR. These are my disclosures. So to give some background, as you know very well, in Asia, calcified type 1 and type 0 bicuspid valves present a non-circular opening that limits optimal TAVR deployment. Deformed TAVR is associated with worse clinical outcomes, and current procedural options are inadequate to produce well-expanded and circular TAVR deployment, so many operators employ device downsizing using smaller prosthesis in relation to aortic annular anatomy. So the objective of this research was to introduce possible advantages of splitting bicuspid aortic valve leaflets prior to TAVR. So this was some research actually in tricuspid valves predominantly, from Minneapolis, showing that THV deformation results in many adverse consequences. So both through pinwheeling, increased leaflet stress, as well as flow stagnation and turbulence, resulting in halt, you can get the end result of fibrosis, calcification, and then premature THV deterioration. So there are many contributing factors: the calcified raphe, excess and asymmetric leaflet calcification, also LVOT calcium, When you have severe rapid calcification, either adjacent or opposite leaflet, severe calcification can make things even worse. Small intercommissural distance, LVOT discrepancies, discordance with the annulus, and also if the anatomy is as often we see non-circular. So we had some prior research that high TAVR risk morphology, especially in type 1 bicuspid with heavily calcified RAF and excess leaflet calcification, was associated with increased mortality after TAVR at long-term follow-up. And the separation in curve started early, but there was ongoing separation. More recently, we showed that the combination of underexpansion and eccentricity of balloon expandable THV was associated with adverse long-term outcome, increasing mortality in the long term. So the concept of BAV leaflet modification was in the setting of this, we often see reduced expansion, increased eccentricity, and when you perform one or more lacerations, the hypothesis is that we should get increased expansion ratio and reduced eccentricity. There are many putative benefits: reduced THV deformation, allow implantation of larger THV, and reduce risk of immediate TAVR complication, and also increase THV durability. So initially, we collaborated with Picardia to initially do several simulations. So initially, simulations were computer simulations with and without split with FEOPS. This is FEOPS simulation, computer simulation, and you can see without in the red and green with simulated split. But then we employed bench testing with this device. This is actually the next generation shortcut device, which is a mechanical splitting device. This was in a excised bicuspid valve with very thick 8mm calcification, and this on the bench showed promising results. So we collaborated with the engineers to use reconstructed valves from excised bicuspid valve from patients undergoing cardiac surgery, and we tested hypothesis performing either one or multiple splits, both with self-expanding and balloon expandable valves. So with this bench testing, you see here pre-split, you see a deformed TAVR, and post-split there was dramatic increases in both area and reduction in eccentricity with improved circularity. This was also the case with type 0. When we performed at least one split, we saw greatest benefit with the first split, dramatic increases in area. And you can compare this just to a no split with post-ill versus one or two splits. There was a dramatic improvement in area and also reduced eccentricity. This was also seen with balloon expandable valves with dramatic improvements in area and again reduced eccentricity, improved circularity. So we are considering whenever a patient comes to clinic, weighing their surgical risk and their TAVR risk. So surgical risk is well established, but TAVR risk is predominantly CT-based, likelihood of a suboptimal early outcome, but also a late outcome. So I can show you some individual cases. This is a case, 84-year-old female with type 1 non-right, severely calcified bicuspid, calcified RAFI, opposing leaflet severely calcified, but the patient also had high surgical risk with octogenarian age and frailty, had aortopathy, 5 centimeter aorta. And unfortunately, even despite careful pre-dilatation and underfilling of the TAVR initially, we ended up with root hematoma and pericardial effusion. This case was performed by Raj Makar, who very quickly aspirated, and patient had a good result. But we again looked at computer simulation, and perhaps this could have been modified by aortic root tricuspidization with leaflet splitting. So this was looking at the blinded simulation with Darcy simulation, and you can see area of increased wall stress under the left main, which is in fact what we saw in this particular case. But even if you don't have immediate complication, we have found in our clinical data that if you have bicuspid under expansion and eccentricity, it is associated with increased mortality, but interestingly is associated with very, very high rates of halt. You see in this group where you have both under expansion and eccentricity, almost 60% halt in this very large 300 patient series. This case, looking at it, we describe it as intermediate risk because the opposing leaflet was not severely calcified, but as you see, the raphe is severely calcified. And in this case, although we had a very good immediate result, we had under expansion. And we're starting to look at this as a model. You can see here the severely calcified raphe, and in the model, the volume, we can measure the volume of the raphe, and we're trying to use this in a predictive model. And effectively, we demonstrated that the increased raphe volume and total volume was very predictive of heavy calcification. So here you see bicuspid aortic valve leaflet modification with concept of using basilica, and in fact this was a case performed by Danny DeVere, and you see here basilica performed with self-expanding valve, and in fact this was not a downsized valve, and despite very severe aortic valve calcification, you see a well expanded and non-eccentric self-expanding evolute valve. So I collaborated also with Dr. DeVere. I performed the imaging in this series, but this was performed actually in Seattle, where Dr. DeVere and colleagues performed 7 basilica cases with aortic root tricuspidization, which we describe as ART. And in these cases, 7 of the 7 cases, we had 6 that had very good quality CTs, and we could determine 5 out of the 6 had increased TAVR risk by our model. And in all 7 of them, despite the increased calcification, we performed only annular sizing, 2 with Evolute Pro and 5 with Sapien 3 valve. In the end, we performed not only CT pre but CT post, and none out of the 6 with high quality CT were underexpanded, and only 1 was eccentric, but actually this was due to a mechanical interaction with mechanical mitral valve. As you can see here posteriorly, the eccentricity was due to that and not due to the bicuspid aortic valve. So we're proposing this new paradigm based on the bench testing and also early clinical experience of bicuspid aortic valve leaflet modification with mechanical splitting, and the putative benefits are reducing the TAVR risk of the patient, but also enabling larger TAVR with no need for downsizing. And you can see in these cases, potentially even in low TAVR risk, where you have a tissue bridge with the raphe, you may have some possible benefit. Where you have more calcified cases, like this case done by Dr. DeVere with self-expanding valve, there's a likely benefit. This case where severely calcified raphe, there's also likely benefit and potential for annular sizing. But in certain proportion of cases we can also reduce the risk of very severe complications like aortic root injury. So in conclusion, THV deformation is associated with worse clinical outcomes. Bicuspid morphology is a risk factor for THV deformation, especially with calcified raphe and leaflets. Pre-TAVR BAV leaflet modification may optimize TAVR expansion with improved ellipticity, opening area, and hemodynamics, potentially reducing the risk of root injury and enabling a larger TAVR to be implanted. With the increased use of TAVR in patients with bicuspid aortic valves, lifetime management of this population is critical. And either we call it ART or BAV-LM because maybe you can do more than one split and create even a quadricuspid route rather than tricuspid. It could contribute both to optimization of index procedure and improve coronary reaccess. Finally, further clinical evidence is required to validate the concept of splitting bicuspid aortic valves prior to TAVR. Thank you.
Yeah, okay. Thanks, Dr. Yohei. I think there might be questions.
Yes, it is a really genius thinking. It's a fantastic concept. I totally agree. And what is the cerebral protection for the basilica in the native, especially in the bicuspid valve, because it's a cut of it, it's a lot of tissue and a lot of calcium. So there is a chance of the emboli. It's a stroke incidence may be higher. And what is the main purpose to your procedure? Is that just increase the valve area or improve the eccentricity itself? And finally, in the on-site, we doing such kind of procedure, we need some cutoff value. If how much improve the eccentricity is that I do the shortcut, but the extent of the shortcut is different in the different operator. I did a shortcut, but what is the final result is we need some cutoff value.
Yeah, I think all very valid questions. This is preliminary data, both in bench and clinical. I think with all leaflet modifications, typically we are doing cerebroembolic protection, at least from concern of potential embolization. The 7 cases performed were very favorable. Actually, other centers in US are starting to do this. Other center doing it is Long Island, St. Francis Hospital. And in some respects, doing a shortcut or basilica in native is a little bit easier in some respects than for either in redo TAV or bioprosthetic AVR, because the dimensions are larger. You know, sometimes we have some difficulty navigating small frame with the shortcut device. The reason I like the idea of shortcut is potentially you can do multiple cuts. When you're doing basilica, it's quite difficult to do multiple cuts with basilica, but you know, it still remains to be seen how if we can do this in patients very easily with shortcut. And we are waiting for the Shortcut Pro, which the cutting is more complete and doesn't require back tension. Right now, our current shortcut cutting is predominantly through a back tension. You put back tension on the device, and that's the mechanism. But the later shortcut has a more a sharper blade, and I think is more likely to achieve a more straightforward cut.
Dr. Yohei, in my mind, the most important factor that prevents THV from full expansion in bicuspid valve is calcified raphe. But for leaflet modification, usually what you can modify is the non-calcified part. So do you think this could be effectively change the response of the raphe to the THV expansion?
Yes, we saw this both in the clinical cases and on the bench, because you are cutting adjacent to the raphe, and the raphe actually will move with the other leaflet. So if you, for instance, if you cut in the adjacent to a left-right raphe slightly to the left, the raphe will move with the right leaflet. So certainly you are not cutting in the raphe, you are cutting adjacent to the raphe.
Okay, thank you, Dr. Chirahawi. I think because time is constrained, so we're going to move to the last talk. This talk will be delivered by Albert Grube. I think Dr. Grube is an old friend of all of us, so no any introduction. So the topic is at the crossroads, transforming TAVR from a safe and doable procedure towards precise medicine. Welcome, Dr. Grube.
Yeah, thank you very much. And obviously, first of all, I would like to thank all my friends here for this very, very generous invitation. I rushed over from the meeting in Germany to be back here. And I will never forget the French dinner last night. And believe it or not, I drank a lot, but I'm very sober today. So I'm actually able to give my presentation. I hope you find this presentation somewhat entertaining and particularly exciting, moving forward. And the title is a little complex, I think, at the crossroads. And when we are at the crossroads at TAVR, it means that have we done anything, or are we looking into the future, transforming TAVR from a safe and durable procedure in the past towards precision medicine? These are my disclosures. So the road we took so far, start of an exceptional journey, treating the untreatable. For many of you that are younger, you don't experience and you don't know this time, but many people, when I started this together with Ellen Cribier, they saw me in jail because they said this is an unethical procedure and surgery is good enough for all patients. TAVR rode towards a standardized mainstream therapy. That's what we did. Next stop on the road, young patients and longer life expectancy. So the road ahead, a crossroads moment in young and otherwise healthy patients, is just safe and doable, still good enough. TAVR 2.0, multi-parametric precision, is in procedural planning and execution for future-proof therapy. Everyone knows this, the pioneering solution. Most reviewers back in 2002 said, TAVR will never work. It is a stupid and unethical idea. Surgery is good enough for all aortic stenosis patients. That is what we faced in 2002, 2004. The rest is history. The undoable procedure, published as a special report in Circulation, now cited more than 5,000 times, reviewing and reimagined daily by many thousands more. The journey of evidence is summarized on this slide, basically with two platforms, balloon expandable and self-expandable, across the risk spectrum. TAVR is either superior to surgery, particularly in the red zone group, or equal but never inferior to surgery. We've proven this in randomized trials with two platforms. Also, the journey of clinical practice. In line with the positive trial data, TAVR experienced a rapid growth and a constant rise of procedural numbers. The expected growth rate until 2030 is 300 TAVR will move towards younger patients. The median age of TAVR is continuously decreasing, and especially in those younger cohorts below 70 and below 65 years, numbers are on the rise. Correct or not correct, only future will tell. Beyond mere low risk, TAVR will move towards asymptomatic severe aortic stenosis, symptomatic moderate to severe aortic stenosis, and moderate aortic stenosis with cardiac damage. And you can see here, even in the developed countries, in the fast-growing countries across the globe, looking at all aortic stenosis with supposed clinical relevance, a vast undertreatment is still present, and these will be the main patient groups we address in years to come. So the road we took, treating the untreatable, we did. The road towards a standardized mainstream therapy, we did. The next steps of the road, let us see, and that are the crossroad moments of TAVR in the future cohort. Safe and durable procedure to durable and precise place of therapy. So I do believe that the modern TAVR procedure of the next decade will be performed in a whole different patient collective, and safety alone will not be good enough anymore. THV performance in young, active patients, durability and redoability will be key standards of a successful procedure. Let's discuss how procedural planning and execution can impact on these above-mentioned aspects. Let's define the cornerstones of such TAVR 2.0. TAVR 2.0, procedural planning. Contemporary pre-procedural CT analysis will have to be incorporated. Predictive markers of success and device performance, such as annulus and root geometry, calcium patterns, plus stroke risk, ppm calculations, and PVR prediction. Patient individual simulation of different devices implanted may actually guide device choice. It might help picking the right device for an individual patient. Digital twins help predict exact interaction of device and anatomy, for example, aortic root with calcium. Also, a consistent potential roadmap for AVR sequencing in young patients who might outlive his first implanted bioprosthesis are important. Lesion preparation and stent optimization, and we've heard this before. Detailed follow-up of implanted TAVR prosthesis revealed that stent frame underexpansion and eccentricity are correlated with increased rates of THV leaflet thickening and potentially thrombosis and more leaflet pinwheeling. Also, increased rates of actual clinical events, especially strokes. And finally, higher rates of earlier THV degeneration. We have to prepare and optimize the frame. However, careful assessment could also show that effective post-dilatation optimizing stent frame expansion could mitigate all those negative effects. Significantly less underexpansion in self-expanding, post-dilatation, and less pinwheeling after balloon expandable double tap. So, similar to what we have learned in coronary stenting, the lesion needs to be prepared and the placed stent needs to be optimized for ideal flow through. For an optimized THV 2.0 procedure, this will mean preparation of the calcium and optimization of the implanted THV, not only following PVL, but beyond that, achieving most ideal expansion in every case for best function and durability. Reliable coronary access. Preserved coronary access has been identified as a key issue of TAVR in narrow anatomies and especially in many TAF and SAF and TAF and TAF scenarios. Coronary access depends on multitude of parameters such as design of the first-second valve, implant depth and leaflet overhang, and functional neoskirt. In many cases at risk for coronary obstruction, chimney stenting has been introduced and widely adopted as a simple countermeasure. However, while preserving flow with an easy-to-use off-the-shelf trick in patients more than 80 years, that might be sufficient. Is it still good enough in younger patients, likely needing PCI and repeat procedures? Probably not. In many cases, these stents will be crushed, and while flow is preserved, access is impossible. Only using advanced measures such as leaflet modification, likely needing dedicated devices for broader adoption, easy coronary access can be and should be preserved. Preventing acute coronary obstruction during the procedure using off-the-shelf measures was a sufficient solution in elderly, high-risk patients. In TAVR 2.0, preserved coronary flow needs to be upgraded to truly reliable coronary access. Advanced techniques and likely dedicated devices will need to be integrated into the interventional portfolio to reproducibly achieve this goal. Alignment: only after more than a decade of active TAVR practice, we became aware that all prostheses were randomly aligned with respect to the native commissures. While in recent practice, alignment was nice to have, helping with coronary access, its potential implication reached far beyond that in younger patients. Dedicated innovation and device iterations will help us to achieve reliable commissure alignment across different platforms, some of them summarized here. So, TAVR at the crossroads, from doable to precision medicine. TAVR has revolutionized the treatment of aortic stenosis patients. TAVR enabled to treat the untreatable and provided a solution for high-risk patients. A sequence of trials then established TAVR as reliable across all surgical risk profiles. Now, a new frontier in TAVR therapy rises. Younger patients at earlier disease states. In this whole different patient collective, safety alone is not good enough. We will need a toolbox to enable best THV performance, durability, and redoability, precisely matching each patient's individual given factors and needs. Procedural planning to predict device interaction and potential sequencing, lesion preparation and stent optimization for optimal THV performance, transforming preserved coronary flow into reliable coronary access if needed with dedicated tools. Achieving commissure alignment as base for sequencing and new native flow profiles. This recent learning of alignment, which we made only during the continued course of TAVR practice, exemplifies we need to stay humble, open, and ready to learn. There will be many more key procedural parameters and techniques we do not even think of as of now yet. With that, I would like to thank you again for your attention, and again, thanks for the invitation. I'm very honored.
Thank you, Dr. Grube, for the wonderful talk. Any question, comments? So obviously you were far away before us, so maybe. Oh, yeah.
Thank you, Professor Grube. I'm Dr. Lee, a cardiac surgeon. So since you talk about the crossroad of TAVR, so what's your suggestion for the surgeon? Is there any suggestion? Maybe we should create a good, feasible condition for the maybe TAVR in surgical valve. So is there any suggestion you tell the surgeon? Yes.
Well, I can tell you from my own experience, TAVR, surgery has been pronounced dead from the many early days, but they're still alive. And much more important, the patient population has changed. But I think now, instead of being opponents, now we're really partners. And I think that was an educational process along all the line. But I think now we do have in individual cases, surgeons are busy in the operating room. And interventional cardiologists, hopefully, are busy in the cath lab. But there are always patients, individual patients, that should really be discussed, which, for example, and I can give you some examples, the routine work right now, nobody cares whether the surgeon is doing or the interventional cardiologist is doing. The so-called heart team stuff is very, very, very important, but you don't need to be in the cath lab in order to support the interventional cardiologist, nor we should be in the operating room to have our eyes on the surgical implant. So basically, I think the decision, and as we matured the field of TAVR, I think the discussion in borderline cases, I should say, particularly when it comes to younger patients, then I think we should really be careful just moving straight forward into young age. I think, and I just come from a discussion in Germany between surgeons and interventional cardiologists, patients with 65 years. 65 years for TAVR is pretty young. And the number of bicuspid aortic stenosis patients also increase. We're doing it daily. Are we doing, and not everything that we can do, we should do. And I think that's a very important aspect. So there's a lot to do in the future for surgery. And we are still in TAVR, we are still having many gaps to close. We don't know the answers yet. Even with Hsin telling us about the modification, that is beautifully shown whether or not that will change really our practice. It won't be with shortcut. Number one, it is extremely expensive in the United States. This device costs $18,000. So there will be much more to come, only if these devices are accessories and for broader use, then maybe we can think of cutting it and making the prosthesis more circular. Whether or not that really translates into issues of durability remains to be seen. We have some indications for that, yes. But I think most importantly now that safety alone is definitely not enough. We have to do better in these days than just trying to be safe with low complications.
Okay, thanks, Dr. Gruppe. In the interest of time, we have to close this session. I think in this session, we have stepped out of the safety comfort zone, and we addressed a lot of challenging issues. I think it's very insightful. So thank you, the moderators. Thank you, all the panelists. Thank you.
We are about to start to the section 6, live transmission 6.
Good afternoon, ladies and gentlemen. I'm Dr. Lee from Zhenxing General Hospital. Professor Yin has another duty, so I replace his position now. So it's my honor to co-chair with Professor Ko from Korea and our distinguished panelist, Professor Si Junze, cardiac surgeon from Wang Hospital, and Professor Wang Qihong from Kasei Hospital, cardiologist, and Professor Huang Zhengyi from Chang'an Memorial Hospital, also cardiologist, and Professor Chen Junji from Cheng'an Memorial Hospital, and Professor Men from Thai, and Professor Mi Chen from Switzerland, cardiologist, and Professor Du Zhongming from Far Eastern Memorial Hospital, cardiologist. So today, the first section is live transmission from Zhenxing General Hospital. So Professor Cao.
Yes, Dr. Lee.
Yes.
How are you?
You are online. Yeah.
Okay.
Please
Thank
go
you.
ahead.
So good afternoon. The doctor beside me is Dr. Tsai Jia-Ru. He will present the case. Before Dr. Lin. Okay. Before the start of the procedure, I would like to introduce our team. Dr. Tsai Jia-Ru, our case lab technician nurse, head, Xu Jinxuan, and nurses. And today's image imprinter is Dr. Lin Huanqiu. And Dr. Lin will present the case. Dr. Lin, please.
So thank you, Professor Cao, and audio expert. Now is our live transmission case. Next. So here we came across with this 74-year-old lady who suffered from shortness of breath and chest tightening for several months. She's a small lady which is only 156 centimeters in tall, and her body weight is 61 kilograms. So her body surface area is 1.6, and she has been diagnosed with critical aortic stenosis, which aortic valve area is only 0.7 square centimeter, and with a functional class 2 congestive heart failure. Her comorbidity including double. Sorry. We'll readjust. Sorry. What? Okay.
Wrong slides.
So the slide is a little bit wrong. So we will restart again. So I apologize for this. So our case is a 91-year-old female, which is a very small lady. Her height is only 142 centimeters in tall, and she suffered from functional class 2 heart failure syndrome for several months, and also lower limbs edema. So she has been diagnosed with critical aortic stenosis, which aortic valve area is 0.5, including comorbidity, including mitral valve severe regurgitation and massive tricuspid regurgitation. Her coronary artery disease was not very significant, only 50% stenosis at middle portion of the LAD. And also she has a chronic lung disease, FEV1 on 0.8. So her calculated STS score is 20%, which is a very high surgical risk. So as you can see on the transthoracic echo, we have discovered there's a severe degenerative mitral valve caused severe mitral regurgitation. And the transaortic valve mean pressure gradient was 41, and the peak pressure gradient was 71. So this is a severe aortic stenosis cases. The current angiogram, as we have mentioned, there's only 50% stenosis at the middle portion of the LAD, just below the major diagonal branch, and all other vessel was patent. So the multi-slice analysis shows this is a small annulus. The area is only 353 square centimeter. The parameter was 68. The LVOT size was only 22. The sinus valsalva diameter is around 29 millimeter, and the STJ diameter is only 26. Both coronary height was adequate. The left main coronary height was 14, and the right coronary artery was 16. Lifted length is only 12 to 13. So there were no coronary obstruction risks in this case to perform the TAVR procedure. The length of the membrane statins was 1.5 millimeter, and there are very few calcium, only 134 cube millimeter. So as you can see, we put the simulation. This is the 26 WFX plus for simulation. Both valve to coronary distance and valve to STJ distance was enough for left main and also the right coronary artery. And there was no significant peripheral artery disease. Our access will be fine. However, as you can see on the 3D reconstruction, there's very tortuous descending aorta and also the abdominal aorta. There are two angulation. So this is our challenge today. And also the aortic angulation was 56 degrees. So our plan to do, we would like to use 20 French large sheaths and a long sheath to cross the two angulation to the ascending aorta, to the very upper portion of the descending aorta. And also we will use a 26 millimeter avalute access plus for this TAVR procedure. Thank you.
Okay. This old 91 old lady, it is quite short, quite short. And she's a little kyphosis, and so I think and also the horizontal aorta, and as we know, the horizontal aorta is frequently associated with tortuosity of the aorta. So for this patient, I would like to hear all the experts' opinion about the management of this case.
Yeah, I'm Young-Guk Ko.
Yes,
so I think in this case, balloon expandable or self-expandable, I think any platform can work very well. But according to the information provided, the membrane septum length is 1.5 millimeter. Is that correct? So then there is a concern about potential conduction disturbance after TAVI procedure. So in that case, balloon expandable shows lower risk of complete AV block. You have chosen self-expanding valve. So what do you think about the potential risk of complete AV block in this case?
Yeah, the risk is present because quite short membrane septum. But this lady, the annulus is small, so we rather choose self-expanding valve. And also, this is our main reason. Yeah. And any other comments?
Okay, for the small annulus and the low risk of coronary accesses, I think maybe self-expandable is better, can get a larger EOA, but maybe consider high implant, maybe avoid the PPM, maybe.
Also, I'm surgeon. Yeah. I'm Dr. Shi, because yes. This patient associated with severe mitral regurgitation. So, what are you planning? What do you expect after this TAVRs, and then what are you planning for the severe MR?
Yeah, the patient's age is quite old. Then our plan is for this kind of disease, if the patient is not undergoing surgery, and we normally treat the aortic valve first, and then after TAVR, and we can follow the severity of MR and the TR. And if probably in some cases the MR and TR the severity will be decreased. But if there is still severe MR TR, then maybe we can use another transcatheter method like MTEER or TEER for this kind of patients.
Professor Tu.
Because of the horizontal aorta, would you do the BAV before you implant the valve?
Oh yes, thank you, Dr. Tu. Because the calcium is not so much, and for horizontal aorta, no, if the aortic angulation is too sharp, normally we would like to use a snare to help the procedure, and this patient has very tortuous aorta, so we plan to use longer sheaths, dry sheaths, which is 20 French, 65 centimeter, and to avoid initially to avoid crossing the aortic arch, we just park the tip of the sheath and close to the arch, but because sheath is too short, the remaining segment outside the body is too long, so our working length for the evolute is inadequate. Therefore, we have to close the arch, and we also can use so-called body wire. But actually, we prefer this method. And for the evolute, they provide the 18 French sheath, which is 33 centimeter in length, but it only can close the first band, and so we still worry about the advancement of the valve. Therefore, we choose longer sheaths. Can we, because the transmission time is only 30 minutes, so can you show the first? Please show the first image. Okay, this is for Sentinel. Next one. You can see it's quite tortuous at the lower abdominal aorta. Next one. Next one. Just showing this is for pigtail from the groin, and we use small long sheaths. You can see it's quite tortuous. Next one. This is for Sentinel. Next one. Next. So advance the extra-stiff, super stiff wire for the advancement of long sheaths. Next one. So this is a 20 French sheath, dry sheath. Initially, we just packed over there, but I think the working length is inadequate. Next one. So we advanced the sheath, which is quite smoothly advanced to the ascending aorta.
And what kind of wire you used to support the sheath?
Super stiff wire.
Super stiff. Thank you.
For horizontal aorta, sometimes we use this method, and to get the better coaxial of the supporting wire, and by using this method, we would not use snare again. We can close the valve quite smoothly. So this is where we are, and we close the valve, and this is a safari, and we are going to advance the device. Right, 3点钟. Okay.
Dr. Chao, the general anesthesia is routine anesthesia in your hospital?
Yeah, yes, it's our routine, yeah. So you can see the valve can be advanced without too much resistance. Let's see. It's quite...
Dr. Chao, since you use the long sheath, so the evolute can maintain the good commissural alignment under the long, within the long sheath.
Yeah, we will check, because you can see the head marker is at the outer curvature. So I think at this moment it's okay. And then after closing the valve, cusp overlap. OK 哈。可以，嗯。Give me the wire, please. There's some resistance of the pigtail. I just reposition of the pigtail.我看不清，放大一下来，打去那个。
So in which cases do you use this kind of long sheaths? Patients with horizontal aorta too, or only patients with tortuous aorta?
Yeah, I think for the very tortuous aorta and horizontal, if we use the snare, then we probably don't use this long sheaths. And if we use the long sheaths,
Dr. Chen, you have the case with TAVR or covers aortic stent graft surgery before, then you use the long sheaths to transport the device.
Yes, exactly. When we also have the TAVR access, we will use the longer sheaths, makes it easier. Also, we have another case we use it because it's a degenerative, the trifecta. We have the difficulty. Also, big tortures have difficulty to retrograde crossing the valve. Also, this long sheaths, maybe not gore, a triple one destination will also work to help you to maneuver the catheter retrograde crossing.
Because this the patient only had a little calcium, therefore we would deploy this valve slowly and use pacing the whole procedure. 慢慢来，慢慢来，等等，慢慢来。等一下，我照个相看看来。I think this position, this step is fine. Okay. Good. Pacing off, yeah. And parallax. Then we use RL to get the parallax view. Nè, 对好，这样对好吗？没有对好，对好。Do you accept the depth? Is it too short? Too high? Or
how about the panelist comment about the position of the device?
Bit high, huh?
Men?
It's a little high, but I would take a quick pictures because sometimes the pigtail is not at the bottom of the cusp. Yeah.
I think it's too high. Yeah.
Yep.
Maybe. So whatever.
Would recapture, maybe partial recapture, and then deploy it again.
好的。不要太多，我慢慢推你。这样 OK 了哈 ，OK。没有，这 OK 好，这样哈，好，照相啊。Better. Can you go back to come back to cusp overlap? 啊，偏高哈。OK. Check with count. OK， 放大一点点。Usually. What do you think? I think it's still a little bit high, right? So maybe we 回到刚刚那个好了。Maybe we reshift one more time and make a deeper position. 对中间来说，慢慢的，对，你再说吧，你再说。对 ，OK， 对，这样呢，好，来放，可以，这样可以，可以。我要 neutral 了哈。It's better. Okay. That's enough. 可以了哈。What do you think these steps?
Yeah, I think it is okay. So on the, I think LCC is a little bit deep, but I think still it's okay. So it's better position than before.
Yeah.
But we can see the conduction via QRS complex.
Okay.
Yes.
The blood pressure is low now.
Dr. Lin, can you show the T?
Okay. Okay.
Is the depth okay?
Yeah, the depth is okay. Yeah.
Okay. Okay, maybe we can accept this depth. So we are going to deploy the valve. One rapid pacing. 180. Since this only little calcium, so we deploy the valve with rapid pacing 180 BPM. Okay. Okay. Pacing off. We move. We take out the nose cone first. Okay. Yeah. Okay. Dr. Lin, please show the echocardiography, the T.
Okay. So now it's the long axis view. As you can see, the valve was expansion pretty well. There's only minimal paravalvular leak, but we can see there's the severe mitral regurgitation. Okay, so now we will see in the short axis view by using the X-plan. The commissure was pretty aligned. The pulse was around the 4 o'clock and maybe 11 to 12 o'clock over here. So this is the commissure alignment for the left main coronary artery. And the valve expansion was still in oval shape, but I think it's okay. Two minimal paravalvular leak over the 7 o'clock and also the 3 o'clock. So,
yeah. So what do you think? Will you do the post-dilatation?
For this 91 patient, no, I won't do the post-dilatation. Yeah.
Okay.
How about Professor Zheng on the procedure? Will you do the post-dilate?
No, I think the result is perfect. So I will leave it.
Yes, I'm the same, but I want to ask Dr. Ying-Hwa Chen, can you see the valve already touch the membrane septum or not?
There's some attached to the septum, but I could not confirm their significant contraction with the membrane septum. Yes.
But now the current ECG is bundle branch block, so maybe it could be transient. So, but there's no conduction disturbance, and the blood pressure is fine. So I think, because no calcium and the expansion of the valve is acceptable. So I will not do the post-dilatation.
I also agree. So the valve is so well expanded. It shows a round shape, and I think only minimal palpable leg is visible. And the ECG shows a widening of QRS complex, and additional post-dilation may cause complete AV block. So in this case, I think I would be happy with this result.
Yeah, so we show you the autogram. Right. Can you see it? I think that's only mild artery regurgitation, and the implantation depth is about 5. Yeah.
Excellent result. Yeah.
Any comment or question about from the panelists? So, Professor Chao, because we are a little bit behind the schedule, so thank you for your great presentation in this specific patient with a very tortuous aorta. And you use the long sheath and put the sepsis expandable device for 91 patient. The result is quite good. Thank you very much.
Thank you. Thank you.
Thank you. So, yep. So because Professor Ko have to catch the flight, so we have to move we change the schedule. So everybody is quite familiar with Professor Ko from Korea Surveillance Hospital. So today he will deliver a very interesting talk and hard talk about the ICE-guided TAVI experience sharing from Surveillance Cardiovascular Hospital, Yongsan University Health System. Please.
Thank you very much. Today in live case, we see the general anesthesia as a routine anesthesia, but in many centers these days, we perform TAVI under MAC. So why do we need echo imaging for TAVR? Definitely we need to assess the procedural results, especially the severity of probable leak, whether we need to have post-dilation or not. And also detection of complication is very important. So if the patient shows blood pressure drop, then we need to look for causes of hypotension. But if we have MAC anesthesia, then actually the common imaging guidance is transthoracic echo, but it has limited window and the limited quality of imaging, especially when patient has a supine position, and also if the patient has a obese body stature, and also especially when the patient has a COPD. So for have better imaging guidance, in our center we applied intracardiac echo as a routine imaging guiding. Definitely the limitation of the eyes for imaging guidance during TAVR is the high cost, and also we need to have learning curve, and this is also invasive imaging procedure. However, but the advantage of the eyes is that we don't need additional sedation, and it shows excellent image quality. And also we can have a continuous monitoring, and sometimes we don't have to have imaging specialist if the operator is experienced. And we don't have this 3D imaging, but in near future we can have the 3D imaging. The value of 3D imaging is not known, but I think it is an interesting tool. So currently, 2 systems are available in Korea, acute nerve system and ViewFlex. These catheters are, I think, comparable, but as I said, in the new future, we can have the 3D eyes. So the role of 3D eyes is, as an imaging guidance for TAVI should need to be investigated. When we show the eyes images, I think there are 2 basic eyes views for TAVR. Longitudinal view showing the longitudinal axis of the aortic root, and especially for the detection of probable leak, we need to have a short axis view like this. So, and I'd like to show several cases. This patient has some severe calcification in aortic valve. And here we did the predilation with 20 millimeter balloon. And this can be monitored with the intracardiac echo. As this is the bright material is the balloon. And after that, we inserted 29 millimeter Evolut Pro. And after implantation of Evolut Pro, we need to see whether there is a significant amount of palpable leak and whether we need to post-dilate. As you can see here, the palpable leak, this jet, can be detected by eyes. And also in short axis, we can see the valve is not fully expanded. It shows a D shape. And here we can see the palpable leak. And so after seeing this, we decided to perform the post-dilation. With the rotational fluoroscopy, we can also see the degree of the expansion of the valve. And with this information, we decided to perform post-dilation with 23 millimeter balloon. And we can see also in cardiac echo the inflation of the valve and the expansion of the valve during the ballooning. And then we check that palpable leak with the eyes. We can see the amount of palpable leak has significantly reduced in short axis and also in longitudinal axis. However, this was the TTE was performed later, but in this view, it is difficult to find. The resolution is inferior to compared to eyes, so the imaging quality is different. So another case, this patient in this patient shows also calcified aortic valve, and the valve was implanted a little bit high, and since the valve was not fully expanded, we performed balloon post-dilation, and then the valve was further expanded, but the anchoring location appears to be a little bit high. So the question is whether it is okay or we need to have second valve. And we look at the eyes. This was the post-dilation, and you see at 7 o'clock, 7, 8, you can see the palpable leak. And after post-dilation, there is still mild to moderate palpable leak, but I think we can see that there was no severe palpable leak. So I think this is very old lady, and we can leave it, and so we did not perform second valve implantation. But again, in TTE, we don't see that much palpable leak, and in also long axis, there is some palpable leak, but it is difficult to evaluate, assess the amount of palpable leak after TAVI procedure by using TTE. So another case, this is a case we treated the balloon expandable valve, and we did additional ballooning using double tap technique. That means we use the same volume for optimize the result of the valve implantation. And after the double tap, we don't see no significant amount of palpable leak. And on intracardiac echo, you can see after first balloon implantation, there was some mild palpable leak between 10 to 1 o'clock. But after double tap, the palpable leak has significantly reduced. So we can see better the result of double tap using intracardiac echo. So we can also monitor the complication of the TAVI procedure. In this patient, we see some calcified nodule. So we performed the TAVI using balloon expandable valve. And after implantation valve, actually there was some leakage of dye here, very small amount. But this patient showed on eyes the tear the flap, and I think this is the aortic dissection caused by the calcium nodule during valve implantation, and also these patients developed pericardial effusion. So with using echo eyes, we can immediately detect the complication of the TAVR procedure, and we can manage the complications immediately. So the eyes provides excellent image quality and continuous imaging guidance without interfering with the intervention during TAVR procedure. Eyes enables rapid assessment of TAVI results and prompt management of procedural complication. Eyes can be operated autonomously by experienced interventionists. Thus, eyes may help guide TAVR, especially in patients with complex anatomies. However, the high cost of eyes and the steep learning curve required for this operation remain limiting factors for its routine use in TAVR. Thank you for your attention.
Thank you, Professor Ko. Is there any comment from the panelists? Professor Shi? Yeah. Professor Xu.
Thank you, Professor Go. And what is the optimal eyes probe position for the short axis view of the TAVR? Could you recommend?
Yeah. Let me show you. Here, you can see here the post-reflection of the eyes catheter, and I directed the catheter into the right ventricle, and then I rotate the catheter into the alveoli. So with that, the maneuver or the directioning of the catheter, we can better see the short axis of the valve. Yeah.
Okay, I just wondering, very interesting about the last case. What's the outcome and what's your decisions to for the dissection? And the second question is that any complication or should be watch of this eyes the complication?
Yeah, actually we have experienced only one case of pericardial the perforation, the pericardial effusion by the managing of the maneuvering of the eyes catheter. But otherwise we have no complication related to use of eyes. The last case was managed by the surgery. So we sent to the patient the surgery, and the patient recovered. Yeah.
Professor Chen, next question.
Yes, Professor Go, from your experience, I saw some operator prefer eyes from the jugular approach. So from your experience, from jugular or femoral is better?
Yeah, I think it's for the convenience of the procedure. We prefer to use a femoral approach, transfemoral approach, because if we have a transjugular approach, then we need another, the operator who manages the eyes catheter. So then I think there is no difference between, it's for the convenience of procedure. It's better to have the catheter through the femoral vein.
Okay, thank you, Professor Ko. I believe if we have a 3D eyes, they can provide more information, especially in TEER or mitral procedure. So let's move to the let's talk. The last speaker is Dr. Liu Junting. Liu Junting is a well-experienced pediatric cardiologist, and we invite her to our hospital, Cheng-Chung Cheng Hospital, to do the radiograph, especially when you do the structural heart therapy. We depends on her experience quite a lot. So today she will give a talk about the CT planning in valve interventions. Please.
Thank you, Professor Lee. Good afternoon, ladies and gentlemen. I'm Cheng-Chung Liu from Cheng-Chung Cheng Hospital in Taiwan. Thanks for having me. Today, I want to walk you through a case that really highlights the complexity of lifetime management in TAVR, specifically the nightmare scenario of delayed coronary obstruction after a redo TAVR. So we're looking at a 73-year-old lady who come to us with progressive chest tightness for 3 days. She had a very complex cardiovascular history. She had severe coronary artery disease with multiple previous PCI procedure involving both the LAD and the RCA. She's on regular hemodialysis for ESRD and a baseline STS score of nearly 37%. It's a very extremely high surgical risk patient. And back to 2020, she had a 26 millimeter LVR for a critical AS. So fast forward 4 years, she's back in the lab with prosthetic stenosis. We ran for a CT analysis to plan the redo and found that the initial evolute were underexpanded. The landing zone dimension ranging from 19.4 millimeter to 21 millimeter. So if we plan to do a short in tall redo TAVR, we suspect the downsize of balloon expandable valve would be an option. So that's why we will choose the 20 millimeter SAPIEN 3 valve. The ideal implantation strategy was to position the balloon expandable valve with its outflow below the coronary ostia. However, the small VTC and the small VTSTJ were major red flags, placing this patient at a high risk for sinus sequestration. So on top of that, expansion of the balloon expandable valve could further enlarge the previous evolute frame, making the coronary obstruction even more concerning. So as we know, we want to perform the leaflet modification as called as the unicorn procedure for the left coronary cusp. However, we still worry about the potential upward TAVR valve migration during deployment. If that happened, the new skirt could end up above the coronary artery plane. Combined with further expansion of the evolute frame by the second valve, the risk of the coronary compromise would become even higher. So, given these concerns, although it's safe for the right coronary artery, we decide to proceed with RCA protection as an extra precaution. So our strategy would be pump through the left coronary cusp first and go to the RCA protection, then go back to the left side to complete the unicorn procedure. So we'll fast run through the unicorn procedure. We use AO1 and pigtail to aim at the target zone of the left coronary cusp. After a wire is passing through, we use pigtail, exchange the sapphire wire to secure the tunnel, and go for the coronary protection for the right coronary artery. Then go back to the left coronary cusp, do the balloon dilatation with 12 millimeter balloon. Okay, so after all the preparation, we're ready to do the unicorn of the left coronary cusp. We use 20 millimeter SAPIEN valve, slow stepwise inflation, control the position to keep the nail skirt below the coronary risk plane. We don't want it to migration upward. And after the unicorn, we do the post-dilatation to optimize the expansion. And we're grateful that the final angiography result showed the pattern of both right and left coronary artery. The commissure were very aligned, and the VTC of the left coronary artery seen pattern. The measurement is 2.5, and hemodynamic result was quite great. The mean pressure gradient is 6 millimeter mercury. Okay, shut down, sorry. Sorry, a little bit technical problem that we're solving, and thank you for waiting.
So I think it's a very interesting and educational case. But I'm cardiac surgeon, so I want to the interventionist how to deal with such a patient. I mean, to prevent the coronary obstruction when you do the TAVR in TAVR. So, Dr. Huang.
Sorry, it's back to life. Sorry. Thank you. I will go back to the PowerPoint, thank you. And 11 months after the reduced TAVR, the patient presented with a progressive chest tightness and was subsequently diagnosed with non-STEMI. The coronary angiography reveals stenosis of the right coronary artery at ostium, middle, and distal portion. Interesting that the ostial lesion appear highly calcified, fibrosis and compressed, raising the concern that the lesion of the right ostium may not represent normal scenario of the atherosclerosis. Okay, and the intervention was very technical difficult because the valvular frame. Also, we use and as well as the lesion was very hard to treat. So we treated sequentially with POBA, and POBA failed, and do the orbital atherectomy and failed. We do the NC balloon dilatation and failed. And so we go through the bailout standing of 2 drug stent and still compressed lesion and show the intramural hematoma and also the dissection. Luckily, the final angiography demonstrated a septal expansion with retorsion, but after all the hard work dealing with RCA ostium stenosis, we know that the lesion appeared more complex than calcification alone. And when we retrospectively review the imaging, we know that the second TAVR valve resulted in further outward expansion of the valvular frame. This case highlights an important consideration in short in tall reduced TAVR procedure is that the expansion of the first TAVR valve by the second TAVR valve may further narrowing the neo sinus. Recent studies have demonstrated that altered neo sinus flow after TAVR valve may substantially affect coronary accessibility and the re-interventional feasibility. And the neo sinus show information of the thrombus, extracellular matrix, calcification, and microvessel. And recent pathological reports have shown massive circumferential endothelial growth along the upper crown of the alveoli, leading to substration of the sinus valsalva with subclinical delayed coronary osteoobstruction. So this may explain why some patients present months or even years after TAVR with acute coronary syndrome. So the conclusion is our case suggests that progressive neosinus compromise and delayed coronary encroachment may also occur over time, particularly when the initial TAVR valve frame is further expanded during reduced TAVR. And thank you for attention.
Thank you, Professor Liu. So in the comment from the panelists.
Okay, we do some effort on the CD present, the second valve choice, the coronary preparation, just to avoid the acute coronary obstruction during the second valve, the valve. But for the etiology, for the day coronary obstruction, the etiology is uncertain. Maybe we can cause some many reasons. But the interstitial turbulent flow of the sinus valsalva to cause the turbulent flow and the atherosclerosis maybe is another reason.
So will you increase the anticoagulation drugs for such patient? I mean, valve in valve, and do you increase maybe use the dual antiplatelets or other drugs? Yeah.
Or dipyroid. Maybe, but no data support the
So, judging from the second angiogram, I think there's a total occlusion at this RCA. So I presume the second event should be acute coronary syndrome. So probably it's not totally depend on the occlusion of the transcatheter valve. So I think my question is, okay, in patient with severe calcified coronary artery with stenosis, just like this case, before TAVI, should we open the coronary first? Especially when you consider there's a high chance to and the difficulty for second access.
Thank you for your question. I think we, because the first procedure is done at 2020 and 2024 before I was in here, but I suppose they also discussed the same questions and they might prepare for both procedure, TAVR and PCI, and they might choose to do the simple first because it seems like the reduced TAVR is much more easier than the PCI. So I think the symptom might be improved after the reduced TAVR, and they see, oh, the PCI maybe can wait. We can do it later. So I suppose it might be this year. But thank you. Yes, it's a acute patient. Yes.
Okay, because time is limited, so we have to close this session. And thank you for Dr. Chao's live demonstration told us about her case, and the ICE device also is quite informative for the structural heart therapy. And Dr. Liu provided a case the mechanism of TAVR induced coronary leg obstruction. So thank you very much. And see you next year. Thank you very much. Yeah.
Now we will progress to this section. This section is talking about pulmonary artery denervation from mechanism to clinical application. I'm Dr. Zhongyi Zhang. I'm cardiac surgeon from Zhenxing General Hospital, and my co-moderator is Professor Chen Shaoliang, Vice Superintendent of First Nanking Hospital. And our panelists include Dr. Chen Yi-Chen, cardiac surgeon from Zhenxing医院, and Dr. Huang Wenbing, cardiologist from Zhenxing General Hospital, and Huang Jianlong, cardiologist from Zhenxing General Hospital, and Jimmy Hom, well-known cardiac surgeon from Singapore, and Dr. Chen Xiang from Xiamen, and Dr. Yang Jinggang from Huwai, Peking. And we also have the Dr. Okay, now we will introduce the first speaker, Dr. Chen Shaoliang. Professor Chen Shaoliang is a pioneer of pulmonary artery denervation, and today his talk is pulmonary artery denervation, mechanism, evidence, and patient selection. Let us welcome Professor Chen Shaoliang.
Thank you very much. Thanks for Zhenxing teams to invite me and for giving me such a big chair. So even the topic seems doesn't correlate very strongly with the main theme of the Taiwan valves, but I think after my presentation it will change your idea at all. So the topic of presentation is about the PADN, pulmonary denervation for pulmonary hypertension with different etiologies because we have had a pool of data. So I think it's the right time to get the mechanism analysis to prove from the evidence. And finally, I will briefly introduce how to select the patient. So I think this slide summarizes the current prevalence of pulmonary hypertension. According to the WHO report in 2017, so it's reported in 1% of overall population. So it's I think it's not a rare disease because of the huge population. So I think it could be 23 million people with pulmonary hypertension even in Taiwan. So according to the WHO definition, there are 5 types. Stratification for PH, group 1 pulmonary arterial hypertension, including idiopathic connective tissue disease associated as well as the congenital heart disease. The latter one is much common in developing countries compared to developed countries. Group 3 is relatively rare, but I think it's still also increased very much. Type 4 means CTEF is particularly increasingly very much in mainland of China. So finally, for group 5, I think there are many different etiologies or with unknown etiology of pulmonary hypertension. So far, there are 5 types of pH-specific medication for group 1 pulmonary hypertension. But you know, the group 2 pulmonary hypertension accounts for a great proportion of the patient with pulmonary hypertension. In the past many years, so the overactivation of pulmonary sympathetic nerves has been confirmed from bench and also from the clinical, evidenced by the increased rest heart rate as well as the increased muscle sympathetic activities. So this is why. So 25 years ago, beta block was prescribed for patients in daily practice because of the systematic side effects. So finally, beta block was excluded from the recommended medication. So next point is how to define the distribution of pulmonary artery sympathetic nerves from the slide on the left, right panel. You can see this is a result by my team. So almost 15 years ago, we identified the distribution of the pulmonary artery sympathetic nerves, so which usually starts from 1 to 3 galleons, just beyond the PA valve. So after 10 to 15 minutes, taken from the galleons, so three or more bundles will merge together, forming a bundle. So go directly to the distal end of main pulmonary artery. Once it reaches to the distal bifurcation area, so usually it will divide to branches. So later I will briefly introduce the distribution of the pulmonary sympathetic nerves. So from the over 720 corpuscle human bodies autopsy. So we identify, right now we are very clearly about the distribution of sympathetic nerves. From the figure you can see it starts from the 1 to 3 galleons, forming a main bundle. When it reaches to the distal bifurcation area, so dividing into a posterior branch around the proximal left PA, and another anterior branch highlighted by red color from the anterior wall main trunk to the anterior wall of right branch. Also, there's some connections between the posterior branch with the anterior branch. So, following the distribution, I think it could be easily to understand how to do PADN procedure. On the extreme right panel, you can see for almost 20% of the patient, because the data from our over 720 patient, 720 corpses. So some patient did not have the three branches forming the bundle. So only one branch from the left lateral side of the main trunk of pulmonary artery. And also just around the bifurcal area, there is a very large nervous plus. So this is why for some cases, immediate after the PADN procedure, so mean pulmonary arterial pressure could be reduced by 50 or even 60%. So this is the example of the typical case. So usually we need two projections of PA angiography, AP cranial with shallow LAO and cranial. So with the two projections, so it's easily to calculate, to measure the diameter of the main trunk of PA as well as the ideal location, site ABC for denervation. So after that, following the distribution of nerves, so it's easily to put the PADN catheter with a distal ring circular design with 10 electrodes pre-mounted onto the distal ring. So after several clockwise or counterclockwise rotation of maneuvers, so it's easy to get any 3 electrodes very tightly closed with the intima of pulmonary artery. So once we finish the bench and preliminary clinical study, so we designed and conducted our PADN 1, phase 1, PADN 1, phase 2, PADN safety, PADN 5, as well as the PADN PH heart failure 5 trial with 571 patients, including in those 5 trials. So I will briefly go through the introduction of 5 clinical trials. First is the PADN 1 phase 1 trial. It's a first-in-man trial, a study in 2012. So we only included 22 patients with group 1 pulmonary arterial hypertension, with 1 patient excluded from this study because of the positive acute vascular reactivity test. So finally, of 21 patients, 13 patients in the PADN group and the remaining 8 patients in the medication group. It was a non-randomized design. It's a film study. So we just to get the improvement in hemodynamic and 6 minutes walk distance, as I showed on the right panel. You can see by 3 months of follow-up, both the systolic and the mean pulmonary arterial pressure decreased by 30 to 45% independent of the etiology of the patient, with a significant increase in the exercise capacity. So you can see the 6-minute walk distance increased by almost 90 meters. So I was not confident or quite satisfied with the preliminary data from the film study. So we need to design 1 by 1 clinical trial to identify the safety and the efficacy of PADN procedure. So this is a PADN safety trial. It's a multi-center, 11 Chinese centers, randomized design with sham control procedure on the background of pH-specific medication. So the primary endpoint was a 6-minute walk distance change at 6 months follow-up. Also, patients were followed up until 1 year. On the right panel, you can see from the curve, you can see immediately after 1 month, so 6-minute walk distance increased in both groups. But after 6 months, so it decreased slightly in the control group compared to the PADN group. By 1 year follow-up, so the exercise capacity decreased in the sham group very much compared to continually sustained slight increase in the PADN group. I think this is very, very striking finding to encourage us to design next more clinical trial. Also, it provides the calculation for the sample size. So from the study flow chart, you can see we changed the assessment timing point according to the guideline. Once the medication initialization, we need to follow up 3 to 6 months. But for the clinical trial, we shortened the timing for the assessment, so we recommend to regularly, routinely follow patients at 1 month after randomization. after we finish the PADN safety, which was a very, very important clinical trial to get the final approved by NMPA in China, as well as the CE mark. And also it's almost mostly accepted by FDA. So I think it will be very, very important clinical trial. Next, we design our PADN-1 phase 2 trial. We need to identify the long-term clinical follow-up for patients with different etiology of the pulmonary hypertension. So this study included 66 patients who underwent PADN and also completed 1 year follow-up. So from figure, you can see we finally identified the 3 sites of ablation. So right now it's called 3 sites, good standard ablation technique. Also, KM curve confirmed if the baseline pericardial infusion greater than 10 mm, which will be very important biomarker to predict non-response immediate after the procedure. You know, PADN procedure totally different from RDN. So it means immediate after the procedure. So there is usually very striking reduction in mean pressure compared with almost no change of the blood pressure of the RDN. And also, from the bar figure, you can see after 3 months of follow-up, there was no further reduction in hemodynamic. It means after 3 months of follow-up, the PA remodeling was stable. So this is very important. On the right table, I think a very important striking finding is that through 1 year follow-up, so there was a very clear trend to show the dynamic longitudinal reduction in PAWP. As I said, we included 66 patients with different etiologies. Of them, 18 patients had group 2 pulmonary hypertension secondary from heart failure. So I do believe the dynamic reduction in PCWP could come from this patient with a group 2 pulmonary hypertension. So I think this is a very strong reason to telling us we need to shift from the group 1 PAH to group 2 PAH secondary from heart failure. So I think I also provide several reasons. Heart failure with the presence of pulmonary hypertension, I think further increase the worsening of clinical event. Even right now, there are some medication for group 1 PAH, but none has been approved by guidelines by FDA for patients with heart failure-induced pulmonary hypertension. Right now, by 2023, so heart failure affects almost 35 million patients. By 2025, it affects by 65 million patients. So it means there is a very quick increase in the prevalence of patients with heart failure, particularly the presence of pulmonary hypertension with heart failure further increased the cardiac death. So the pulmonary does not only as a link between right and left side. So for the overall analysis, we have to consider to use the PA coupling with the RV or LV. So from the left figure, you can see in patients with a decreased left ejection fraction, so the slight increase in endosystolic pressure in LV with a very, very slight increase in cardiac output. So this is so-called PA-LV uncoupling. Again, for patients with heart failure with preserved ejection fraction, the slight increase in the cardiac output will be associated with a significant increase in PAWP. So this is why diuretics usually could not reduce the PAWP very much. Also, before the design of a clinical trial, tried to identify which parameter could predict the long-term clinical outcome for patients with heart failure as well as the pulmonary hypertension. From figure, you can see there are multiple different combinations of the parameters. Finally, independent of the etiology of the pulmonary hypertension, so the RV-PA coupling restoration is the only one important predictor for the improvement of the patient with heart failure. And pulmonary hypertension. Also for patients with heart failure, also there is the presence of the we call the dead space ventilation. So it means much more oxygen but very less blood flow. So this is the key question. So also my team recently just published the correlation of the VMA, a very important metabolic product from non-adrenaline, as well as the non-adrenaline clearance in lung to predict the response of patient to PADN. So after that, we designed our one more pilot study, only included patients with half PEF with IPCPH. It means PVR is normal, but PM pressure and the PAW increase immediate after the pulmonary PADN with a longitudinal monitoring change of LV pressure as well as the PAWP. From figure, you can see the LV diastolic pressure increased very much. So it means the diastolic function in LV has been changed much more. So after that, several years ago, we have published our PADN 5 in JACC intervention. So this is also randomized study, a multi-center study based in mainland of China with sham control procedure to compare the PADN with the GDMT for patients with a group 2 pH with a PVR greater than 3 units. And the prominent point was also 6-minute walk change. So also, following 1 year follow-up, we provide a significant difference in terms of the clinical worsening. It's a base for the calculation of patient sample size for our next global trial organized by FDA. So based on our previous data, we designed our one more China pivotal trial. We have finished. So basically, we assumed the 1 year clinical worsening rate will be 24% in the GDMT group compared to 11% in the PADN group. So after the 1 year follow-up, we did identify the correlation of the baseline echocardiographic measurements, cardiac index, as well as the TAPS. TAPS is a parameter for the RV function. So if the CI greater than 2.0, TAPS greater than 13 millimeter, we could boldly predict the patient will get much more benefit from the PADN treatment. Also through 1 year follow-up, because for any heart failure randomized study, we need to calculate the number of repeat events. So this is called MCF curves. So it's clearly show in the GDMT group, each patient has the chance of 0.7 events through 1 year follow-up. So also for this trial, we also provide the multiple course regression model to identify the different combination of parameters to predict the clinical outcome. Finally, we define 3 domains. One is the PA domain, RV domain, as well as the LV domain to predict the response and the clinical outcomes. Finishes a brief introduction of our previous trial. So finally, I will introduce, because all data came from China. So some guy argue about the general reliability of the PADN procedure. So we organized the pivotal trial outside China from Europe. So finally, we included 30 patients with pulmonary hypertension induced by heart failure with increased PVR. It means only CPCPH. So after 6 months of follow-up, so right heart catheterization was redone to identify the mean pressure decreased by 12, PAWP as well. PVR also reduced very much, accompanied with a significant increase in 6-minute walk distance as well as the KCCQ. So finally, we provided the final result as I showed in this summary. Also, the outside pivotal European trial was presented at EuroPSA this year, last month. So I think my presentation could be useful for you guys. Once again, thanks for your learning, for your listening. Once again, thanks the Zhenxin team for inviting me again. Thank you very much. Thank you.
we will discuss after the second speech, okay?
Okay, thank you very much. So right now, let's move on to the second speaker. It's my honor to invite our colleague, Dr. Cheng-Chung from Xiamen Cardiovascular Hospital, Xiamen University, to present the PADN tips and tricks and troubleshooting. Go ahead, Cheng-Chung.
Thank you. It's my honor to be here to present the topic about the PADNs from theory to practice, tips, tricks, and troubleshooting. And thank you again, Zhenxin teams invite me. So as everyone knows, PH, pulmonary hypertension, is a malignant pulmonary vascular disease characterized by programs, evaluations of pulmonary resistant PVR and PAH. Its disease progress is now well controlled. Various evaluations lead to a right heart failure to death. The prevalence of PH is approximately 1%, which is now low and making it global health issues and demands attention and concern. Based on the issues logical cause, PH is generally classified into 5 major groups. Group 1 is pulmonary arterial hypertension. Group 2 is PH associated with left heart disease. Group 3 is PH associated with lung disease. Group 4 is PH associated with pulmonary arterial obstructions. All other causes are inferior captured as Group 5 PH. At the beginning, we were focused problems on Group 1 PH, just Professor Solantas mentioned about, so we don't repeat. And from the physiological perspective, RV, right ventricular pulmonary arterial component, RVPA component is a central factors in the pathogenesis and progress of PAH and serve as a characteristic prognosis indicators. Its dynamic trends persist throughout the disease course. Clinically, the gold standard for assess RVPH campaign involves invest right heart catheterizations to measure ventricular pressures and volumes during the cardiac cycles. Quantifies no-loss dependent ventricular contractility and outer load. And the ratio ES to EA reflects the RVPA comparison with a normal range of 1.5 to 2.0. In PH patients, these ranges reduce. Non-invasive measures such as echo and CMR can estimate comparing use the syringes like taps to PSP. In the early stage of the PH, these comparing mechanisms allows the right ventricle to the compensation for increased outer loads by enhanced cardiac output, preventing over-clinical symptoms. However, during disease progress as PVR and pressures remain persist in elevators, the RVPAs are unaccompanied at this stage. Right ventricular dilations trigger cascade of functions impairments and ultimately result in a right heart failures. Beyond compliance with right heart functions, the dilated right ventricles depress the interventricular supports the left walls during the discharge and impairs left ventricular filling and cause reduced ejections and functions deterioration. So pulmonary hypertension is driven by symptoms over actions increases the nodes internal innervings and metal nervings, leading primary arteries remodeling. The PADN dilated target list out as 6 months. The PADN CFDA trial shows 6 minutes was distance improves by more than 61 meters versus 18 with some. And anti-proBNPs fast almost 60% versus 25%. Pulmonary vessel resistant PVR drops 27% versus almost 15%. And critical worsen events 1.6% with PDN and 13.8% with SUN. So these data prove PADN significantly improve function, hemodynamic, and outcomes. So as an original technology for the treatment of the pulmonary hypertension, PADN has under more than 10 years research from the theories to animal experience and to clinical practice. In multi-centers RCT clinical trials, the total numbers of enrolled subjects is above more than 400. The finding of these studies has been published in top international journals with the research outcome PADN's respective size in 2022 ESC guideline. This recognition has followed facilities the technologies, researchers, and market approves in both China and Europe. It can be seen from the search popularity of the keywords on PubMed, and a large number of studies related to pulmonary arteries denervations have been published since 2013. This means that with the graduate mutation of the PADN, these technologies is being assessed by experts in the global fields. Moreover, PADN has gradually been included in various guidelines and experts' consensus for the treatment of the PH. Based on the result of the mentioned clinical pivotal studies, the PADN device has obtained the CE mark, FDA hold, and NMPA approved, and allows the PADN procedure to be performed in regular markets. So, and the PADN procedures are mainly divided into 3 steps: right heart catheterizations and pulmonary angina placement and fixations of the ablation catheter, and the implementations of the automatic ablations. The interventional access is usually from the left femoral veins, or sometimes from the right catheter vein. At the valley first, we should perform 2 consecutive non-selective pulmonary angina under certain gantry positions with LO20 and Cardio 20 and AP Cardio. The positions of the AP Cardio 20 will be the ablation positions. Sometimes the parameters of the high pressure systems are 3 millimeters of the value, 15 meters per second, and velocities of 600 precise of pressures. It is widely important that during outer pulmonary angio's, the surgical tables should, as well as the grandiose position, should be fixed and maintains fixation during the whole period of the PADN procedure. It's recommended to use a 6-flange PTL catheter for pulmonary angina, and it's recommended to use a 20 to 30 centimeter fields of view to center the main pulmonary arteries in the field. during the pulmonary angiography and the ablations, the operating table should be kept steady. And after the pulmonary angiography, theories, we will get flow scan images showing main right and left pulmonary arteries with clearly at the gantry positions of AP corridors. We may then venture at some important lines through indicators, anatomies, structures of the pulmonary arteries, as are shown in these images. Yellow lines and white lines indicates the lateral walls of the MPA and consider the finalist positions of the ablations. Catheter in the MPA, the white dash double head narrow is indicates the egress diameters of MPA, which is 10 millimeters distal to the upper range of the pulmonary valve. Measures the length of the MPA diameter to follow determines the size of the RF catheter. So before insert the ablation catheters into the body, we need to use the AP cordials pulmonary angiography to identify the ablation targets. As shown in the figures, the right slowly slides represents the lateral walls of the MPA. The green dot line represents the anterior walls of the LPA. The yellow dot line presents the posterior walls of the LPA. And the white lines, white outline, the contours of the tracheids and the left and right branch. The intersections of this line is ablation point A, which is most important ablation size. Ablation point B and C are 2 millimeters away from the point A, located on the posterior walls and anterior walls of the left pulmonary artery, respectively. So under the follow 260 centimeters drive valve, guidewise is positioned in the distal PA. The P-tail catheter and 6 flange sheaths are exchanged for either. A 6 flange long sheath also can very friendly use. The sheath is advanced over the guidewise with its T position at the LPA ostia. And after remove the dilators and guidewise, the sheath serves as the RF catheter delivery conduit. So advance the ablation catheter into the main pulmonary arteries through the previously placed vascular sheath. It should be noted to facilitate the selections of address the ablation catheter within the pulmonary artery. If the length of the MPA increase 15 millimeters, keep the tip of the sheath above the pulmonary valve. But otherwise, the tip of the vascular sheath, the tip of the sheath above the, but otherwise the tip of the vascular sheath needs to rest below the pulmonary veins. In addition, it's recommended to connect the monitors to the side arm of the vascular guide sheath to monitor the patient's hemodynamics during the address the ablation catheter. If the ablation catheter is very difficult to address into the position, we need attention should be paid to whether the sheath has been inserted too deeply. Finally, we need to make at least one of the electrodes at the tip of the ablation catheter as close as the positions to the previously identified ablation target A. So after we complete the placement of the RF catheter, we can connect the catheter to the RV generators and prepare to start the ablation. And this is some troubleshooting, procedure troubleshooting for PADN. And when just mentioned about we need to keep the bed don't move stables, and sometimes you will widely enlarge right heart and the heart trend positions, make it difficult for the shoes to be pensioned, and we can ask for the adjust curve shoes to application, and also we use a knife flange match shoes. And sometimes the class nodes did not align with the ablation size. Maybe we need to use AP Credios 20 floss to see or rotate the shoes gently, or for select new position to ablation. And sometimes happens, the power or the impedance will increase. Maybe it's the electric cabin. We can see sometimes this is black here is number 5 electric carbon coupling here, and this number 3 or number 4 electric loss combination. So we when it happen, we guess it happen, we need to remove the catheter, use a wipe gauze to remove the carbon tissues. And we also do some PADN case, and this year we published a very interesting case in Yohei journal. It's a one-stop PADN combined with tricuspid angioplasties for the treatment of a CPC-PH with severe tricuspid regulation. And this 64 years female, the patient has a persistence and AF and a history of previous use mitral TEER to reduce his MR, and he still feel very symptom after half years, and we can see we very severe tricuspid regulations, and we use we check we measures the right heart catheters. The mean the PSP is very high, more than 55, and based on the cranial trust, it is excludes cannot do the tricuspid angioplasty. So we do the PADN first. We check the pre the PADN. The mean PAP is 35. After that, other PADN, the mean PAP is reduced to 23, and the PCF reduced from 28 to 18. Then PVR still reduced from the 2.1 to 1.4. And then we can do the K-clip safety and use 2 clip from the lateral, from the anterior to septal, and 1 first clip, and the anterior to posterior leaflet. So the areas of the tricuspid valve from 20 now reduced 16. So we keep follow up. The PSP clears from echo shows from the 13 millimeter is spread to the 28, and the ejection improved from the 60% to 60. The patient's symptom is released. So finally, this my technical message. PADN is a minor invasive radio frequencies ablations procedures that reduce the simultaneous drive to the pulmonary vascular. And procedures is a standard use right heart catheter angios ablations position from A, B, C's position use the PhD 300 generator. And the PADN fills the gap between the expansions, lifelong drugs, and high-risk transplantation, offering durable interventional option for PH patients worldwide. Okay, thank you.
due to the time delay too much, the committee decided to withdraw the third topic, and we would direct progress to the discussion, and the discussion will be held by Professor Chen.
Thank you very much. So I think next time we need to invite the third speaker to come again and join us. So thank you, Dr. Cheng-Chung, for your wonderful presentation. So I think it's time for discussion. Yeah, any comments or question from panel? Go ahead.
Oh, okay, thank you. Thank you, Professor, for your nice talk, and always fully support our Sensing Life every year. Thank you again. And I have two questions for you. The first is, how heavily should the RV parameter like a PAPI or PVR factor into the patient selection of pulmonary denervation? And the second question is, based on your long-term trial data, which baseline hemodynamic parameters most reliably predict the non-responder? Thank you.
Wonderful for your two questions. So basically, from our PADN 5 trial, we only included patients with mean pulmonary pressure greater than 25, PAWP, PCWP greater than 15, PVR greater than 3. It's defined according to the previous last generation of guideline definition. So I have shown in my slides for China pivotal trial. So we included both patients with IPC or CPC PH. IPC PH means patient has normal PVR, but according to the new guideline, so the definition for pulmonary hypertension is mean pulmonary pressure greater than 20 mmHg. So this study will be presented at the ESC this year, and right now is under review in a top class journal. So secondly, for your second question, I think it's a very key point. So I also provided the analysis, interaction analysis to identify which parameters could predict the lung clinical outcome very confidently. So finally, I do find cardiac index by right heart catheterization greater than 2.0. Or TAPS, do you know TAPS? TAPS measured by cardiac echo greater than 13 mm. Both are very, very strong parameter. So that means for patient at very end of stage of heart failure, don't treat it.
Congratulations for your great achievement. I have a question, because the PADN also benefited for pulmonary vascular and the RA remodeling. So the mechanism is just like the pathophysiological benefit of the sotatercept, the newly FDA approved medication. So what's your opinion about the PADN for all groups of the pulmonary hypertension patient, or only PAH or group 2 left heart failure PH? Do you think group 3 is also beneficial?
Yeah, a wonderful point. From our previous trial, PADN 1 to PADN China pivotal trial, we only included patients with group 1, group 2, and group 4. But unfortunately, in our China pivotal trial, we only included 2 patients with group 3, because patient has very severe lung disease associated with a connective tissue disease. From our Chinese patient population, SLE is much more common connective tissue disease. Some of them have very severe lung function impairment. So 2 patients were included in one in the PADN group, another one in the control group. In control group patient died after 3 months from the randomization. So I think the next step, right now, I'm cooperating with more Chinese centers to identify if the PADN could be beneficial for patients with the group 3. Another point is that, I'm sorry, I spoke too much. Another China is so huge. For example, for people live in Xinjiang and Xizang, most of them have low oxygen, have the hypoxia-induced pulmonary hypertension. So one physician, Professor Wang from Cheng-Chung Medical University, brought the PADN device to Xinjiang to treat several patients with low hypoxia. I think it will be next frontier. It could be very rare in Taiwan, right?
I've got a question. I really enjoyed your talk, Professor Chen. I'm a surgeon, so I was wondering what good am I on this panel? But I would like to ask you one question. How quickly does this technology works? The reason I ask is that I can just see that this potentially can work externally if we're operating on a sick patient, left heart failure. After operation, they will have very stormy course, high inotrope level, right heart failure, and those are tricky patients to treat. If this can lower the PA pressure, help the right heart, it will potentially make our life a lot easier.
I think you share same point with Professor Cheng-Chung Cheng about the routine use of PADN during the cardiac surgery. During the surgery, open chest, right? I did cooperated with 2 surgeons in China. Jimmy, you are famous. I know you very much. So use our PADN cassette because it's an open cell, a distal ring design, very simple, very suitable for cardiac surgery. So we can open the catheter to surrounding the distal main trunk. So after 2 minutes, we only need to apply 2 minutes at each side. It's quite easy. So the learning curve, no learning curve for cardiac surgeon, but only 2 or 3 learning curves for IC. So immediate after the ablation, so the PAP reduced almost 70%. So because the result was too good, over good, I don't believe myself. So I think we need to learn more data. So it's my privilege to cooperate with all cardiac surgeons together. Thank you for your question.
Jimmy, I just asked Professor Chen, I was thinking when we're doing the open chest surgeries, we not using the RF, instead of taking the cryo probe, but just do the operations. I think maybe they have the same effect. Yeah.
Yeah, also, when Chinese cardiac surgeons, when they do the surgery for lung cancer, so because patients have very high PAP, so they use the PADN, I help them. And after the PADN procedure, they got autopsy. I mean, they got the specimen for the pathological study. Very, very significant improvement in remodeling. Jinggang, any question?
Nowadays, the combination targeted drug therapy is recommended to the PA. What is the role of the PNDA in this context? And in your previous trial, the trial was a single targeted drug combined with the PNDA. So what's your opinion?
Yeah, you mean background medication, right? Yeah. So actually, for PADN CFDA, it started from 2017. At that time, there was no any choice to prescribe, to provide a combination of medication for patients because of the cost. Secondly, for our PADN-5 trial as well as the China pivotal trial, we recommend very strict GDMT, guideline-derived medication therapy for patients with heart failure. Once again, no any pH-specific medication were approved for Group 2 pulmonary hypertension. But in terms of the GDMT, I think it's not very easy, particularly for our Asian people. We have small body. So most of the patients could not tolerate to maximum dosage of 3 or 4 combination of GDMT. Any comment, Cheng-Chung?
It's my honor here. I think PADN is widely friendly use as so many experienced casters PCI. I think only 3 or 5 case learning curve. We can handle the PADN.
Compared to the RDN and the PADN, which is simple? RDN, the renal.
So I don't have any experience about RDN, but I think the anatomy of the renal nervous, I think the anatomy is widely complicated compared with PA. So I think it's different.
Sorry.
for Professor Cheng-Chung, what are the most reliable intraoperative endpoints for successful pulmonary artery denervation? Do you think? What is the most reliable endpoint?
Yeah, I can answer. Yeah. I can answer. So, I defined the endpoint.
Yeah.
So,
yes.
Immediate after the procedure, either systolic or mean pulmonary arterial pressure reduction greater than 10%. Okay. Most of the patient with almost 20% to 30% reduction.
Yeah. Go ahead. The congenital heart field, and some patients have severe pulmonary hypertension and receive the total correction. Do you think in the same procedure, after complete the reconstruction of the heart, could we do the pulmonary artery denervation in the same time?
Thank you very much. I think I have multiple experience for patients with congenital heart disease. According to the guideline, so the congenital heart disease associated with the pulmonary arterial hypertension is defined as a small defect. It means the ASD diameter less than 20 or 10 millimeters for VSD with extreme high patient, extreme higher PVR. This is one. Second one, China is still developing country. Do you agree? So we have a larger population of patients with congenital heart disease. So we do include some patients in our clinical trial. After the commercialization of PADN in China, so many centers tried PADN for patients with congenital heart disease. I think we got very similar, very same result. Next point there, I'm not sure the currently in Taiwan, but in China we do have many patients with Hsin syndrome. So it's very tough. So we tried to do, I think so far, almost 20 to 25 cases. Very good results. One example is that because the baseline PVR greater than 14, no chance for intervention or for surgery. So after PADN, PVR decreased to around 5 to 6. It's a good point for repair.
Can you kindly tell us the roadmap for commercialization outside of China? CE mark trial, FDA trial, things like that?
Actually, I say PADN has been approved by DMR, by CE. So right now, I think outside the US, we can use PADN. Thank you.
Have delayed too much. We will close this section. Thank you.
Session A will start it right now. And this topic is advances in transcatheter and surgical valve therapy. And due to the time limitation, we will skip the first presentation.
Okay, good afternoon still. This is our last session, so advancing transcatheter and surgical valve therapy. And co-moderator is Professor Lin, and we have panelists, Professor So and Tu, and Professor Chen, and Professor Tsai, and Professor Lin. And I think first, we'll skip the first one. So we'll go to second, direct go to second speaker. Okay. So I think Professor Liu is online. And Lu, Professor Lu is online or the?
主任不好意思，因为陆主任他在刚刚下飞机，也可能来不及做报告，所以让我先替他做这个报告。
Okay. So 曹博士，我give a talk on the tricuspid valve replacement. So I just go ahead. Thank you.
好的，各位教授，大家下午好，我是来自上海市第一人民医院的曹静怡，然后替陆主任来做这一次的汇报。因为大会给的题目是3间半的置换，所以我们是想从合并有左心瓣膜疾病的同期干预来进行这一次的汇报。那多瓣膜病变在我们临床的这个工作中，其实会发现很多病人都是合并有2个甚至3个以上的瓣膜病变，在65岁以上的人群中，大约有30%的病人是有存在多瓣膜病变的。那3间半反流呢，很多时候是继发于我们的左心瓣膜病变。根据病因来看的话，其实最多见的可能就是风湿性的病因，第二常见的话就是继发性的病变。其中最常见的一个类型可能就是主动脉瓣的狭窄以及2间瓣的反流。那么和3间瓣相关的，其实不管是2间瓣的狭窄或者反流，以及主动脉瓣的狭窄和反流，都有可能引起3间瓣的反流。从这个左心瓣膜和3间瓣整个病程的发生发展来看，尤其是2间瓣和3间瓣的这个病变的关系，可能是更加深刻的。在我们早期一些患了2间瓣的患者中，随着整个病程的发展，2间瓣可能会存在一个相对的狭窄，那么这个时候就会出现一些3间瓣的反流，并且3间瓣反流的程度越深，患者预后可能是越差的。在我们临床上面来遇到了这些合并有左心瓣膜以及3间瓣反流的病人，在去对病人进行干预的时候，除了要去评估这个3间瓣反流的严重程度，还需要去评估3间瓣反流产生的病因是原发性或者是继发性，根据这些因素去综合评估这个患者是适合同期做3间瓣的置换或者是修复，或者是继续去观察它这个3间瓣反流的发生发展程度。在外科上来说的话，我们通常会采取肽成型或是比利卡成型，或者是用3间瓣的瓣环去做一个环缩，来减轻它的3间瓣反流。但是通过这个一些研究发现，在同时处理这个多个瓣膜的患者中，它整个并发症的发生率可能会比处理3个瓣膜的时候要高很多，往往在30%以上，甚至如果说同期处理3个瓣膜的话，它的并发症发生率可能会达到将近40%。那介入的这一项技术，因为其这个伤害比较小，并且手术时间也比较短，患者的恢复会比较快，所以在一些比较高危或者说是一些不适合做外科的患者中，可以去进行这样一项技术的开展。目前国内甚至说是国际上，其实也有一些中心去做这个同期或者是分期处理左心瓣膜以及3间瓣的一些研究。已经得到证明的是，同期去处理3间瓣的成型以及2间瓣的成型是比较安全的。但是在处理这些病人的过程中，我们可以看到，如果说术前病人的3间瓣反流比较重，那么随着这个3间瓣反流严重程度的进展，患者的预后可能是呈一个下降的趋势。那这个时候我们其实就要去考虑到，在什么时候对这些患者去进行干预，可能是对患者获益更多的。那我们考虑的主要是有几个危险的因素，一个是 三尖瓣反流的病因。那么房颤肯定是我们遇到的比较多的。另外一个呢，就是要考虑到患者的一个左心的功能。如果说是左心功能低于40%，左心摄血分数小于40%，那这个时候患者可能整体状况比较差，这个时候去干预的话，相对来说风险会比较高。再有一个是对于这个三尖瓣反流的严重程度，如果是在一个4+或是4+以上的一个评级的话，也是需要立刻去干预的。最后呢，就是这个三尖瓣瓣环的大小，也是需要去评估的一个指标。目前呢，也有一些这个文章开始总结，去处理左心瓣膜以及三尖瓣的一些原则。那在这些存在有三尖瓣反流以及主动脉瓣狭窄的病人中，我们可以遵循3部曲，在这个没有房颤以及右心功能尚可的病人中，其实可以优先去处理这个主动脉瓣的病变，也就是做一个 TAVI。在 TAVI 之后呢，去观察这个三尖瓣的进展程度。如果说三尖瓣反流有恶化，那这个时候就需要去干预三尖瓣。但是在一些主瓣干预之前就存在有刚刚讲过的这些危险因素的病人中，其实是推荐去同期干预这个三尖瓣和主动脉瓣的。那如果病人的一般情况还可以，那可以选择外科去进行一个主瓣的置换，或者主瓣的置换和三尖瓣的修复。但是如果说是一些高危高龄这个外科手术高危的患者，那就选择同期去进行一个 TAVR 和 TAVI 的治疗。同样的，在存在有二尖瓣反流和三尖瓣反流的患者中，也可以遵循这样一个3部曲。但这个时候呢，我们可能关注的更多的是一个患者的肺动脉压力情况，另外一个呢就是患者的三尖瓣病因的来源。如果说患者的肺动脉压力比较高的情况下，那我们还是倾向于优先去解决患者的二尖瓣的病变，在二尖瓣干预之后再去观察患者的三尖瓣的变化情况。但如果说这个病人的三尖瓣的病因是以房性为主的，那这个时候还是推荐同期去做一个二尖瓣和三尖瓣的干预。至于这个同期或者尖瓣和三尖瓣的优缺点，也有一些相应的总结，但其实因为现在这个经验可能还不是很多，主要的话还是要去综合的一个多学科的患者的评估，以及在更多的临床工作中积累的一些经验。那TAVI呢，其实是一项比较成熟的技术了，整个发展的过程可能有20多年了，所以因为生物瓣我们知道的它整个使用的寿命有限，所以在接下来的整个临床工作中，我们可能会更多的遇到一些TAVI瓣衰败的病人。那么在对这些病人去进行干预的时候，也就是做一个瓣中瓣的技术的时候，我们首先要考虑的就是他第一次植入的这个TAVI瓣的一个大小型号。另外的话就是整个患者的输入也好，主动脉瓣的结构也好，去做一个综合的评估，然后选择一个适合这个病人的这个瓣中瓣。二尖瓣来说呢，我们现在比较成熟的其实是TEER的技术。二尖瓣置换虽然说是已经有一些这个商品化的产品，但是它整个并发症的发生率还是比较高，所以像我们中心的话，其实现在还没有开展这个介入的二尖瓣置换，更多的还是做一个TEER夹子。那三尖瓣的话，主要就是三尖瓣置换以及三尖瓣的TEER技术。目前用的比较多的，在国外来说的话，可能就是 Evoke 和 Rooks。然后还有的话就是我们自己研发的一个 TAVR， 包括这个国际上的一个 tricuspid。从干预的顺序上来讲，大多数情况我们是选择这个从左心的主动脉瓣到二尖瓣，再到右心的三尖瓣。但是如果说这个病人的三尖瓣是以狭窄为主的话，其实这个时候可能是需要去评估一下患者的左心功能。如果说患者的左心功能还可以的话，是推荐优先去处理这个三尖瓣的病变。 那接下来的话，就是我们中心做的4个同期去干预左心瓣膜以及三尖瓣的 case。这个病人是一个72岁的女性，被诊断为三尖瓣反流合并有一个主动脉瓣的狭窄。既往呢，这个患者是有一个二尖瓣的置换病史。TAVI 的话，其实相对来说就比较成熟了嘛。然后通过评估的话，我们是选择了一个23号的 Venous A 瓣膜。但这个病人比较特殊的一个，就是因为这个患者左右的股动脉都偏细，所以这个病人我们是选择了一个左侧的颈动脉入路。三尖瓣来说的话，我们中心其实现在做的就是最多的就是 Lux 瓣膜，然后这个病人整体的结构其实还可以，主要需要关注的就是他之前放过一个起搏器，所以需要去评估一下我们做时间跟铆定的时候，这个起搏导线会不会有一个影响。那整个手术过程是比较顺利的，优先去植入了一个23号的 Venous A 瓣膜，然后再去干预我们的三尖瓣。第二个病人呢是一个76岁的女性，左臂有一个主动脉瓣的反流狭窄，以及三尖瓣的反流、三尖瓣的狭窄以及主动脉瓣的狭窄。那从 CT 上来看的话，这个病人的右心房其实已经扩大的非常厉害了。那这个病人之前是换过一个三尖瓣，之前是换过一个二尖瓣的。那 SGS 评分和 tricuspid 评分来说的话，都是一个手术高危的病人。主动脉瓣呢，我们是通过评估计划植入一个26号的 Venous A 瓣膜，通过左侧的股动脉入路。三尖瓣的话是计划植入一个3065的 Lux 瓣膜，这个型号的话相对来说瓣膜是偏大的，并且我们通过评估整个三尖瓣瓣环和我们时间隔的角度来到了110度。因为 Lux 的话它是有一个时间隔铆定的这样一个装置。那在我们评估的时候，其实是希望这个角度在80度到100度之间是相对来说比较安全，脱落的风险会比较低。但这个病人的话，这个角度就偏高一点，所以术中的话是需要去结合超声以及 DXA 去评估它整个结构以及瓣膜的稳定性的。那手术过程呢也是比较顺利的，优先去干预了主动脉瓣，最后去进行了一个三尖瓣的置换。那第三个病人呢是一个71岁的女性，合并有三尖瓣的狭窄、三尖瓣反流以及主动脉瓣的狭窄。那这个病人呢是之前换过一个三尖瓣的生物瓣，那这次呢其实是以狭窄为主的，也就是一个生物瓣的衰败。所以在三尖瓣的瓣中瓣应用中，其实和主动脉瓣也是比较类似的，需要去评估它第一次瓣膜的型号以及整个瓣膜的大小。那通过分析下来呢，我们是计划植入一个26号的 S3 瓣膜。主动脉瓣位呢是计划植入一个26号的 Venous A。那像这样一个病人的话，就像我前面说过的，因为他三尖瓣可能是狭窄更重，那一旦麻醉了之后，他整个心室数量可能就会下降，所以这个病人的左心功能其实还可以。那我们是优先去干预了他的三尖瓣，在三尖瓣植入一个瓣中瓣之后呢，再去做这样一个主动脉瓣的干预。第四个病人是一个74岁的女性，合并有三尖瓣反流以及主动脉瓣反流。那这个病人还有一个情况呢，就是肺动脉压力偏高，入院的肺动脉压力在54毫米汞柱，并且他入院前的这样一个心超报告其实是提示的轻度的主动脉瓣反流。但是入院之后，我们因为这个压力是偏高嘛，所以我们优先去用药物进行降肺动脉压力的治疗。但是在复查心超的时候，发现这个病人的主动脉瓣反流从轻度进到了中度，并且这个听诊的杂音也比较重，另外水冲脉也很明显，所以这个病人其实是 具备了2套方案，一个呢是我们术中优先去干预它的主动脉瓣，然后去评估它这个肺动脉压力的情况。如果说压力在一个安全的范围内，那我们再去干预三尖瓣。如果肺动脉压力还是偏高的话，我们就只干预它的主动脉瓣。那主动脉瓣呢，我们评估下来是适合一个27号的 beta flow 瓣膜，三尖瓣是一个3050的 look。那在干预完这个主动脉瓣之后，我们再去做一个右心的测压，可以看到这个时候的肺动脉压力是36毫米汞柱。那么在这个压力下去进行一个瓣膜的干预，就是相对来说比较安全的，所以也是顺利的植入了一个 lux 瓣膜。植入之后可以看到基本上没有这个反流以及瓣脱漏。那对于这些合并有左心瓣膜的三尖瓣病人来说，我们是去分期还是同期去进行一个瓣膜的干预？其实我觉得最主要的可能就是一个术中的稳定的水流动力学。如果说在干预一个瓣膜之后，这个水流动力学情况还是不是非常理想，或者说患者的情况还是比较重的，那我们可能会推荐这些病人去做一个分期的处理。另外的话，还有就是我刚刚提到的这个风险因素，如果说合并有这些风险因素的话，至少是2个以上的风险危险因素，那这个时候我们可能也是推荐同期去干预。另外的话，这些病人其实术前的一般状况都比较差，所以除了这个外科或者说是这个介入的这些医生的治疗之外，在患者术后的这个 ICU 的治疗或者说是微术期的治疗，其实也是比较重要的，对于患者的康复也有很大的影响。以上就是我汇报的全部内容，谢谢各位教授。
Thanks, Doctor, for your excellent review of the tricuspid replacement. Also, thanks for sharing all the interesting cases. And suppose we have a discussion after all the speaker, but since you're online, due to time situation, we just need only one question. And any question from panelists or any comments? One question.
曹医师，非常感谢你精彩的演讲。那我有一个问题想请教，因为我们做三尖瓣手术，在 severe TEER 上面，有时候病人的 outcome 都不是非常理想。那我想请教你在术前的话，你要怎么样去分辨这个病人他是 reversible 的 RV 的 remodeling， 或者是他是 irreversible 的 RV failure， 这样来决定你的治疗策略。谢谢。
其实我们对于三尖瓣的病人也是在积累一些治疗的经验。那就我来说的话，因为我接触的临床时间可能也不是很长，就可能2年左右的时间。但是从我接触到这些三尖瓣反流患者之后，如果是我接诊了一个这样的病人，首先我会自己去看一下他整个心超的情况。我们在临床中可以看到，这些如果存在有这个室间隔摆动的这些病人，其实他整个右心的功能是比较差的。那么你这个时候如果说去给他做一个 lux， 我们做的都是 lux 嘛，一个它整个瓣膜的稳定性可能会比较差，另外一个它术后这个右心功能会有一个走向一个更差的一个结果。另外的话，就像陆主任他提出了一个三尖瓣反流综合征，术前我们除了去评估患者的右心功能之外，还是要去更多的关注患者整个周围脏器的功能，尤其是他的肝功能和肾功能。如果说术前已经存在有肝肾功能不全的情况下，那你做这个 lux 之后，或者不是 lux， 做了三尖瓣的介入之后，你可能需要对他的肝肾功能去做一个额外的关注，而不仅仅是去关注他整个右心功能的情况。
Thanks, Dr. Zhao. Due to time, we have to move to next speaker. Thank you much for your excellent talk. I will have Dr. Lin introduce the next speaker.
Superintendent Wang and all the distinguished guests in this room. I'm Dr. Lin from Tri-Service General Hospital, and it's my great honor to co-chair this session with Professor Jeng. I would like to introduce our next speaker, Dr. Mi Chen.
Dr. Mi Chen is a physician scientist specialized in structural heart disease and cardiac surgery. He currently serves as the Deputy Director of Structural Heart Department at the Fuwai Yunnan Hospital and the co-PI in Beijing Fuwai Hospital. And especially she is now an associate editor of Jeng case reports. Today his topic is from CT to fluoroscopic insights from 7 cases of self-expanding valve. Dr. Chen, please.
Thank you so much for the kind introduction. Currently, I moved back to Switzerland most completely. And my name is Mi Chen. This topic I think is interesting. It's about valve. And I think now the patient came to us. And let's go to the case directly. So the first case is SAV in TAV. And this is 83-year-old male present us with the shortness of breath and Ying-Hwa function 4. And he has the SAVA and also the bypass in the 2013, and in 2020 he implanted first TAVI valve with the Evolut Pro 29. And in 2023 the patient came back with the shortness of breath. And the patient has the coronary disease and the kidney dysfunction, and also has the stroke and really high risk with the Euro score 33. Currently, he's under the warfarin treatment. And let's look at this echocardiography. Is aortic regurgitation, and the ejection fraction is quite low, it's 27%. So come to the first question. For the valve, maybe we need to put the third valve. So the first question, if it's a regurgitation problem, then you need diagnosis clearly, because the regurgitation could be transvalvular, also could be perivalvular. So it's easy. We just go to the short access, sometimes not so easy, and to see clearly. But you need to think in mind, it could be the perivalvular possibility. So we see this is only all the regurgitation is inside of the Evolut Pro. So this is easier. Otherwise, we will have totally different treatment. Then we check the coronary angiography, and because the patient has bypass before, is the Lima to LAD looks quite good, this pattern, and the Wang to the diagonal is also looks good. But however, the coronary obstruction is still a problem in this patient, because only the left anterior descending artery is partially protected by the bypass. So we come to the first quick questions. I think everyone maybe know this, the vivid classification from Gilbert-Tonville is that we need to evaluate the sinus concentration or the coronary obstruction risk. Basically, first we need to compare the coronary risk plan versus the neo-skirt plan. If our coronary is quite high, then usually you are very safe, you are in the gray zone. And if not like this, we still have a chance if we have big sinus and also the high STJ, then maybe you jumped into the yellow zone. And if both you have a low coronary cast, no coronary ostium, and small sinus, then you may in the red zone. Then let's do our CT planning here. So we know the left main is 8.8 millimeter, right coronary artery is 14.8, and the STJ height is okay, is 23.6. Then we looked at the 29 Evolut Pro. We know the external skirt, whatever you will have this new skirt, is start from the node 3. And you may have the external, the neo skirt is until the node 6, depending on how tall your neo valve. And the commutator height is 26 millimeter. So we just measured roughly. I think the co-valve is implanted around 2 millimeter below the annulus. So the potential, the highest potential neo skirt plan is 24 millimeter, which is above the STJ, also above the coronary plan, which should be the lowest one, is the left main 8.8. So this definitely is a high risk of the coronary obstruction in the type 3. Then we come to our planning. So question 1, which valve? We know there are 4 combinations, TOR in TOR, short in TOR in this case. So TOR if you put Evolut in Evolut, definitely has a high risk of the sinus sequestration, because you will have all the neo skirt of the evolute leaflet. So because for this case, we would choose the Sapien as our first choice. And Sapien in evolute, we need to notice that it will form a tube. And also then we need to continue to evaluate the valve to coronary and a valve to STJ. Then come to our question number 2, and which size. So normally for 29 evolute, we will go to the 26 Sapien, then we do the measurement, and this is also first, the annulus is only the 22 millimeter of the evolute. And if we put the 23 Sapien, we know the bigger Sapien has a higher frame that has a 20 millimeter. If we even have the under expansion, the height will be even higher. So here the V2C is okay, more than 5 millimeter, but V2 STJ is less than 3 millimeter, it's risky. But if we put a 23 Sapien, the frame height is only 18 millimeter. If we put the lower button to button, then the STJ is already above the Sapien, it's quite safe. So in this case, we would prefer to go to the 23 Sapien. And then we need to think about of the implant height, leaflet overhang. As we talked before, if we implant Sapien in evolute, we will form the tube, which means we don't have the waist. First means we have a higher near skirt, which how high we implant the Sapien, how higher the near skirt we will get. And also this tube means we will decrease the waist of evolute, means we increase the dimension of evolute to 0 to 2.5 millimeter as the test. And if we do a low implant, then we will have at node 4, we will have the 90% leaflet overhang, which means we will have maybe have the problems. So, but there is no in vitro data for the 23 Sapien in 29 evolute. We don't know. So this is the question 3. What's the height position? If we go higher, we have more risk for the coronary. We go lower, we have the leaflet overhang. How could we achieve the balance? Then we look at the data again, then we know even we put quite low in the node 4, I think the difference between the gradient is still acceptable. And we know the pathology of the evolute regurgitation, and from our experience, regurgitation is better than the stenosis with the leaflet overhang to cause the problem. So in this case, we will think the no coronary obstruction is much more important than the potential leaflet overhang. So we will choose the Sapien and with the 23 and which the height, and here don't forget we still have a surgical valve outside, which could mean become a really good umbrella. First, we cannot create more expansion. It means we have the fixed distance to the coronary. And we can place the height as the surgical valve. Then we already know, because it's a curved valve inside, we already know this is a different safe height. We don't create any new near skirt, and it's safe for our coronary arteries. So this is our first key question for the coronary risk. Then the second quick question is always the processes patient mismatch, especially when we decide to a 23 Sapien. Then we look at the patient, he's a 177 centimeters, 73 kilograms, he's a relatively big patient. And if we evaluate and predict the EOA is only the 0.74 is around moderate ppm. But from our practical experience, we know if the true diameter is 23 is usually enough for an old man, and 21 is enough for an older woman. So we will prepare. If it's high grade, then we will do the fracture. So when we plan everything, really the procedure becomes quite easier. We just choose a 23 Sapien and place the frame, upper frame to the upper frame, and do the implant. And there is no probable leak, and the mean gradient is 8 millimeter. It's a really straightforward procedure, only 10 cc contrast in total. So this is the really classical valve case. We always planning from the which valve, which size, and which height. Then let's go to the case 2. It's a bit different. This is freestyle, and the freestyle is interesting. When we look at the CT, we can look at the panel A. There is 2 annulus. The higher annulus is implanted with the freestyle and is higher, and the original annulus we can notice that it is lower. This is put in the 24 years ago. And then there is a TAVI Evolut Pro 29 in the 6 years ago. The patient has the regurgitation now again and show that is the shortness breath. So we will plant Sapien in this case, and what we show here clearly, because if we have a homograft or something like the freestyle, something, we usually have an elongated LVOT. And if you look at the CT, you will see this co-wall is quite low, but actually we think it's okay because it's respect the original native annulus rather than the homograph annulus and give us more chance for the coronary assessment. So in that case, we will put the CPN just the lower bottom to the lower bottom of the evolute, and we will, of course, we know we will have the good coronary flow. So this is the case is also, when we plan well, it's easy. We just put it lower bottom to the core valve. And let's go to the last case. It's a bit different in another scenario. It's a 56-year-old male show us with shortness breath. And the patient, 2014, has the SAVA magna is 25 millimeter. Then we put a Sapien 23 millimeter. In the 2015, also the patient has a parvalvular leak. Then we put a vascular plug in between the surgical valve and the annulus. And the patient has the drug abuse, so this may be the problem. He returned to us again with the really fragile status. So the patient has the aortic stenosis with the mean gradient 38, and the EF is okay, is the 67%. So in this case, we look at CT, you have a glimpse. The outside is a surgical valve, then is 23 Sapien. Then outside the Sapien is outside the SAVA is the vascular plug, and is enlarged left coronary sinus. But we look at it very clearly because then it has a big sinus, so the coronary looks quite safe if we don't implant a high valve. And we always want to have the pre-SAVA CT to let us understand more about the original anatomy. Then we measured it. Actually, this patient annulus has 24.2, and we have the chance. And currently, after the valve-in-valve, the Sapien is only 20 millimeter, and with also a plug inside. And then we are thinking about, because this is a really big patient, has 188 centimeter, 80 kilograms. And we think about how to choose the Sapien. If we choose the 23, then the patient may have the high gradient. This is a big challenge for the valve-in-valve case. Then we think about out of the box. Maybe we can try the 26 Sapien and fracture both 23 Sapien and SAVA. Actually, this is the first reported case that even the Sapien valve can be fractured. So into the procedure, we always recommend to rotate your C-arm because you don't want to cross your Y outside of the frame of the Sapien. And then we implant a 26 Sapien top to top to ensure the near skirt is the same. And then we do the post-fracture with the high pressure is the 24 millimeter true dilatation. And we implant the 26 Sapien, fracture both 23 Sapien and the SAVA with the 16 atmosphere. So we look at the CT. So from the before is 24.2 millimeter of the annulus, and this treatment is 20 millimeter only. Then after our implant 26 Sapien, we achieved the 23.2 is larger. And if we measure the bottom frame or the top frame, even it could be larger, and the mean gradient 6 millimeter. And also the parvalvular leak has been solved from the vascular plaque. So this is actually three quite interesting case because the first one is classical. It's like we plan this as a reduced TAVI. We have both the pen for the coronary obstruction and the pen for the gradient. Then what is different in valve? Then we know the pen of the coronary obstruction usually not such a big pen compared to reduced TAVI because we already have a TAVI first TAVI valve there. And surgical valve can be umbrella, and we also have some surgical, like elongated LVOT. But what makes us, we showed in the third case, makes us really, the pain is even bigger, it's the gradient. But now we understand even for the fracture, we can do it. Can do it with the SAPIEN, but I just want to mention when you decide balloon size, because you have lots of the valves inside, usually you have a 1 millimeter frame and 1 millimeter leaflet when you're planning to choose the true dilatation diameter. Thank you so much.
So any question from the panelists?
So Mi-Chen, very nice presentation, excellent cases. So I have a question. You are also a surgeon, right? So what is your point of view in expecting a valve procedure? So doing the index procedures in, for example, it's a surgery. So how would these kind of planning will affect your valve choice or performing boot enlargement, especially in Eastern population? Or what kind of surgical valve will you pick during the index procedure?
I think this is quite important, and we always have lots of the discussion of the small annulus what. And I think the first question, we still need to respect the patient wish. The wish is with the valve choice. Will you prefer mechanical valve? You don't need second intervention, but you take drugs, you have bleeding, you have stroke, or you want a biological valve, you use the 15 years, then you need a second treatment. I think this is compared to the SAVA or TAVA, because my feeling is the biological SAVA or the TAVA, I think maybe not so big difference, but still makes a big difference is biological versus the mechanical. We still need respect. I think this always put the first thinking in the heart in discussion. And then is we need to, like the last valve before you play first, we need a plan with the patient anatomy, whether we have according to the life expectancy, whether we have the reduced TAVI chance or re-reduced TAVI chance. And also I think important is whether, like, we are really experienced, the team with the bicuspid aortic valve, but we still think about if you want to know pacemaker and then you have long life expectancy, you don't want to paravalvular leak, and maybe the surgery still can achieve the best result compared to the balloon expandable valve.
Thanks, Dr. Chen, and for your excellent talk. Due to time, I think we have to move to the last speaker. And our last speaker is Dr. Pop, and he's from Alexander's Brothers Medical Center in Chicago. He's a co-founder of and also the head of structural heart disease, and also the CAS lab director. And he will give a talk on SAPIEN 3 Ultra real-world performance in the context of the PADN 3 long-term outcomes. Please go ahead.
Thank you for the kind introduction. It's a tough act to follow after Dr. Chen. Those were some very exciting cases. My lecture is a lot more boring. So this is kind of where we are with partner 2 and 3. So SAPIEN XT was followed by SAPIEN 3, SAPIEN 3 Ultra, and now we have SAPIEN 3 Ultra Resilia. We're not going to talk about SAPIEN X4 because God only knows when that's coming. But there were differences in the frame design between SAPIEN XT and SAPIEN 3. And then SAPIEN 3 Ultra brought a fluffy skirt, and Resilia obviously replaced the leaflets with different tissue. It's important to note the differences in frame between XT and S3. The XT frame is shorter. The top open cells are smaller, and additionally the leaflets are mounted at the top of the posts, whereas on the SAPIEN 3 the leaflets are mounted at the top of the commissural posts and not on the top of the frame. So you do actually at the top of the S3 you have a little bit of space for the neoskirt in case the coronaries are at risk. S3 versus S3 Ultra, same frame, better skirt. On the 29 in particular, the skirt is taller because there is no 29 S3 Ultra. There's only 29 S3 Ultra Resilia. So whenever you're looking at doing a 29 case, I always pull the Resilia valve because otherwise your skirt is going to be almost 3 millimeters shorter. So especially in very large anatomy, when you're trying to oversize, when you're trying to seal, the Resilia valve is nicer in the 29 because it adds the ultra skirt. Real world Resilia data. This is data from Yoshi Koneko's group in St. Louis, where they compared, really apples to apples. So they basically looked at surgical valves, Edwards surgical valves that had Resilia versus Edwards surgical valves that did not have Resilia. And there's a clear benefit with the Resilia tissue. So when Resilia first came, the Edwards people would come around and they would give you this whole spiel about, how they took the tissue, they put it in animal models, and calcification was different. And that's, to me, about the most boring thing under the sun. When I can't sleep at night, either I listen to that talk or I listen to the talk on the Bernoulli equation. But this is real world data, so this is actually meaningful because these are real surgical valves in real patients and it makes a difference. So this is, to me, the first real world data that talks about Resilia, and you can see at 8 years Resilia significantly outperformed the non-Resilia Carpentier-Edwards valves in freedom from reoperation due to SVD and SVD. So that's great. So now we have evidence that the Resilia actually helps with durability, which before was more or animal models. How about the real world implications, what we care about day to day beyond durability? So we have a bunch of data that shows that you get lower gradients, and initially the thinking was the lower gradients are related to the way the leaflets are mounted, because on the 20, on the 23, when Resilia tissue came along, they changed the way they mounted the leaflets. And as you can see in the picture at the top, there is a clear difference in how the valve opens. The valve opens a lot better. What's interesting, however, is that we have a bunch of other data that looked at Resilia, and that data shows that the gradients are lower even in valves that are not 20 and 23. Even at 26 and at 29, the Resilia valves seem to have lower gradients. And the leaflets are mounted exactly the same way, so it seems to be a Resilia factor. And it actually turns out, and this is not publicly reported data, that people don't go around talking about this, but actually the Resilia tissue, the Resilia valve leaflets are a little bit thinner than the original valve leaflets. So still bovine pericardium, but just a little bit thinner, which probably explains why the gradients are lower. Finally, gradients are great, and having lower gradients is good, but we know now we have pretty good evidence that gradients are not the same as durability. We know that TAVR valves have lower gradients than surgical valves in general. The lowest gradients for surgical valves are in some of the most hateful valves on the market. And we know the data from the trifecta that hemodynamics do not correlate with durability. How about low-risk data? I was asked to talk about that. So this is the two major studies, the Evolute Low Risk and the Partner 3, which started at the same time, completed at the same time, but now somehow they have about a 1-year difference in reporting, in follow-up. 7-year data for Partner 3 shows equivalent biological valve failure with the surgical arm. As we know, this is not true in the Evolute low-risk data where the curves have separated. The other important thing is in the Evolute data, Dr. Chen had at least 2 cases where the failure was primarily by aortic insufficiency, and that's certainly what we're seeing in the 29 and 31 and 34 valves. The bigger concern with failure via regurgitation is that it's very unpredictable. So about 50% of the patients fail acutely. and those are not pleasant cases to deal with. It's also not obvious that it's related to post-dilation because it's not, a lot of cases don't have post-dilation that deviates from the IFU. You know, we're not supposed to compare studies side by side, but this is a side-by-side comparison. Again, this slide I think has been shown before. We now actually have 10 years data for S3 from subgroup analysis in Partner 2. Again, in Partner 2, Sapien XT did not do as well as surgery, but at 10 years, Sapien 3 seems to do just as well as surgery. So I think that's pretty much all I had. Thank you very much.
Thank you. Thank you very much for the overview of the real-world performance and the Partner 3. So I think you have a few minutes, so we can have one comment or any questions from panelists? Any? No question. Okay, so the slides you presented, that's resilient. Is that the TAVI or the first slide you say the resilience is better than regular? Is that the surgical valve or this is?
So the first data that I showed was perimount valves without resilia versus perimount valves with resilia.
Surgical.
Surgical valves. So I think that's a fair comparison because it's essentially the same valve except different tissue on it. So I think that's good that we have 8 years data showing that side by side there is benefit from resilia.
So in the US now most use the resilia valve or still use S3 Ultra?
It's a cost factor. My healthcare system wants me to kind of ration the Sapien resilia valves to younger patients. I think we, you know, for TAV in TAV, we certainly do only resilia. Any situation where the valve is going to be underexpanded, if I put it in a trifecta, it's going to be a resilia. If the patient has high-risk features for early valve failure, such as end-stage renal disease, parathyroid issues, they get resilia. But, you know, if somebody is 92 years old, they probably get the regular valve.
So, I saw that in the States we'll use more like a resilient because in our hospital we already removed the ultras, S3 Ultra, all the resilient only. Okay.
So, Andrei Pop, is any data about the surplus technique? I mean, when you resection the prosthetic valve, then you put a new TAVR device within the surgical valve or transcatheter valve. So, for me, maybe the TAVR device is better designed than conventional surgical valve because the straw is thinner and the EOA will be bigger than conventional surgical valve. So to be a surgeon, we always think about the company should provide us a good device, better than conventional surgical valve. So if we can use the TAVR device into the conventional surgery, maybe the story will be different. Yeah. So is any follow-up about the surplus technique result?
So surplus is, there are people who absolutely love it. Keith Allen in St. Louis, who's a good friend, he's a very aggressive surplus operator. So just surplus, for the people who don't know, was described for self-expanding valves, and basically they make a small aortotomy. They go in, cut the leaflets off, mark the commissures, and then they implant a Sapien valve with commissural alignment under direct visualization. If you're doing it in a Sapien, you don't need fluoro. If you're doing it with Evolute, you actually need fluoro in the OR. Keith has also used it in other situations. He's used it in mechanical valves, where he'll put a Foley in the ventricle, pop the leaflets of the mechanical valve, clean it up, and then put a Sapien in there. It works really well. It's you know, you need a surgeon who's done it a few times and they know what they're doing. But it's a very promising technique for people who are where the high tall frame valve is well adhered to the structure and it's difficult to take it out.
Okay, thank you so much for your talk and all the discussion. So I think we have to conclude this last session.
Thank you for your perseverance. And now we have to conclude this meeting. I greater, would like to say that I appreciate your attendance. And this meeting, I think, is very successful because there are so many topics, and every topic is very interesting and stimulating. And I think in this era of the so-called transcatheter treatment of the valvular heart disease, there is still a continued evolution of the kind of these different kind of therapy. And I think in the next several years, we still have a lot of brainstorming and innovation. So I think that maybe in the future we have to change a little bit about the kind of presentation. We have to shorten the time of the presentation and focus on directly to the point instead of spending some time for the introduction or background or even guideline. Okay, except if you want to change the guideline. And okay. So just to reduce the timing of the introduction and directly focus on your point, and we have to remain a little bit more timing for discussion. So even the discussion is more important. So this is what I'm thinking about. The next meeting will be like this, and I think that in the past, in the future, several years, in the next several years, we still have a lot of achievement. Okay, so thank again for your meeting, to attending this meeting, and especially for our experts from different countries, far from the different countries. Thank you again. Thank you.
Thank you for staying for another couple of minutes, okay? I will give a long speech, sorry. I'm looking forward to hear in the future valve, no end. So hopefully 5 or 10 times. Now we're up to the 3 times. The next time I will hear probably 5 times or 6 times. So we'll see. And I only want to say thanks to all the participants for you really involved in this excellent meeting, and we have a really busy, very heavy schedule. So, but I learned a lot, so I enjoy it. And also I'd like to thank the local meeting organization committee for their really hardworking and countless hours they put in to generate this excellent the agenda and the meetings and program. And last, I'd like to thank to the staff member for working so hard, either in the here or the behind. We probably even don't know. There's so many people work so hard to make this meetings really, smooth and successful, and all the engagement. And I really appreciate for everybody's effort. Thanks again. Hopefully see you next year.